हेलो ज्वाइन कर लाइन पे हूँ दिख रही भी हेलो
Start now, sir.
हेलो
You are muted. Please unmute now, Dr. Rajesh.
This session includes lectures by famous personality of API. And first lecture is by famous rheumatologist of Hyderabad, Dr. Narsimlu. And that is an approach to spondyloarthritis. Second lecture is approach to unconscious patient by Dr. J. Paul, Kolkata. And third lecture is by Shyam Sundar, sir. That is drug-resistant malaria. Now I give my mic to moderator. Today's moderator of this session is Dr. Abhishek Kumar. Dr. Abhishek, are you hearing me?
Thank you, sir.
That is drug-resistant malaria. Now I give my mic to moderator. Today's moderator of this session is Dr. Abhishek Kumar.
Rajiv, I'll request you to those who are present and you coordinate with the people who are giving lecture. All three people, you coordinate. To take help of others. The best thing is, since you are there, so you are the best person to introduce and go ahead with the, unless you are very busy somewhere else.
Yeah, it's all right, sir. I have time, no problem, sir.
Yeah, you go ahead and do it. Because anyway, I'll be leaving after 15 minutes for the eco workshop.
Yeah.
So Rakesh has told me to be there at 2:15. We
Dr.
are meeting at 2:15.
Dr. Abhishek.
Good afternoon, sir. I welcome you all on behalf of organizing committee of BAPICON 2021. And now we are moving towards the first session of fall, in which, as told by Dr. Rajiv, sir, there are 3 lectures, one on spondyloarthritis. This is the first one lecture by Professor G. Narsimlu, sir. And to chair this session, we have 2 eminent persons, Dr. Ajay Kumar Sinha and Dr. Om Kumar, sir. Dr. Ajay Kumar Sinha is a known cardiologist of Bihar and India. And the first topic of ours is the approach to patient of spondyloarthritis, and that is done by none other than the known rheumatologist of India and abroad, Professor G. Narsimlu, sir. Professor Narsimlu, sir, is MD FICP. Sir was the past Dean of Indian College of Physicians, and we have received his hospitality in APICON 2016, that is 2016, in which he was the former chairman of the scientific committee, served as professor and HOD in NIMS, Hyderabad, and past president of Indian Rheumatological Association. Now I give mic to our chairman, Dr. Ajay Kumar Sinha sir, to please proceed with this session. And I request Dr. Simnu sir to please share the session, share the slides.
Great. Welcome you, sir.
Thank you, sir.
This is a great opportunity for us to listen to you on such a very important topic. And you know, this is a very common topic all of us face, whether you are a general physician or a specialist or a cardiologist. This, we keep on seeing such patients. And you know, often we give some analgesic and non-inflammatory, anti-inflammatory agent, that's all. And in our teaching program also, during MBBS or even MD, we were this particular, you know, arthropathy was he was occupying a back seat. So this is a great opportunity to be with you, Dr. Narasimlu. So over to you, sir.
Thank you, Dr. Ajay Sinha sir and Dr. Om Kumar. At the outset, I am immensely thankful to BR chapter of API. BR chapter API contributed immensely to API at national level, locally, and at personal level, I am very much thankful to my mentor, Dr. Bibi Thakur, and my friend, Dr. Kamlesh Tiwari. And today talk my approach of spondylorthopathy. Next slide. Now, the learning object of this title is to describe the known spectrum of spondylorthopathy. Next, to describe joint and extra-articular manifestation of spondylorthopathy and treatment of spondylorthopathy and the role of biologics. Next slide. Now, backache is a main symptom of spondylorthopathy. But backache is so common, 15% of the backache is inflammatory. The prevalence of backache is 0.1 to 1.1%, means an average 1% of the population will be having a backache at a given time. More common in the male, 1 in 5,000 to 1 in 10,000 only require surgical intervention. Means 99.99% of the backache require only medical treatment. Often unnecessarily they are referred for surgeons or neurosurgeons and unnecessarily MRI done. MRI requirement of backache is 1 in 5,000. Need MRI only for specific purposes to diagnose special diseases or surgery. Next slide, please. Now, backache two types. One is a mechanical backache, other is the inflammatory backache. What we see in mechanical backache most common, it can occur any age, variable onset, may be acute, may be chronic. Worsen with the movement and often improves with the rest. Next slide. Whereas, next slide, please. Next slide, please. Whereas inflammatory backache are common in the less than 40 years, is insidious onset, less likely to be acute, improves with exercise, unlike mechanical backache. It doesn't improve with the rest, it increases on rest. Early morning stiffness, 30 minutes, and disturbance sleep, especially during second half of the pain, second half of the sleep due to pain. Next slide. Now, red flag signs of backache. These causes of backache should be very alert. Whenever backache is associated with thoracic pain, whenever backache associated with unexplained weight loss and fever, recent bacterial infection, pain worse at the night or when supine, bladder bowel dysfunction, history of carcinoma, ill health or acute medical illness, IV drug users, people who are immunosuppressant, progressive neurological deficit, disturbed gait, sudden type of anesthesia, age of onset less than 20 years or more than 55 years, major trauma, minor trauma in elderly or due to in a setting of osteoporosis. These are the red flag signs of backache which need to be thoroughly investigated. These are the only situations where we require a CT scan or MRI. Next slide, please. Next slide, please. Now, ankylosing spondylosis, the most common spectrum of spondylorthopathies, where backache will be more than 3 months. The limitation lumbar spine movement, chest expansion decrease, bilateral grade 2 to 4 or unilateral grade 3 to 4, sacroiliitis will be there. Then we make a diagnosis of ankylosing spondylosis. This is old newer criteria. Next slide. Now, spondyloarthropathy is a misnomer. It thought to be a variant of rheumatoid arthritis in the past. Hence, we call it seronegative spondyloarthropathy. These are a group of inflammatory arthropathies that share a distinctive clinical, radiological, and genetic features. These diagnoses include ankylosing spondylosis, reactive arthritis, psoriatic arthritis, enteropathic arthritis. All will come under spondyloarthropathy. Next slide. Now, spondyloarthropathy, several criteria have been proposed. 1984 newer criteria has a low sensitivity. So, a lot of new criteria come. The key features to use for the classification of different groups are inflammatory axial arthritis like sacroiliitis or spondylitis. Peripheral arthritis, often asymmetric or oligoarticular. Enthesitis, inflammation of the tendon insertions. HLA-B20 positivity. X-ray evidence of erosions or hyperostosis, that is reactive bone. Extra-axial or extra-articular features. These are the features that are taken into consideration for various classification criteria. Next slide. Next slide. Now, spondyloarthropathy, European spondyloarthropathy study criteria was inflammatory spinal pain or synovitis, asymmetric predominant lower limb synovitis, plus any one of the following: alternate buttock pain, sacroiliitis, positive family history, psoriasis, inflammatory bowel disease, urethritis is sufficient to make a diagnosis of spondyloarthropathy. Next slide, which has sensitivity of 78 to 88%. Next slide, please. Next slide, please. Hello, sir. Somebody say, no. The spectrum of spondyloarthropathy, there are different types: juvenile chronic arthritis, ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and arthritis spondylitis associated with inflammatory bowel disease. These are a group of related disorders that share distinctive clinical, radiological, and genetic features. Sacroiliitis, spinal inflammation, peripheral arthritis, enthesitis, extra-articular manifestation, strong association with human HLA-B27. Spondyloarthritis can be divided into predominantly axial and predominantly peripheral arthritis. Next slide. Now, HLA-B27 is a class 1 molecule found in 8% of healthy white cachecans, but it is 90% seen in ankylosing spondylosis, 40 to 80% reactive arthritis, so also 70% juvenile arthritis, and 40 to 50% psoriatic arthritis, undefined arthritis 70%. HLA being one of the genetic marker to help us in making a diagnosis of spondyloarthropathy. Next slide. Now, spondyloarthropathy diagnosis is very important because the ankylosing spondylosis, unlike rheumatoid arthritis, the peak of onset is in young adults. Between age of 18 and 30 years, somebody will develop spondyloarthropathy. Whereas rheumatoid arthritis, the peak age of is 30 to 50 years. The age of age 17 to 30 years, very, very important, in somebody's educational career, job career, and marriage. In this age group, somebody becomes disabled, their personal life, their professional life gets significant impact. Economically active individual with a major impact on the ability to work will have significant impact. It has a suffering to whole life. So early diagnosis and treatment of ankylosing spondylosis very, very important because of this impact. Next slide. Next slide. Now, what are signs and symptoms of ankylosing spondylosis? Axial manifestation, chronic low back pain, with or without buttock pain. Inflammatory characteristics occur. What are the inflammatory characteristics? Occurs at night, sleep disturbances, early morning stiffness, limited lumbar motion, and onset of age less than 40 years. Next slide. Now, what are the structural changes? Because of inflammation, new bone formation takes place. Most striking feature of ankylosing spondylosis. Spinal syndesmophyte, you can see syndesmophyte in the photograph, and ankylosis, and both can be seen on conventional radiograph. Bamboo spine and bilateral sacroiliitic features of ankylosing spondylosis. These are the features of structural damage. We should not wait till the damage takes place. Next slide. Now you can see bilateral grade 2 sacroiliitis. The irregularity, sclerosis, widening of the joint. One side, narrowing of the joint, bilateral sacroiliitis, a feature of ankylosing spondylosis. Next slide. Now this is the bilateral grade 3 to grade 4 sacroiliitis. You can see narrowing of the joints, irregularity, one side, the ankylosis is taking place. So grade 4 sacroiliitis on left side, grade 3 sacroiliitis on the right side. Next slide. Now, CT scan picks up sacroiliitis much before X-ray. You can see the sclerosis and irregularity of the bilateral sacroiliitis, bilateral advanced sacroiliitis, condensations of ili can occur. Next slide. Now, the ossification vertebra from normal to ankylosis. How you can see is the normal vertebra. First, next is the squaring of the vertebra with ankylosis. First vertebra normal. Next erosion, we call Cheney corner sign. Next sclerosis occur. Next squaring occur. This is because the reversal reaction of the entire part of the vertebra. Then obviously dysmorphia develop. Then bony ankylosis and bridges will take place. Next slide. Now, what are signs and symptoms of ankylosing spondylosis? Peripheral arthritis, enthesitis. You can see inflammation, Achilles tendon insertion, the knee joint inflammation, dactylitis. They can occur in spondylorthopathies. Next slide. Now, the incidence of peripheral arthritis and polyarthritis occur in 12% of spondylorthopathy, nearly 38% due to oligoarticular, nearly 30% monoarticular, 22 to 24% of the spondylorthopathy, peripheral arthritis doesn't occur. Next slide. Next slide, please. Now, what are the extra skeletal manifestations? The constitutional features: anorexia, malaise, low grade fever, weight loss, fatigue. At this stage, we make a diagnosis, we can prevent structural damage. Next slide. Now, extraarticular manifestation, NTOVT is most common, inflammatory bowel disease, subclinical inflammation of the gut, cardiac abnormality like conduction disturbance, aortic insufficiency, psoriasis, renal abnormality like IgG nephropathy, then lung abnormality, airway disease, interstitial abnormality, emphysema, and bone abnormality, osteoporosis, osteopenia. So, ankylosing spondyloarthritis not only affects the skeletal system, it do have effect on the extraarticular organs. Next slide. Now, how the quality of life affected because of spondyloarthritis? Because of pain, presence of pain, there are sleep disturbances, there fatigue, loss of mobility, and dependency, loss of social life. And all these have effect on employability and higher rate of mortality. Stiffness is the most common cause of the quality of life. Next slide. Now, you can see over time, joints of the spine can fuse together and cause a fixed bone posture. See how the disease progresses, 1947, 57, nearly end of the 30 years, it becomes hangers to posture, totally not able to move his spine. This type of damage we have to prevent. Next slide. Now you can see patient of ankylosing spondylosis, hangers to posture, there is extension and forward flexion of the cervical spine, kyphosis, increased lumbar lordosis, flexion of the hip, flexion of the knees. Next slide. Now, the ankylosing spondylosis diagnosis getting delayed nearly 5 to 7 years in most of the. What is the reason? Because the 5 to 7 years is very, very important to prevention of the damage. Diagnosis suggests sometimes extra small manifestation, enthesitis, uveitis, and peripheral arthritis. Rarely late diagnosis with complications like spinal fusion, structure, cardiac syndrome, restricted lung abnormality, aortic insufficiency, they will propel us to make a diagnosis of ankylosing spondylosis. Next slide. Next slide. See if you see this graph, from first symptom to first diagnosis, it takes nearly 10 to 20 years. The 10 to 20 years is very, very important for autoimmune inflammation to suppress and prevent the damage. Next slide. Now, what are the reasons of late diagnosis? There are two reasons. Number one, low awareness of ankylosing spondylosis among non-rheumatologists. It can be seen as a major challenge for a physician in a primary care to think and identify the patient with inflammatory spine disease. Among the large group of patients with chronic back pain, most often of another origin. Lack of awareness among the physician and GPs are one of the main reasons. Next slide. Now, second, most of the time we are diagnosing ankylosing spondylosis based on 1984 New York modified criteria, where there was need for radiographic survey to diagnose a definite ankylosing spondylosis. And radiographic damage usually occurs of 10 to 20 years. Means because the criteria is not picking up early diagnosis, it's picking up only after the damage. We are missing early diagnosis. Next slide. Next slide. Now, the New York 1984 criteria, it is a old criteria defined much before biologics available. Sacroiliitis detectable X-ray occurs very late, nearly 10 to 15 years after MRI can detect it. And no MRI available in 1984, used only for clinical trials. But that was applicable in the clinical practice also, because of the some of the deficiencies in the classification criteria and lack of awareness among the clinicians. There was a delay in a diagnosis of ankylosing spondylosis or spondylorthopathy by 10 to 20 years, which was very, very vital period for prevention of the damage. Next slide. Now, see, if we see diagnosis standard for ankylosing spondylosis modified New York criteria 1984, if apply, it can diagnose only radiographic stage, means back pain with radiographic sacral cartilage, and or back pain with syndesmophytes. But the symptoms were there just 10 to 20 years before radiographic picking of the sacroiliitis. Next slide. See, the back pain, when was there 10 years back, MRI was showing a sacroiliitis, but radiographic changes will be normal at this time. This is called pre-radiographic of spondylorthopathy. To occur, any changes in a conventional X-ray to occur, it was taking 10 to 20 years. With the 10 to 20 years, very, very important for prevention of the damage, structural damage occurring in the vertebra and axial joints. Next slide. Now, spondyloarthritis and classification criteria, different criteria. Spondyloarthritis, axial peripheral joints, Amar and European spondyloarthritis criteria. Ankylosing spondylosis classification 2009, ankylosing spondylosis modified New York criteria, psoriatic arthritis, and peripheral arthritis. Now, 1984 criteria are the most popularly used by clinicians till now, but latest is ankylosing spondylosis assessment study classification criteria 2009, where it become very simple, and this has become more popular now. Next slide. Next slide. Now, ankylosing spondylosis assessment study group classification criteria ankylosing spondylosis, where we require sacroiliitis imaging. It could be X-ray, CT, MRI. Plus one of the features on imaging like active inflammation MRI or definite radiographic evidences, or HLA-B20 is positive, any of the two other clinical criteria like inflammatory back pain, arthritis, uveitis, dactylitis, psoriasis. So the sensitivity, specificity is significantly increased by this criteria. So we're able to make an early diagnosis of spondylorthopathy. Next slide. Now, increasing awareness among the non-rheumatologists. This is the NIH data. A decision criteria for early referral to rheumatology by orthopedic or general practitioner taken by NIH, where a chronic back pain, low back pain more than 3 months, and age of onset less than 45 years, and any of the 3 screening parameters like inflammatory back pain, positive HLA-B20, sacroiliitis, these patients were referred to rheumatologists. A total 350 patients. 149 patients with a definite axial spondyloarthritis, of which 43.3% had established ankylosing spondylosis. 49.7% had a pre-radiographic axial spondyloarthropathy. These are the cases were missed by orthopedician and general practitioners. When they were referred to rheumatology OP in Guy's hospital, they are shown already 50% are established, 49% pre-radiographic spondyloarthropathy. But these are the cases missed. So increasing awareness of spondyloarthropathy to the physician, orthopedicians, and GPs at grassroots peripheral level will help a lot to relieve the patient from suffering. Next slide. Now, comparing 2 referral strategies. One is referral strategy 1, where patient lead at least one of the 3 criteria. That is inflammatory back pain, women leukocyte antigen, and sacroiliitis and imaging. The second referral criteria, patient meets at least 2 of the following criteria. influent back pain, HLB27, sacroiliac, family history, good response, NSAID, external manufacturing. Both the criteria didn't show much difference. They have good sensitivity, specificity for making the early spondyloarthropathy diagnosis. Next slide. Now, how a patient of spondyloarthropathy coming to the rheumatologist, what you will do every 2 to 3 months, what you do, disease activity, disease damage. Disease activity is measured by BASDAI, where the parameter early morning stiffness, pain, fatigue, intensity is taken into account. Where the functionality, that is disability, bath enclosing spondyloarthropathy functional index, BASFI we call it, function anatomy, putting on the stocks and tied without help, and daily life. These two parameters are measured for assessing activity and disability, that is damage. Next slide. Next slide. Now, see the cutoff for disease activity less than BASFI, less than 1.3 disease inactive remission, whereas it is 1.3 to 2.1 moderate disease, 2.1 to 3.5 high disease, more than 3.5 high disease activity, where we need to intervene. Whereas to assessment of the efficacy of the drug, cutoff of improvement, it should be more than 1.1 clinically important improvement, more than 2 major improvement. So these are the outcome measures we use in a caring ankylosing spondyloarthropathy patients. Next slide. Now the flow chart. European recommendations of management of ankylosing spondylosis, NSAID, education, exercise, physical therapy, rehabilitation, association, self-help group, all require to all the patients, all the period of time. NSAID is effective both axial and peripheral arthritis. Sulfasalazine is effective only peripheral arthritis. Local steroids can be given both axial and peripheral arthritis, where TNF blockers are useful both axial and peripheral arthritis, and analgesics sometimes used. So last is the last option, surgery, where pain is intolerable, damage occurred, fusion of the spines will take place. Next slide. Next slide. Now, what are the drugs used in the treatment of spondyloarthropathy? Physiotherapy, NSAIDs, DMRD, corticosteroid, famotidine, biological response modifiers, and surgical management. Next slide. Next slide. Now, the recommendation for management of the treatment tailored according to the various features like current manifestation of disease, current symptoms, clinical findings, disease activity, pain, function, disability, structural damage, hip involvement, spinal deformity, and general clinical status. Next slide. Next slide. Now these are various NSAID used. Celecoxib and etracoxib found not only in NSAID effect, it also found disease modifying effect. Next slide. Next slide. Now see the continuous NSAID versus on-demand NSAID. It is found continuous NSAID it has a disease modifying effect. So in ankylosing spondyloarthropathy, we prefer going for continuous NSAIDs till the disease gets in remission. Next slide. Now corticosteroids, local injection of corticosteroids is definitely useful. The solomedrol pulse therapy 1000 milligram what you use in SLE not found statistically significant. But however, local corticosteroid injection definitely useful in spondyloarthropathy. Next slide. Now we can see the biologic infliximab. Before giving infliximab, we can see MRI, the inflammation. After infliximab, inflammation receding. It only shows infliximab has a very much significantly clinical effect if it's proved in MRI. Next slide. This is the radiograph of MRI of the sacral joints before etanercept, after etanercept. You can see sacroiliac inflammation total receding after 24 weeks treatment with etanercept. Next slide. Next slide. Now, infliximab, etanercept, adalimumab, all three are effective. Adalimumab is given 40 milligrams every 15 days. Etanercept every week. Infliximab regime of 0, 15, 1 month, and 6 weeks, and afterwards every 2 months. Next slide. Now, 2010 update ankylosing spondylosis EULAR recommendation management ankylosing spondylosis are non-pharmacological treatment, continuous education, physiotherapy, NSAIDs, local corticosteroid, DMRD, anti-TNF therapy, and IL-6 is not effective in the treatment ankylosing spondylosis. There have been data has come. Next slide. Next slide. Now, these are various biologics are found useful in the treatment of spondyloarthropathy. Golimumab available, tocilizumab available, serilimumab available, seculimumab available now in India. This icrizumab still not available. Apremard available, used for psoriatic arthritis. Tofacitinib found not useful. The baricitinib phase 2 trials are going on till we have to get the data. Next slide. Now, take home message of this my spondyloarthritis. Prevalence of inflammatory back pain very high according to 3 different criteria sets. European spondyloarthritis criteria most sensitive, followed by Amor criteria and Berlin criteria. Modified Newer criteria for ankylosing spondylitis most specific, and MRI B20 do contribute but limited. Early diagnosed spondyloarthropathy make a forward for initiation effective treatment and diminish the burden of the disease. Berlin proposed algorithm for axial spondyloarthropathy may be useful in patient. Physician will take care of the backache and refer to orthopedism only when surgery required, like a disc collapse with neurological deficit. Routinely, MRI should not be done in all cases of backache. This is my take-home message. Thank you, sir.
So, thank you, Professor Narasimlu, for your masterly lecture on this inflammatory back pain syndrome. And I think among audience, a lot of great physicians are there, and they must be having some comments and some questions from Dr. Narasimlu. So I invite questions from the audience. Dr. P.K. Sinha, Dr. Shailendra Kumar.
No, thank you. Thank you. It is such a nice detailing of the topic. So it made us, all of us, intelligent enough to deal with this ankylosing spondylitis and the spondyloarthritis. Thank you very much for such a nice lecture.
Thank you, sir, for nice presentation. But in short, what message you would like to give to differentiate between mechanical and this and AS? How we can differentiate clinically? Tell me few words in short. Mechanical pain, because that pain is most common, I think. Mechanical back pain. So how we can differentiate apart from onset from it's from mechanical pain, ankylosing spondylitis.
So my second slide has shown this mechanical backache, inflammatory backache. Mechanical backache can occur at any age. It gets relieved on rest. It increases on exercise. It is more in the daytime than night. Whereas inflammatory backache is a feature of ankylosing spondylosis. It occurs in the age group of less than 40. Increases on rest, decreases on activity. More in the night, especially second part of sleep get disturbed. Apart from this, when you examine the patient, you see local tendinous sacroiliac arthritis, limitation of chest movements, limitation of spine movements, and Patrick test. We extension, abduction, external rotation of hip, and press one hand on the knee, one hand on the opposite sacroiliac. Press it, they get pain in the buttocks. These features of sacroiliac arthritis. So this history and clinical features of sacroiliac arthritis and decreased movements, you almost 99% you make a diagnosis of spondyloarthropathy, ankylosing spondylosis. X-ray only we require for confirmation. And HLB-21 to classify criteria, because one clinician to other clinician, one center to other center, the variability is as minimum as possible. Most of the time, after the end of the clinical history and examination, we make a diagnosis of spondyloarthropathy. X-ray is only to confirm, not more than that. And most of the investigations are safety investigation like LFT, creatinine, GOT, blood count. Before starting a DMR biologic, hemoglobin should be more than 9, total count should be more than 4,000, platelet count more than 1 lakh. These are the parameters. Safety investigation do. Confirmation only MRI or X-ray or HLB-27. It aids you in the clinical diagnosis.
Sir, how is the response of latest drug you have shown in your slide in this AS?
Sir, again, if you suppose only peripheral arthritis is there, sulfasalazine is effective. If it is a axial joint involvement, sulfasalazine symptomatic improvement occurs, but structural damage will not get prevented. But NSAID definitely yes. physical exercise means spinal exercise, definitely yes. And we're not responding. The any biologics or infliximab, etanercept, adalimumab, exemptia, adalimumab, and golimumab, they're all equally effective. Sir. Anyone you can use. Ultimately, what you see, which is the cheapest? Golimumab is only very costly as of now. Adalimumab is costly. Now, Indian pharma people have come up with generic type. It become very cheap.
Thank you, sir.
Thank you, sir.
Sir, you are muted. Sir.
One question in the chat box, that what is the role of JAK inhibitors in ankylosing spondylitis?
Sir, tofacitinib is showing a variable results. Paracetamol data yet to come. So JAK inhibitor as of now not approved by FDA in the treatment of spondylothopathia. However, peripheral arthritis is found useful.
So, since there is no question,
Sir, just
Dr. Abhishek.
One comment from my side.
Yeah.
Dr. Nasimlu sir is a very good teacher, very knowledgeable person, a very good orator. And I have heard him in inaugural function of BAPICON, Hyderabad BAPICON, and he gave a lecture on teachers and importance of teachers. I was touched upon the words of Dr. Nasimlu sir. I always remember what is the importance of teacher in our life. And this shows that sir is so much warmth and respect at heart. This is the quality of him one must know.
Thank you, sir. Thank you.
Thank you, Dr. Abhishek, for acknowledging the greatness of your teacher. So with this, we come to the end of the first lecture. And as I have informed by the organizer, probably second speaker is not available. Dr. Jyotirmay Paul.
Yeah.
Dr. Abhishek, whether is available for second lecture?
Sir, some technical glitch is there. So Dr. Shyam Sundar sir is present, and request you to proceed with sir.
Yeah. So we can proceed to the third lecture of today, which will be delivered by none other than Professor Shyam Sundar. And I cannot dare to introduce Dr. Shyam Sundar. I can only pay regards to him. And he was my teacher during my MBBS and MD days. And he is such a great person in the field of nephrology. And presently, he is a distinguished professor in the Department of Medicine, IMS BHU. He is president-elect of API. I just searched about his contribution in medicine. He has got around 1,000 research articles and more than 30,000 citation of his articles. So we can imagine the greatness of sir. And I am quite humbled to introduce, or rather pay respect to Dr. Shyam Sundar. And he will be speaking on a very important topic, or very relevant topic of treating malaria, resistant malaria. Sir, Professor Shyam Sundar, sir.
Thank you. Thank you, Om. And really reminds me of my olden days. So thank you for all that adjective that you have given. Anyway, so should I share my slide?
Yes, sir.
It is not coming. Let me see. नहीं हो रहा
शेयर नहीं हो रहा Zoom पे Zoom पे तो यही शेयर कर जाता है
Abhishek, can we help?
Backend team, please allow participants to share. Backend team.
Allowed, sir. We allow. Please repeat share. दोबारा एक बार शेयर करके एक बार चेक कर लें. Hello.
The host can share the slides.
Yeah.
Sam Sunali, don't need slides. You don't need.
Actually, slides are needed, but anyway, what can be done? Can I email the slides?
Yeah. Sir, you can email. We will share your slide.
You have. Should I email you?
Yeah, no problem, sir.
What address?
I am sending my Gmail address.
Shamsundar, how are you?
Oh, fine. Thank you, Dr. Narasimhulu.
Nice to see you.
Thank you.
But you lost some weight.
Yeah. Little bit.
And Tiwari sahab, namaste.
Sir, you can, with due regard, you can open the PowerPoint slide and then minimize it, and
Yeah,
then
that's
try
what I have
sharing.
done.
And then try sharing.
I have done that only. I opened the PowerPoint, but somehow.
And minimize it.
Sir, click on Zoom share screen and select basic tab and click on your PPT and share. Yeah, only click on screen and share button.
What did you say?
Click on share screen button.
Share screen button, yeah.
Click on your share button. Second share button, click.
Share button. It says I have a green screen, okay. Karke.
No, you're not in screen.
ये खुली हुई है.
हाँ खुली हुई नहीं मानते.
तो मुझे मेल कर दीजिए, मैंने ईमेल आईडी भेजा है आपको.
I think backup team can share the slides if slides are available.
एक बार आप दोबारा चेक करिए सर. मैंने एक बार और.
एक मिनट. You send the email at which address?
Yeah, I have sent, sir, on your WhatsApp. See.
WhatsApp.
Yeah.
Okay, so should I?
You can send this, no problem. I will share to him.
Okay, sorry for the delay.
It's all right, sir. No.
All right.
आपके शेयर स्क्रीन का कलर ग्रीन है कि नहीं सर?
नहीं, ग्रीन नहीं है.
इट मींस यू आर नॉट अलाउड टू शेयर. ग्रीन नहीं है इसका मतलब कि आपको शेयर के लिए जो वहां से अलाउ किया गया है दैट इज नॉट एक्टिवेटेड टू योर स्क्रीन. तो आप फिर से अगर लॉग आउट करके लॉग इन कीजिए तो प्रॉब्लम सॉल्व हो जाएगा सर.
ओके, लॉग आउट करते हैं.
जी, फिर से लॉग इन कीजिए, देन प्रॉब्लम विल बी सॉल्व.
आज क्यों टेक्निकल प्रॉब्लम आ रहा है? सब लोग रिलैक्सिंग मोड में है.
जस्ट अ मिनट.
कोई टेक्निकल प्रॉब्लम नहीं होता है अक्सर. फिर से लॉग आउट करके लॉग इन करेंगे तो प्रॉब्लम विल बी सॉल्व.
पॉसिबली डेलीगेट लॉगिन से सर लॉगिन किया है स्पीकर के बदले.
सबके लिए सेम है.
So what about the other speaker, Jyotirmay Paul? Is he not?
Sir, no response came.
Oh,
I'm there. I'm there.
Dr. Jyotirmay Paul is here?
No. सुबह अर्ली है वो गड़बड़ा गया
नहीं, कुछ नहीं गड़बड़ाया, अरे इतना होता है।
ठीक है, वो मेल पे आ जाएगा तो इट कैन बी शेयर्ड, इट्स नॉट अ प्रॉब्लम।
I mailed it to you as a WhatsApp too.
Yeah. इसमें दौड़ के जाओ वहां पे ये लोड कराओ हॉले में लोड कर हैं
अजीब जी, आप अपने लैपटॉप पे भी कर दे सकते हैं।
जी सर, मुझे भेज दीजिए।
Hello.
Sometimes there is a problem with this. I don't know what is.
I think by the time slide is being shared, Professor Shyam Sundar can start his talk.
Yeah. Good afternoon, everybody. I'm going to speak on malaria, and the incidence of malaria actually has gone down. And today, if you compare 2001 to 2019, only 16% cases are there now compared to 2001. So it is on decline. Even falciparum has also declined from 1 million to 0.15 lakh. Number of deaths have decreased from 1,700 to just 50 in 2019. And now National Framework for Malaria Elimination has set a goal to 2030 for elimination. Now, drug-resistant malaria threatens because of the increasing anti-malarial drug resistance, and effective anti-malarial treatment, malaria control and elimination all are hampered if we do not have adequate tools to combat this disease.
Hello, sir. Wait, because PPT is received. May I have a play of that one?
Thank you. Thank you. Next. This is the Anopheles mosquito, which is responsible for transmission of malaria. Nowadays, of course, it's dengue, more dengue than malaria, but still, I mean, this is the this is the mosquito. Next. And here I just told you that the incidence of malaria has gone down from nearly to 20 million. Just a minute. Next, please. So it has gone down from 2.08 million to 0.33 million during 2001 to 2019. Similarly, malaria cases have declined as far as falciparum is concerned from 1 million to 0.15, so almost 7 times less. And number of deaths are just 50 now. And as I said, that the National Framework for Malaria Elimination has set a goal for 2030 for elimination. So it is very important that we discuss and see how to combat malaria effectively to achieve its elimination. Next. Now, increasing anti-malarial drugs resistance threatens the effective anti-malarial drug treatment, because if there are no effective drugs, the treatment cannot be successful. Thereby malaria control and the elimination, which is set for 2030. In falciparum is the mainly responsible for severe malaria. In falciparum, resistant to chloroquine was noted in 1973, almost 50 years ago in Assam. And then, of course, all over the country. And we lost a very cheap and popular drug. Earlier, when we were students, anti-malarial meant that we give chloroquine 25 milligram per kilo in 3 days. So that was the practice. But now I don't think I have written chloroquine for several years. This was not only chloroquine, then resistance to sulfadoxine pyrimethamine followed. And it was more in northeastern states. And now it's all over the country. Next, please. Now, what are the facilitating factors for emergence of drug resistance? Poor quality of anti-malarial drugs. In our country, we can have very good companies making good drugs, but there are many companies which will make spurious drugs or drugs with less amount of drug, or incomplete treatment courses. We don't give for the duration it is required. And you will see that many people give 1 day, 2 day like that, and if the patient is afebrile, they stop it. Then monotherapy was prevalent, quite prevalent when we were students, and even till few years back. And this led to resistance to development of drug-resistant mutants, and due to subtherapeutic drug level, because if the drug levels are low, it promotes resistance in the parasite. Next, please. Drug resistance arises when the mutants are selected by anti-malarial drug concentration, which provide differential inhibition. What I mean to say that the drugs they try to reduce the susceptible parasite population, but they have no or very little effect on the multiplication of mutants. So these mutants or these drug-resistant parasite, they increase in the number as compared to the sensitive ones which are eliminated. Next. Now, just for example, atowacone resistance is what mutations are there in antimalarial drugs? Atowacone resistance is associated with a single point mutation in the cytochrome B gene of Plasmodium falciparum, which confers 1,000-fold reduction in the sensitivity to the drug. 1,000-fold. Artemisinin derivatives are particularly suitable for combination partners because they are very active antimalarials, producing 10,000-fold reduction in the biomass of the parasite per sexual cycle. And thereby they reduce the malaria transmissibility. And resistance to artemisinin was actually not heard few years ago, but about 10 years ago, it was reported from Cambodia and now from some other areas also, especially Mekong countries. Next, please. Now, what are the mutations? Plasmodium falciparum multi-drug resistant protein, which is in short also called as PFMDR1. It is located on chromosome 5. It encodes an ABC transporter, and it is located in the membrane of the food vacuole. It is involved in the modulation of the susceptibility to several antimalarial drugs with mutations in the gene encoding this protein. So resistant mechanisms are associated with increased copy number of this particular protein, PFMDR1, leading to an increase in the expression of the protein, and which results in resistance to mefloquine, lumefantrine, quinine, and now artemisinins also. Next. Now, that was the MDR, and this is the chloroquine resistant transporter, PFCRT, Plasmodium falciparum chloroquine resistant transporter, and it has potential role in chloroquine resistance and other drugs also, and its phenotype. It is localized on chromosome 7 of the parasite. It belongs to the drug metabolite transporter family, so it actually transports the drug in and out of the cell. And there is a resistance to quinine, amodiaquine, pipraquine, and lumefantrine if the PFCRT level goes up. So there is a cross resistance between chloroquine, amodiaquine, and quinine. So again, this mutation is also responsible for resistance to these drugs, and amodiaquine was earlier indicated in even drug-resistant cases. Next one, please. Now, antimalarial drugs will be more prone to resistance when there is a genetic events conferring a considerable level of resistance, such as atowacone or mefloquine. These drugs, who have a long terminal half-life, what they do, that they remain in the system for several weeks, and the drug levels, as it becomes low and low, the parasites which are present, they start tolerating the drug, and slowly they develop the resistance. So it is important that we don't use drugs with long terminal half-life alone. Once resistance starts emerging, transmission and spread is facilitated by production of gametocytes in partially resistant strains. That means that the gametocytes found by the partially resistant strains, they increase in the transmission and spread of the resistance. Next, please. Now, Southeast Asia, including India, in the last decade has been the cradle. So actually it is proponent of emergence of Plasmodium falciparum. And Plasmodium falciparum resistance occurred, was noted in 1963, 1980 to sulfadoxine pyrimethamine, 1982 to mefloquine. Mefloquine was a very popular drug for short period. Artemisinin, 2008, only in a selected area, not everywhere. Then pipraquine, started in 2013. So a ban, if you go to market now, you cannot get artemisinin drugs alone because it is now banned to be used as monotherapy. So it is not available also. That's a very good step because the fixed dose combination are the drugs for the day, and it has been a very important step taken to apply. Next, please. Next. Yeah. So toward the end of the last century, introduction of artemisinin combination therapies provided a much needed and highly efficacious anti-malarial treatment. So combine the two drugs with two different mechanisms of action, and they become effective against all strains of malaria. Artemisinin resistance and concomitant resistance to ACT partner drug resulted in high late treatment failure rates with dihydroartemisinin, pipraquine in Cambodia, and artemisonate and mefloquine in Thai-Myanmar border. I'll show you a map. Next one, please. It was first reported in Cambodia, as I told you, and now in other countries in the Mekong region. That includes Vietnam, Myanmar, Cambodia, and Thailand. These are the countries. It threatens the substantial progress, as I already told you, that if resistance is not tackled properly, the malaria elimination will not occur. And resistance to artemisinin occurs in a very popular now KELCH13 gene, where there is a mutation of the propeller domain. I don't think we should go into that. And it is the major determinant of resistance to artemisinin derivative. Mutation in C-terminal region of K13 protein in this region is associated with artemisinin resistance. Next. So this is a slide taken from the NEJM where they have reported resistance to artemisinin, and you can see the green color or bluish green color. It indicates that the clearance of the parasite is in less than 5 hours, and the red ones, it shows that the clearance takes more than 5 hours, and of course there is no dark colored, black colored this thing in this map. So you can see here that in Thailand and Cambodia, you see the majority of the parasite. You can see these circles. Majority of the parasites are resistant. Some resistance occur in other countries also, and like here in Laos, in of course Cambodia, I told you, and Myanmar. Myanmar is another place, and Thai-Myanmar border. This is Thai-Myanmar border, and Myanmar, where there is a presence of resistance. The study had included one center in India also, but unfortunately, no reports from that is available because probably they did not enroll any patient. Next one, please. This is the slide showing the resistance of combination artemether-lumefantrine resistance. I will come to that later on, where you can see that the light pink areas have more than less than 5% resistance, and the red ones had more 10 to 20% resistance, and very dark one has more than 20%. But in India, you can see it is mostly the light, so less than 5% resistance is there in India to this combination. Because we should know now, this is the most popular drug that is being used in our country at the moment as anti-malarial. Next, please. Now, after falciparum malaria, the Vivax malaria, is there a drug resistance in Vivax malaria also? Yes, it is there. And Plasmodium vivax resistance to anti-malaria drugs is prevalent worldwide. It is also associated with molecular markers of drug resistance, which I come back to later. And then there is point mutation in Plasmodium vivax dihydrofolate reductase gene has been linked to with pyrimethamine resistance and treatment failure in Plasmodium vivax. The drug resistance genetic markers contribute, and of course, they determine the emergence and spread of resistance in Plasmodium vivax, as was the case in Plasmodium falciparum. Next, please. So in chloroquine resistance also, there is a Plasmodium vivax multi-drug resistance transporter protein, which is quite orthologous or similar to PFMD, Plasmodium falciparum MDR, and Plasmodium falciparum CRT genes. And they have been identified as chloroquine resistant markers in Plasmodium vivax. Pathogenic consequences of endothelial activation and sequestration of parasite herbicides are much less. So severe malaria, the incidence of severe malaria is much less or uncommon with vivax malaria, but it does occur. It is not that it doesn't occur. Next one, please. Next. So what combination should be used? It should only be used in at least 2 drugs, and this should be 2 effective. Both the main drug and the partner drug. They should all be very effective, otherwise it becomes a monotherapy, and which has no role in management of severe malaria. So Plasmodium falciparum malaria should be treated with either combination of artemether and lumefantrine, very common in our country now, artemisonate with amodiaquine, artesunate with mefloquine, dihydroartemisinin with piperacquine, and artesunate with sulfadoxine pyrimethamine. Next. Next, please. So national program recommends artesunate plus SP as the ACT of choice. ACT is artemisinin combination treatment of choice for treating falciparum malaria all across India except northeastern states. But I have my own reservations, because we know that SP or sulfadoxypyrimethamine combination is not a very effective drug as far as malaria is concerned. So I don't think this combination, I mean, it's my very personal opinion, should be used. The total recommended dose is that 4 milligram per kilo once daily for 3 days, or it can be used in also twice daily also with 2 milligram per kilo. And then there is a single administration of sulfadoxine pyrimethamine on day 1. The combination is sufficiently efficacious only, mark this point, only where a 28-day cure rates with sulfadoxine pyrimethamine alone exceeds 80%. So the efficacy of this SP or sulfadoxine pyrimethamine should be more than 80%, then only the combination should be used. Next one, please. Now, what is the algorithm for treatment of severe malaria? One is the speed of treatment is very important. More rapid you start antimalarials, it is life-saving. If you delay this patient, we may lose this patient. So we give the drug of choice is parenteral artemisinin. If it is available, artesunate 2.4 milligram at 0, 12, 24, and 48 hours. This was from the famous Sycamore trial. Or if artesunate injectable is not available, artemether intramuscular 3.2 milligram per kilo loading dose, and then 1.6 milligram per kilo OD. And then primaquine should be added to kill the gametocytes so that the transmission is brought down. If it is not available, artemisinins are not available, then quinine salt can be used, 20 milligram per kilo and loading dose, and then 10 milligram per kilo 8 hourly. And it should be combined as soon as possible. It should be combined with doxycycline or tetracycline or clindamycin. Of course, or terramycin cannot be, tetracycline cannot be used in pregnancy and children of less than 8 years because of the various adverse events that you already know. Next one, please. So what is the global deployment of artemisinin combination therapy? What ACT is used? You see, artemether-lumefantrine is the most popular one. It is used in Africa, Southeast Asia and India, Brazil and Venezuela. The failure rate is less than 13%, 8% to 13%. But it is not in Southeast Asia, in Cambodia it is not used. Then artesunate combined with amodiaquine in Africa, Vietnam and Indonesia. The failure rate is more than 10%. So it used in countries where the failure rate is less than 10%. Then artesunate mefloquine in 8 countries. Again, mefloquine is the drug which promotes drug resistance. In 8 countries, and the failure rate is less than 10%. And then SP artesunate, 11 countries, including India, which I have reservations, and the failure is 1.5%. It is not recommended for Northeast India, but I think it should not be recommended for anywhere in India. Dihydroartemisinin plus piperacillin in 8 countries, China and Southeast Asia, and failure rate is less than 10%. Next one. So to summarize, there is a widespread resistance to many anti-malarial drugs like chloroquine, SP, mefloquine, etc., etabacon, from across the globe from various endemic regions. Misuse of the drug, spurious drugs, use of shorter than recommended duration of treatment and monotherapy, they all facilitate drug resistance. Artemisinin compounds are the most effective antimalarial drugs, and there are hints of resistance developing in our country also. Although, I mean, it has not been studied as a phenomena, but there are hints because there is a failure of about 5% of this combination of sulfadoxine of artemisinin and lumefantrine. Next one, last slide. So, but about a decade back, resistance to artemisinin were reported from Cambodia and other countries of the Mekong region. Mutations in KILS13 gene is responsible. Resistance is not limited to Plasmodium falciparum, but also occurs in Vivax. And ACT combination is only way forward pending availability of new antimalarial drugs. So we should not use monotherapy, no question. We should start the antimalarial drugs rapidly, especially in severe malaria. And as I said, that at the moment, we have either we can use artesunate with initially in the severe malaria and then combine, or we can use lumefantrine and artemisinin combination in cases which are not severe. So this was, next one please. So that was all which I wanted to tell you. And this is a picture from Dev Deepavali, very famous festival in Varanasi. And you can see the picture. Thank you very much for your attention.
Thank you very much, sir, for your masterly talking about the science and your vast experience about managing resistance malaria. I'm sorry that due to paucity of time and we are running late, all questions will be posted in the chat box, and I request you to please answer those questions in the chat box. Thank you again, Professor Shyam Sundar. Now, next lecture, as we are seeing that Dr. Jyotirmay Paul has joined, and he is a well-known physician and professor of internal medicine at College, Kolkata. He has got many research papers in tropical medicine and neurological disease. So without wasting time, I request Dr. J. Paul to deliver his lecture on how to approach an unconscious patient. Dr. Jyotirmay Paul, please.
Thank you. Thank you, organizers of the BAPICON, Professor B.V. Thakur, my mentor in API, Professor Kamlesh Tiwari, our President API, Dr. D.P. Singh, Dr. Hemshankar, Dr. Devija, my all colleagues. Today, I have so many catastrophes. First, I forget the timing. I thought it is 4 o'clock. Suddenly, I noticed it is 2:20. Then, it was supposed to happen in the March. I made my PPT. Anyhow, when I tried to open, I see it is corrupt. No issue. The issue is approach to a unconscious patient when came to emergency. What you will do, how will approach, how will diagnose it. It is a day-to-day clinical practice. So I think without slide, I can explain and we can discuss with all of you, because this is a more practical one than a theoretical one. So unconscious patient brought by the relatives, brought by the policeman is a very common, those who are acting in any, whether rural or urban or medical college setup. So what we will do? So our duty is first to resuscitate the patient, to do the minimum management of the patient, to restore the airway circulation, to have some provisional diagnosis, to do the investigation proper, and to diagnose the definitive diagnosis, and to give the actual management and save the patient. This is our basic idea. So what are the minimum clinical examination? That is the that we are going to forget nowadays. We will discuss in the next 15 minutes. So consciousness means it is the awareness of the self and environment. Unconsciousness means loss of awareness of the self and environment. So consciousness has a two arm. One is the arousal, one is cognition. What we are doing, it is a disorder of the arousal. So coma, stupor, hypersomnia, all are basically the disorder of the arousal. That means there is a lowering of the consciousness. Whereas confusion and delirium is basically the clouding of the consciousness. So we are dealing with the disorder of the arousal. So few words about the anatomy, how the arousal is maintained. Basically arousal is maintained by the RAS system, and then the RAS system is basically present in the brainstem and extend up to the thalamus. When the spinothalamic tract pass through the brainstem, it gives some collaterals to the RAS. So that means pain pathway and arousal have some relation. That is why when you give the stimulation, even the patient is stupor, patient can respond. Even the patient is coma, can respond to some extent. And on the way it reaches to the thalamus, it also is connected by several tracts with the cerebral cortex. So cognition and arousal have some relation. So though arousal is a function of the reticular activating system, it has a connection with the cerebral cortex and pain pathway. So this RAS system can be affected in both structural lesion of the brain and also some metabolic disease. And you remember there is so many cranial nerve nucleus, particularly the cranial nerve that regulate the eye movement. These are present in the midbrain and pons. That is why when there is a disorder of the RAS system or disorder of the arousal, that means patient is stupor or coma, there is so many eye finding we get. That is why when you are dealing with unconscious patient in emergency, examination of the eye has the utmost importance. That way I will try to, if the time permit, in next 15 to 20 minutes, I will have why eye examination is so much important. Eye is basically is termed as the mirror of the brain. So when the patient has initially came to the emergency, patient is comatose stage, you ensure the airway, oxygenation and blood pressure, that is the vitals, and do a quick IV access. And first two things you should do, one is give the dextrose. You assess whether the patient is hypoglycemic, give the dextrose, and if the patient is alcoholic, give 100 mg thiamine, because if the patient is alcoholic, giving the dextrose can precipitate the warning encephalopathy. And if the patient is diarrhea poisoning, you give a shot of flumazenil, very short acting drug, and patient will quickly reverse and will help you giving the diagnosis. So after the next 5 to 10 minutes management, you try to get the history from the patient history or the neighbors who have brought the patient, whether the patient have past history of hypertension, diabetes, ischemic heart disease or seizure disorder, or patient take a chronic medication, particularly the antipsychotic drug and the sedative hypnotics, and is there any history of substance abuse of the patient. You also can check the patient's pocket wallet, because you can get so many clues. You can get some prescription, get some medicines that can give the, because poisoning is a 1/3 of the patient who came brought to the emergency, basically due to the different poisoning. So regarding the history, do the take, what is the onset? If it is a sudden onset, you suspect about the intracranial hemorrhage and particularly subarachnoid hemorrhage. But if the patient's development of unconsciousness is quite gradual, by next few days, you can think of the subdural hematoma or different metabolic encephalopathy. If the patient have the fever at the onset or have the history of fever within the few days, you think of the infective process. Very common is the encephalitis or meningitis. If the patient have history of fall or there is the marks of the injury, think of the different intracranial hematoma. And if the patient have the bilateral symmetrical lesion, think more about the metabolic disease. But if the patient has the as a unilateral focal lesion, suppose patient have a convulsion in one hand, or patient have weakness of the one hand, one limb not moving, you think of the structural lesion. But if the patient has bilateral involvement, more chance of having the metabolic disorder. So after this history, you start doing the general physical examination. In the general physical examination, very important, you observe the signs of the injury and the signs of the poisoning. I told 1/3 of the patient came with the poisoning and one good chunk come with the injury. So these two groups consist of almost near of the 50%. So your duty is to ensure the vitals, the circulation. So you measure the vitals, and now you started doing the general physical examination. What we have learned in our MBBS day, it is the temperature, pulse, BP, respiration, temperature. These four are the very important. So pulse BP you measures, you've taken the appropriate step, you do the IV access, given fluid. Now you see the temperature. If the patient's temperature high, so you think either patient have some infective process, maybe encephalitis, meningitis, or other intracranial disease, even the stroke can present with the fever, not fever, is the high temperature. If the patient have high fever with dry skin, you think of the heat stroke. It's very common in April, May months, particularly in the tropical country, or patient have some anticholinergic intoxication. If the patient have hypothermia, think of the opposite. Patient can have hypoglycemia, patient can have myxedema, patient can have sepsis. Next, you are coming to the blood pressure. If the patient have high blood pressure, think of the intracranial hemorrhage or hypertensive encephalopathy. Hypotension in primary neurological disease is uncommon. But if the patient have AMI or some less perfusion to the brain, that can lead to unconsciousness to the patient. That means pathology is outside the brain, but there is an effect on the brain, and that is why due to the lack of perfusion, patient develop the hypotension. Another is the pulse. Another is the pulse rate. There is a tachycardia and bradycardia. If there is alternative tachycardia, bradycardia, there is a chance of having the medullary lesion. But Cushing reflex means patient of hypertension with bradycardia, and that is the features of raised intracranial tension. So these are the few issues of the temperature, pulse, BP that we have learned in the our MBBS third year days. So respiration, very important, because respiratory central control is from the brainstem and from the higher cortical structure. So if the patient have chain stroke breathing, I'm not going details. What is the chain stroke breathing? It is more. Please mute.
हाँ वो तो पहले ही बता चुका.
Sir, carry on.
May I start? May I start? So if the patient have chain stroke breathing, there is a chance of more bilateral hemispheric lesion. But if the patient has ataxic breathing or biot breathing, chance of having the medullary lesion. In the pontine lesion, there can be two ways it can be presented: either apneustic breathing, that means prolonged inspiratory phase, or if there is a lesion in the rash system of the pons, there will be central neurogenic hyperventilation that is characterized by sustained rapid regular hypernatremia. Otherwise, we can get the Cushman's breathing. So pulse, BP, respiration, temperature, they will give enough clue about the cause of the unconsciousness. After that, today I told I will consider more of the neurological examination or the neurological issues that we should examine, we should keep in the mind. when we are dealing a patient with unconsciousness in the emergency. So in the neurological issues, most important what we see, the level of consciousness, cranial nerves, pupil, eyes, the eye examination, most important, motor sensory system, reflex and meningeal signs. Regarding the level of consciousness, beginning I told there is some confusion regarding the cognition and arousal. So many terms are moving. One is the coma, stupor, drowsy, confusion, dementia, so many terms. These are not interchangeable. There is some difference between these two. So though it is not the today's domain of discussion, but I will touch upon some of the issues. Coma means coma, stupor, drowsy. These are the disorder of the arousal. So coma means there is a complete loss of consciousness that cannot be aroused by the ordinary stimuli, or can be aroused by only for deep painful stimuli. Because I told when the spinothalamic tract pass, it gives some collateral to the RAS system. So this is the coma which cannot be aroused by the normal stimuli or require the higher than normal stimuli. What is stupor? Stupor means patient have a depressed level of consciousness, but when you are giving the stimulation, there is a arousal of the patient, and after arousal, patient behave inappropriately. That means patient is unconscious state, you give some stimuli, patient, there is a arousal and patient is talking inadvertently. Whatever you have not asked, something, some bad thrown language, they go on telling. This is called the stupor stage. What is drowsy? On stimulation, patient is arousable, but after arousable, patient behave appropriately. In stupor, patient behave inappropriately, but drowsiness, patient behave appropriately. But when the stimulation is off, again patient go to the drowsy state. This is the basic difference of the coma, stupor and drowsiness. So we assess the arousal by the GCS score, that is the Glasgow Coma score, and with three factors we keep in mind. We are not discussing details. That is the eye opening, verbal response and motor system. If the patient is normal, score will be 15. If the patient is coma, score will be 3. So the patient, other patient will be the in between. And what I told, there is another aspect. There is a disorder of the there is a cloudiness of the consciousness. That is characterized by the delirium and confusion. Another is a dementia. Dementia, patient alertness is preserved, but there is some cognitive disorder. And dementia, there is a cognition decline is a persistently goes on. There is not fluctuating, persistently downhill course. But delirium, there is it is the acute process and there is a fluctuating course. This is the difference between the dementia and delirium. This is one is acute process, one is chronic process. One is gradually downhill course and one is the fluctuating course. So these are the few terminologies when we encounter the patient of unconsciousness, we should keep in the mind. All are not same. Though this is the domain of the examination of the higher function, where we can details. It is a one-day clinical class to discuss the higher function examination. So now we are coming in the brief about the motor system. It is very difficult to understand or evaluate the weakness of a particular limb in a comatose patient, but there is some method. We can see the tone of the patient. If the tone is very low, if we lift the limb and fall freely in the hemiplegic limb or paraplegic limb or monoplegic, we fall suddenly, whereas the other limb will fall slowly. So in that is the facility. In that way, we can assess the weakness of the particular limb. And we are assessing the motor system. We should observe if there is a myoclonus or twitching. If there is a myoclonic jerks, the patient may have some toxic effect, or patient may be intoxicated or drug poisoning, or patient may have hypoxic encephalopathy. Patient had a heart attack. You have delayed the resuscitation. Patient become unconscious. Patient on ventilator. Now there is a hypoxic encephalopathy. You often will get the myoclonic jerk, or you, apart from myoclonic jerk, you can get some twitching. Twitching means there is a non-convulsive status epileptic occurs. If you do the EEG of the patient, you will get the spikes. So in this patient, you should give the anticonvulsant. If you see the twitching of any part of the body, any unconscious patient, think about the non-convulsive status epilepticus. If you do not give the anticonvulsant, this is the importance of understanding. Patient will go on status within the brain, and edema will develop, and unconsciousness will never improve. Patient will go in the downhill course. This is the importance of understanding the myoclonus and twitching of the lip in an unconscious patient. So another important issue in motors, many issues. I will touch upon one important is the posturing. Posturing means whether the patient is adopting the flexor posture or extensor posture. That is called posturing, and this can happen spontaneously or pain stimulus. Regarding posturing, there is a two basic posturing. One is the decorticate, one is the decerebrate. Decorticate means upper limb is adducted, there is a flexion of the arm and extension of the lower limb. This is the decorticate. Decorticate posturing means lesion is above red nucleus, and decerebrate means lower limb, upper limb both in the extension position. Here lesion is below red nucleus. Decerebrate poisoning at the lesion is a below red nucleus. That means within the brainstem, prognosis is poorer. So after giving some stimulation, if you see patient is adopting the decorticate posturing, prognosis is better rather than patient is adopting the decerebrate posturing. So decerebrate posturing, if the patient adopt, is a much more poorer prognosis than the decorticate. And if there is a symmetrical posturing, there is a more chance of metabolic disease. If suppose maybe a hepatic encephalopathy, if there is asymmetrical posturing, maybe some intracranial hemorrhage, so there will be some structural lesion. So now we are coming to the most important issue. There is the cranial nerve and particularly the pupil. Regarding the cranial nerve, most of the cranial nerves, third forces control the eye movement and the pupil, and pupil is regulated by the both sympathetic and parasympathetic. So in the pupil, most important examination, what we will do in the unconscious patient, we will observe the shape, we will observe the size, we will observe the symmetry, position, and reactivity. So what are the important clues? First is either dilated pupil or pinpoint pupil, or we will get the asymmetric pupil. One pupil dilated, one pupil normal size or constricted. So these are three categories we can get. If we get the pinpoint pupil, very difficult to understand the reactivity, but may have some slow reactivity. Your diagnosis will be either pontine lesion or opiate poisoning, because the parasympathetic trunk passes through the pontine. So if there is a pontine lesion, this trunk may be affected. So there will be pinpoint pupil, but pupillary reflex is present. So that is why we get some reactivity. But the pupil is so pinpoint, very difficult to understand the reactivity. But the pinpoint pupil, small and non-reactive pupil, more commonly seen in hyperthermia. Then I told opposite, larger pupil. Larger pupil means we will get in the anticholinergic poisoning or in case of botulism. But large pupil, non-reactive to light, very bad prognosis, patient is in your terminal stage. Another important thing is if the patient is a large pupil, apparently non-reacting to the pupil, but shows some hippus or some reactivity following the next stimulation, that is the ciliospinal reflex, there is a chance of pretectal lesion. And mid-size of the pupil indicate the patient has the combined sympathetic and parasympathetic lesion. Then I told the asymmetric pupil, very important. First, you all know is the Hutchison pupil. There is the herniation of the brain. If there is a huge hemorrhage, there is the herniation. One side pupil will be dilated, other side may be normal or constricted. And another two important issue is the aneurysm of the posterior communicating artery, where the internal carotid artery passes very close to the posterior communicating artery. So if there is a aneurysm that can, and the parasympathetic nerves lies on the surface of the carotid artery. So there will be unilateral dilatation of the pupil. And Horner syndrome, another example of the unilateral dilated pupil that can happen is the lateral medullary syndrome, carotid artery disease in thalamus and hypothalamus. Next important issue is the yes sir. So another few issues. So I'll finish just telling the headline. It is the pupil reactivity. To remember, pupil reactivity usually preserved with the metabolic disease, but structural disease, there is a people reactivities is almost close. So another few issues is the position of the eyes, deviation, nystagmus, range of movement, and oculocephalic and oculovestibular reflex. If there is a brainstem is intact, oculocephalic or oculovestibular reflex will be preserved, with some exception. If there is a lesion in the brainstem, it is the oculocephalic and oculovestibular reflex will be lost. And eye deviation will dictate whether eye deviation towards the hemiplegic side or away from the hemiplegic side. That will give some clue whether lesion in the frontal brain or in the pons. But remember, the drug toxicity, there is a loss of reflex eye movement, but preservation of the pupillary reactivity, that is very much diagnostic of the drug toxicity. Last two to three lines I will mention. Without ophthalmoscopy, no neurological examination is complete. And papilledema, there is a sign of the raised intracranial tension, but it may not develop in an acute setting. It can develop after 2 to 3 days. So exclusion of the papilledema does not mean patient has intracranial tension has not raised. And you see the venous pulsation. If venous pulsation is normal, that means patient ICT is normal. But loss of venous pulsation does not mean patient have raised ICT. So these are 2 points you should mention. And also during the ophthalmoscopy, observe the change of the diabetic, hypertensive, issues of the infective endocarditis. So there are many issues in the eye examination. Pupil eyelid, whether ptosis is there or patient is difficulty in eye opening or closing. So not going to the details of the nystagmus, all these things. But remember, neurological examination, proper neurological examination in the setting can give you the clue, and you can save the battery of investigation. With a simple investigation, you can reach to the diagnosis, you can have the clue, and you can save the patient. Thank you for inviting me in BAPICON.
Thank you very much, Dr. Paul, for your very impressive, fluent extempore on this very important issue. And I think there should not be any question. Only thing that we have to follow what you have taught. So by following your advices and the way of examining the unconscious patient, we can develop a reflex to examine these unconscious patients in a structured way. Thank you very much for this wonderful lecture, and I hand over the mic to the organizer for further proceedings. Thank you, Dr. Paul.
Thank you, sir. All the 3 speakers are excellent, and I must congratulate them. Also, I congratulate and thanks our chairpersons, Professor Om Kumar and Professor Ajay Sinha sir, for conducting this session in a very beautiful manner. Now, I end this session and hand over this mic to our next moderator, Dr. Mrityunjay Kumar Singh sir. Dr. Mrityunjay sir, please.
Abhishek, kindly do moderation in my part, because there is some network.
Okay, sir. The next session is very important one.
Jyoti, your talk was very good.
That is the chairman's oration. And that our new chairman of the state chapter is Dr. Shailendra Kumar Singh sir. And to chair the session of this oration, I would like to request our immediate past chairman, Dr. D. Nath sir, our past chairman, Dr. Shyam Narayan sir, and Dr. P.K. Sinha sir. Sir, please proceed. Sir, you are muted, sir. Nath sir.
Good afternoon, everyone.
Good afternoon, sir.
Most welcome our dynamic president, chairman of API Bihar, Shailendra Kumar.
Dr. Nath, sir, you are not audible.
I am not audible.
Sir, there may be difficulty if you join by some earphone. You can join by computer.
Should I disconnect earphone?
Sir, Shailendra sir, just say a few words. I would like to just hear you for checking.
Yeah, now.
Yes, sir. Now you
Now
are
audible. But
yes, sir.
network says that it is unstable. Network is still not very stable. So I disconnect, then
Sir,
connect.
your volume is less.
Now am I audible? My volume is okay?
Excellent, excellent.
Okay.
Dr. D. Nath, sir, please remove the earphone.
Hello, Abhishek.
Sir, good evening. Good afternoon.
Good afternoon. Good afternoon.
Good afternoon, sir. Dina, sir.
Please
yeah.
proceed with chairman's oration, sir. Dr. D.
Yeah. I have a great duty to perform. Dr. Shailendra Kumar, our new chairman, he graduated from Darbhanga Medical College and then did his post-graduation from Patna Medical College. Now he is an associate professor of medicine and chest disease at Sri Krishna Medical College, Motihari, Muzaffarpur. He is also the vice chairman of a special task force for tuberculosis diseases, Bihar. Friends, he is a very known clinician of our North Bihar, and his one passion in music, he plays mouth organ beautifully. I have heard him playing his mouth organ. And in the next coming conferences, we may be enjoying his mouth organ during the conference besides its academic feat. I present before you Dr. Shailendra Kumar. Dr. Shailendra Kumar, please.
Thank you, sir. Thank you, sir. My broad introduction, apart from my academics and my other things. Honorable President API, Professor Kamlesh Tiwari, sir. Our guest of honor, Dr. Gupta, sir. Our past chairman, Dr. D. Nath, sir. And our mentor and think tank of API, we often call to him, Dr. Professor B.V. Thakur, sir, Dr. A.N. Rai, sir, and our past presidents, Syam Narayan, sir, Dr. Mahavir Thakur, sir, Dr. Devi Ram, sir, Dr. D.P. Singh, sir, Dr. Hemshankar Sharma, sir, and Dr. Sudhir Kumar from Patna. Seniors and dear colleagues. Am I audible?
Yeah, you are audible.
Friends, first of all, I would like to thank you all for your love, your affection, and choosing me as a chairman, Bihar API. Speaking in front of such of august gathering and galaxy of leaders of API is a memorable event, most memorable events in my life. So I bow, because I am speaking virtually from Chhapra. So first of all, I bow my head to the great soil of Chhapra, where great personality like Dr. Rajendra Prasad, Dr. Jayaprakash Narayan, and Vikhari Thakurji was born. And I also thank the Almighty God. You all know, have witnessed the first and second wave of COVID hit. And it hit so hard that we have lost many of our colleagues by serving the humanity. And some of our senior colleagues, by the grace of God, were very narrowly escaped. So I give my tribute to those who lost their lives. But the crisis is not still ended, and probably the third wave is expected. And it may be different from first and second wave. It may be more in pathogenicity and some different in the age of affection. There is, after 2 years of research, still there are many confusions about the proper management of COVID. It is so life-threatening disease that we become fearful when we think about the third wave, because we, and personally I, have seen with very closely, because our SKMCH was a dedicated COVID hospital. Very unpredictable course, very unpredictable complication, and very unpredictable outcome. So it is a totally unpredictable disease. But one thing is very predictable and which works as sure shot as far as combat to COVID is concerned. That is prevention, prevention, and prevention. After all, human life is most precious things in this universe. So we should try our best to save them, and keep them healthy. So all modes of preventive aspect of COVID should be followed, and we should make people aware to follow the preventive aspect of COVID very efficiently. We teach it, we make people aware it, but most of us do not follow it. So we should not only teach, we should show them that yes, we are following, then they will also follow. And among all the preventive methods of COVID, vaccination is the best and probably most sure shot. So the awareness for COVID vaccination should be our aim, because society follows us, society listens us. So we should speak, whether on virtual mode or in public meeting, to make the people aware for the vaccination. And we are sure that if vaccination coverage will be good, then this third wave will probably may spare us or not be able to do much harm than previous one. And in this context, I would like to quote that we, as an API people, we had made a very short video about 2 to 3 minutes for people's education about COVID vaccination, because still there are lots of confusion about COVID vaccination. Still people phone and ask us that, sir, I have diabetes. I am taking some drugs for heart disease. Should I take vaccine? Still they are asking. So it is our duty, our social responsibility to make them aware about the vaccination. And at this moment, while I am speaking as a chairman, Bihar API, my heart is overwhelmed with so many memories, so many thoughts that is related with my journey to API, related with my future plan, my suggestions, and my messages, my vision. Actually, I should say ours, not my, because now I am not me, I am we. So Bihar API, as far as my journey in Bihar API is concerned, first of all, I would like to share you 2 to 3 short storage memories related with my start of journey in Bihar API. The stories which are very important for me because they about API and activities of API. First of all, I would like to share a short memory when the first encounter with the great Professor B.B. Thakur occurred with me. That was the year 1992, when after doing my post-graduation, I was posted in a remote village of Muzaffarpur, and I started practice in Muzaffarpur. And just after a few days of practice, I got a call from very senior person of orthopedics, because his patient has got some post-operative complications. So to manage that post-operative complications, I got a call from him. I saw the patient, and those times were different from these times, because at that time, no nursing home to admit a serious patient was available in Muzaffarpur, no private nursing home, no up-to-mark investigation lab was available to give emergency report in few hours. So think about that, then listen my story. And at that time, salary payment of a government doctor was so poor that salary was paid after 6 months, 1 year. So practice was very mandatory. That was not hobby or time pass. So that patient, anyhow, I made the diagnosis of electrolyte imbalance. But as far as I was a new doctor, so the attendant of patient was not convinced by my diagnosis, and they called Dr. B.B. Thakur for second opinion. And I was called in front of patient by Professor B.B. to discuss about the patient. Naturally, I was nervous. I recently did my PG, so I had the experience of ragging a junior by a senior, so I was nervous. But when I faced him, I faced the patient, he so much praises about my diagnosis and my approach to the treatment of patient. And one line said by him, I can recall that he said that I myself cannot think a better diagnosis and treatment plan than this very young doctor did. So I was overwhelmed. And on that very day, I learned the real meaning of professional brotherhood. Rather, I should call it fatherly brotherhood. He called me at his residence in evening and advised me to become an API member. Naturally, because I started practice and my service few months before, so there was a financial problem. He understood without saying. He told me, you just fill the form and I will pay, and when you feel comfortable, just return me. So in 1992, when I knew API and I knew Professor B.B. Thakur, I felt his dedication and commitment for association. When he was editor to the API Medicine Up to Date in when the conference was in Kolkata, I worked with him as a proofreader, you can say, and I witnessed his many sleepless nights in editing that book and awaking with us. Not that tum सीमा पर लड़ो जवानों हम सोने जाते हैं. He awake with us in his drawing room many hours. So I learned the real meaning of commitment and dedication by him. The next person in my API journey, beginning of my API journey, who impressed me and changed many things in my life is Dr. Professor Kamlesh Tiwari sir. He is so committed person for this API and API works that you all know that when he was admitted in ICU in Patna with COVID, at that time he was also very anxious about the timely publications of API book. He telephoned one of us that वो काम नहीं रुकना चाहिए, उसको देखते रहोगे कि वो सारा चीज एडिटिंग हो जाए, प्रूफ रीडिंग हो जाए. So I really saw her commitment to API, and I witnessed many times, because I worked with him in SKMCH many years and he was head of the department. So he has inborn leadership quality in his personality. So much so that he can read your mind and he can accurately assess about any person that what kind of work will suit to him and for what kind of work he is the most suitable person. So he is an example of nurturant worker, and he very precisely assess the quality of person who come across him in very short period of time. I sometimes felt a magnetic aura around him, like a saint. So I also learned the importance of patience and cool mind. I never saw him in anger intense mind. So that should be the quality of a leader. He taught us. He is a master of doing mission impossible with utmost ease. Many times in our Muzaffarpur API, we have witnessed that some very difficult work in very difficult situation, and that was cleared with utmost ease by his leadership. So I learned a lot with my API seniors, not only academics, but humanity, apathy, and leadership quality. Now, I would love to spread the legacy to my junior colleagues and my friends. In this context, I am lucky enough to belong to such a place where three great leaders of API belongs. Current president, upcoming president, Dr. Professor Sam Sundar, and past president, Dr. Professor B.B. Thakur. So frankly speaking, for me, API is a university in Muzaffarpur, where I learned the meaning of discipline and dedicated selfless work, importance of knowledge sharing, and importance of brotherhood. Every member of API is related with each other with brotherhood relationship, whether younger or older. I am actively related with API since more than 25 years and regularly attending the national conferences. I have witnessed 2 presidents of API from Bihar and many national level leaders. So soil of API Bihar leadership is very fertile. So much so that our leaders are selected twice or even thrice continuously for first line leadership at national level. Now we should be careful to carry on the legacy by promoting our talented junior colleagues. It should be a part of our professional and brotherhood responsibilities. API front leaders at national level and at Bihar level also should be cautious while holding the key post of some other academic organizations. So much so that his dedication and commitment for API should not suffer. After all, API is the father of other academics organization. And as far as I know, accepting IMA, API, the oldest organization, academic organization of doctors, formed in 1944, and IMA was formed in 1928. So our first commitment, first dedication should be API, then any other academic organization if a person holds the post in more than one organization. Sir, with the core of heart, here I should explain that there is no malice, no harsh feeling for anyone as a chairman API. I am not criticizing any person, any activity. I just want to emphasize that unless you will create some space for young budding members, how the great legacy of Bihar and API will be carry on and go on. We as an API member or frontline leader has so many responsibilities apart from our personal responsibilities and family responsibilities. That was very correctly and in detail pointed out by our national president in his presidential oration. That is social and ethical. As a social reformer, I should not say the word reformer. As a social path maker, we should say, because people listen to us. So when we do consultation, we can also teach few words about the importance of hygiene, about the importance of exercise, good foods in his life. In this context, I would like to quote one of the famous saying by Dr. B.B. Thakur, that when I see a obese diabetic patient, I ask him that whether you have come alone or your son or your other members of family has come. He said that yes, my son has come. So then I call him. And if I found that he is also obese, I teach him that take care of him since childhood so that he should not suffer hits so badly by diabetes as you are. So that should be the spirit. We can do a lots and lots for the society apart from just treating and managing the diseases. So that should be we should do. And I know that our leaders like Dr. D.P. Singh, Dr. Hemshankar Sharma of Bhagalpur, and many others, Dr. Devi Ram sir, are very active in this context. So their social services should be followed by all of us. That is my gut feeling. Should act as technical support to the government in case of any medical crisis, just like COVID. What kind of government wants? We should give our services, like when a doctor gives services in wartime. So medical crisis, if occurs in a country, that is just like a wartime. So we should offer our services, all kinds of support to our members, and for we should have different dedicated wings. We have in API, at least in Bihar level, we must have some charitable organization so that more and more charity can be done in our members and for the society. That is my feeling. So, to sum up, my vision and thoughts for 2021 are following, and I am quite confident that with the help of members and all senior leaders of API Bihar, I will be successful in fulfilling my vision and my thoughts. We will organize CME and workshop at least one in a month, and we'll try to cover the problems and diseases which are more prevalent locally, like tuberculosis, AES, how to treat and manage in resource poor setting. We will give chance more and more to brilliant young speaker, as we are practicing in Muzaffarpur API. We often give chance to speak the youngest or younger members, sometimes PGs, who are our future members. We try to link members with API working at remote, semi-urban and micro interior area in various ways by doing activity like hypertension camp, diabetic camp in his area, by doing a smaller awareness program in his area with his help. So in that way, that person who are our members and working in remote area, they feel more linked with API. To update our API Bihar members directory with mobile numbers in and mail ID, and in that context, I have given a suggestion yesterday in GB meeting that if a mobile application of API Bihar could be made, then this purpose will be solved in very efficient and very easy way. And that application will be available to every mobile of our API member, and just by a click, he could know the email ID, mobile number of any member. And that is not very costly affair. So that is my dream, that a mobile application of API Bihar, just like API Central, should be made. And one thing is going on, so I would like to continue that PG of different medical colleges in our CME and TC program will facilitate all health related days by doing awareness program and supporting activities, not just by doing CMEs. Just two things more that was left. So one thing Dr. B.B. Thakur has yesterday said in few words, that we are losing our entity as a specialist of internal medicine. We love to be called as a diabetes specialist, chest and abdomen specialist, and so on and so on. So the internal medicine do not fascinate us. Sir, internal medicine is the father of all super specialties. So our recognition as a internist, we should be proud on and on different platforms, all India platforms or state platform. We should say government that yes, internist should be recognized as internal medicine specialist. I have felt this. I am saying it that because I have felt this, that when I came and posted to Sadar Hospital, that and I saw that on the post of physician, any MBBS can be posted. But on the post of gynecologist, on the post of orthopedician, on the post of pediatrician, MD pediatric, or at least diploma in that specialty is required. But for post of physician, MD medicine is not required in government organization in Sadar Hospital till date also. So government is not recognizing internal medicine as a very important part of medical fraternity. We know that internists have a habit to think a matter, a problem in very collaborative manner. And so we all know that many a times we have learned, we have listened many stories about that when super specialties see a physician, a internal medicine related problem, what kind of funny situations occur. So, sir, internal medicine is important, and we should say that, yes, we are proud of being an internal medicine specialist. Finally, I appeal all members and seniors to give me support, join my hands in fulfilling my dreams and vision, because without your support and your guidance, chairman, as a chairman, myself is nothing. And with your support, with your guidance, this singular I will be automatically converted into a big we, and we will be part of any change, any good change. Jai API, Jai API Bihar. Thank you. Thank you, sir.
Thank you, Dr. Sailendra Kumar, for your brilliant oration. Your thoughts are very new, and everybody should adhere to your program to fulfill your dreams for API. Thank you very much once again, Dr. Sailendra Kumar, our new chairman. Dr. P.K. Sinha is there. Dr. P.K. Sinha.
Yes.
So, yeah. Your views on it.
Your comment, Sinha sir, your comment, please.
Bubbling with the new ideas and new thoughts, and has got many ideas or dreams, I should say, to enlarge our working and face on the national field, also correct our situation in Bihar. Well, dear friend, Dr. Sailendra, we will always be with you to do whatever you like and whatever you want to go to do in API. We always will be there with you. We all will support you. I hope we'll bring about the changes what you dreamed. So nice your presentation is.
Thank you, sir.
Thank you, sir. With this, we close this session and now move towards the next session. And for next session, I would like to hand over mic to Dr. A.K. Das. Dr. Das, sir. I think Dr. Das, sir, has just disconnected.
He's in Delhi.
Okay.
Next session is of lipid and OHA. First lecture is of Dr. Ritesh Agrawal. He is from Orissa, and he is famous endocrinologist over there. His interest is in diabetes and thyroid diseases, and he's associated with multiple hospitals. And now I request Dr. Ritesh Agrawal to join us, please.
Sir, one request from my side also. I would like to request Dr. Sawal Guha, sir, our new secretary, to chair this session. Dr. Sawal, sir.
Yes, I am here.
Sir, please chair the session.
Sure, thank you. Thank you. I'll be there.
Sir, you have to chair a talk of at least 3 persons. Ritesh Agrawal, Professor Dr. D.P. Singh sir, and Dr. K.K. Lohani sir.
Right. Fine, I'm there. And we have the chairpersons here. Do we have the chairpersons here? Dr. Harishankar Singh, Dr. Ravi Shankar Singh, and Dr. Sudhir.
Sir,
You carry on. You carry on.
I'm not
Okay.
anybody,
Right.
so just
So
sir,
without much ado, I would invite Dr. Ritesh Agrawal to start his elaboration. Dr. Ritesh, please.
So thank you all. Good evening, all the delegates. Thank you, Bihar API chapters and the Dr. Rajiv Ranjan sir, who has allowed me to take on the role of evogliptin, which is the newer DPP-4 inhibitor. And I was also listening to Dr. Sailendra sir just before. He has a lot of new thinking which will definitely help to progress the API nationally and also in Bihar chapter. Definitely, sir, internal medicine is the father of all the super specialty, and before doing any super specialty, we have to complete the internal medicine. Whatever you faced and whatever you experienced, we also experienced in Odisha, where the post of physician is allowed to everyone, but the pediatric gynecologist and orthopedician are allowed to at least those who did the PG. So we need to change this attitude nationally and at the state level also to promote the API and the internal medicine. So just starting my talk on the oral hypoglycemic agent, the role of newer DPP-4 inhibitor evogliptin. So if you see the different anti-diabetic medication, and I hope you saw this slide in various forums where all the anti-diabetic medications are available, I will go on the DPP-4 inhibitor, which has a lot of advantage compared to others without any much side effect. So no risk of hypoglycemia, weight neutral, dose adjustment may be there, GI neutral, congestive heart failure neutral, and at the bone level it is neutral. So if gliptin, we already know about the gliptin is its efficacy is similar to other oral hypoglycemic agent. In real life and in Indian patient, it is better compared to the Caucasian. Better HbA1c reduction with a durability of more than 5 years has been noticed. Work in all stage of diabetes, either it is early, late with all other drugs. Placebo-like safety profile, especially for the hypo and weight gain is concerned, and promiscuous for the beta cell regeneration. So if you go by the DPP-4 inhibitor history, we have sitagliptin, vildagliptin, saxagliptin, linagliptin, alogliptin, teneligliptin, and now evogliptin come after approval in Korea in 2014, and it has been approved in India in 2018. So if you see the HbA1c reduction profile of the different oral hypoglycemic agent, the DPP-4 inhibitor has a power of 0.5 to 0.8% HbA1c reduction, which is almost equivalent to the GLP-1 analog, biguanides, or alpha-glucosidase inhibitor. So come to the evogliptin, the most specific gliptin what I am discussing here. It is a selective, potent, reversible inhibitor of DPP-4, extensively studied its efficacy and safety. And in India, as I have told, it is approved in 2018 by DCGI, and it is available as 5 milligram OD dose. If you see the pharmacokinetics, the DPP-4 inhibitor are the enzyme where they bind with the S1 or S2 of the DPP-4, or they bind extensively to the S1-S2- or to the S2 extensive. So the DPP-4 which is available, which bind to the S1 and S2 part of the DPP-4 enzyme is the vildagliptin, saxagliptin, alogliptin, linagliptin, along with the S1, S2 which bind with the S1- and S2-, and the sitagliptin, teneligliptin, and evogliptin will bind to the S2 extensive part of the DPP-4 enzyme along with the S1 and S2. So this evogliptin, what we are discussing, binds to S1, S2, and S2 extensive by a non-covalent bonding. And because of this specificity to the binding of the DPP-4, it will not inhibit the DPP-8 and DPP-9 by at least, so that it will not cause any reaction arises due to the off-level inhibition of the DPP-8 and 9, which cause skin reaction, immunologic function disorder, or delayed healing in scar. In the pharmacokinetics part, if you see, evogliptin has a bioavailability of around 50% with a plasma peak concentration after 3 to 5 hours. It inhibits at least 80% in less than an hour after administration with a half-life of more than 30 hours. It reached the steady state concentration within 3 days, and the accumulation index is 1.3 to 1.5, which is unchanged by food. So you can take it before, with, or after food also. It is not an inducer of cytochrome P450, so there is no drug-drug interaction has been noticed with evogliptin. No dose adjustment required because urinary excretion is not the major pathway for the evogliptin, and dose administration is adjusted in mild to no dose adjustment required in mild to moderate hepatic impairment, but no studies are there for the childproof criteria C or severe hepatic impairment. If you see the T-half dosing and excretion of the different gliptin, evogliptin has a half-life of more than 30 hours. OD dosing therapy, majorly by the hepatic and lesser by the renal excretion. So no dose adjustment required in the renal failure cases. It increased the GLP-1 level by around 1.5 to 2-fold, decreased postprandial glucose by around 20 to 30%, and the effect of this molecule is mostly dose dependent and remained more than 80% inhibition over the 24 hours. A lot of trials are there for the evogliptin, starting from the phase 1, phase 2, and phase 3. And after 2018, it is launched in India, and the post-marketing study and the comparison with the other drugs are also available. So these are the clinical evidences where the efficacy and safety of evogliptin as a monotherapy in type 2 diabetes patient with moderately elevated HbA1c after diet and exercise published, efficacy of evogliptin versus sitagliptin, evogliptin versus linagliptin, and other OHA has been compared. And here you see in the phase 3 study where the evogliptin monotherapy in patient with type 2 diabetes, where the HbA1c reduction is compared to the placebo is much more, with around significantly decreased 7.2% at baseline to 6.9% in the evogliptin group. And here you see the compared to placebo, the HbA1c reduction is much more, which is statistically very much significant after a period of 6 months of therapy. In the same way, the dose dependency of the evogliptin has been studied, where the evogliptin 2.5 milligram, 5 milligram, and 10 milligram is compared to the sitagliptin 100 milligram over a period of 3 months. So here you see the result at baseline HbA1c. The HbA1c reduction with the 5 milligram is almost equivalent, around 1.3% compared to the sitagliptin 100 and evogliptin 10 milligram. So once daily evogliptin 5 milligram was safe, well tolerated, and most frequently reported adverse effects were similar to those of the other gliptin available in the market. They have also head-on comparison between the linagliptin and evogliptin in the Evergreen study, which is presented in ADA 2019, where they confirmed the evogliptin on the glycemic variability by measuring the blood glucose level. And it is the CGMS monitored glycemic variability measurement between the evogliptin and the linagliptin R. And here you see after the 3 months of therapy, the evogliptin harm, the HbA1c reduction is around 0.85% compared to linagliptin 0.75%. That means more than 0.1% difference between the two are. The HbA1c reduction, the number of percentage of patients having more HbA1c reduction is 68%, and response rate below 6.5% is around 44% in the evogliptin arm compared to the linagliptin arm. And here also the major part is the glycemic variability after 3 months of the therapy. The more mean amplitude of glycemic excursion has been reduced to around more than 24 milligram per deciliter in the evogliptin arm compared to the linagliptin. In the same way, if you measure the glycemic variability by standard deviation, the the coefficient of variation and the standard deviation are more favorable for the evogliptin compared to the linagliptin, though it is not statistically so much significant. Change in baseline HbA1c, again, if you see over a period of 6 months, the evogliptin arm is a little bit of superior compared to the linagliptin arm after the 3 months of therapy. And the response rate, as I have told, response rate achieving HbA1c of below 7% and below 6.5% is more in the evogliptin arm compared to the linagliptin arm. And here you see the glycemic variability at baseline and after 6 months of the start of the evogliptin arm. And these are the CGMS data where the target in range has been more achieved compared to the earlier baseline graph. And the proportion of time in glucose in range, now the ADA 2021 more focusing on the glycemic variability and more focusing on the time in range glucose. So up at baseline, only 40% of the patients were on target in range, and after 3 months of the therapy with the evogliptin arm, around 60% of the target in range has been achieved with the evogliptin arm. So in this evergreen trial, they conclude that the oral administration of evogliptin for 3 months is effective on the change in HbA1c, which was proved to be non-inferior to linagliptin, safe and effective anti-diabetic treatment, and the evogliptin administration is also resulted in improved glycemic variability, which is noticed after 3 months of the therapy. In compared to the others in the renal safety data, also data are available for the evogliptin, where around 32 patients mild to moderate renal dysfunction has been studied, and the drug was found to have safe in all grade of kidney function, starting from the grade 1 to grade 5. And the pharmacokinetic and safety of evogliptin in patients with renal impairment. Here you see the mean plasma concentration of evogliptin group, where they have screened around 57%, enrolled 24%, received study drug in 24% in mild hepatic impairment, moderate hepatic impairment, healthy control matched to mild group, and healthy control matched to moderate group. And in this regards, they conclude that in hepatic impairment, doses and administration adjustment is needed in patients with mild to moderate hepatic impairment. In terms of cardiovascular safety of the evogliptin in type 2 diabetes mellitus, a nationwide study conducted in South Korea, where the objective was to describe the demographic and clinical characteristic of type 2 diabetes with glimepiride, DPP-4 or SGLT2 inhibitor as a second-line treatment. So in this study, they included around 23 lakhs patients to find out its role. And in the DPP-4 arm, they have included sitagliptin, linagliptin, teneligliptin, vildagliptin, elogliptin, and evogliptin compared to glimepiride and the SGLT2 inhibitor. And the study design, it is a retrospective observational study using the Health Insurance Review and Assessment Service longitudinal database in the South Korea, where they compared the glimepiride users. DPP-4 inhibitor users were associated with a decreased risk of cardiovascular disease, while SGLT2 inhibitor user had a null association, that means it is non-inferior. In the same way, the specific cardiovascular disease event in DPP-4 or SGLT2 inhibitor compared with glimepiride as second-line treatment after metformin. So they conclude among 1 lakh patients, the type 2 diabetes on metformin monotherapy, patients added or switched to DPP-4 inhibitor were users of evogliptin. Compared to sulfonylurea, DPP-4 inhibitor users were associated with a decreased risk of cardiovascular disease. Evogliptin users were associated with decreased risk of cardiovascular disease compared to glimepiride with a hazard ratio of 0.66. That means around 44% of the patients have lower CVD compared to sulfonylurea. They have also lesser number of cerebrovascular events compared to glimepiride with a hazard ratio of 0.41. That means around 60% reduction, which is statistically very much significant. So the use of evogliptin either decreased the risk of cardiovascular disease or had no association with it compared to other ingredient of DPP-4 inhibitor or SGLT2 inhibitor. When you see in combination the evogliptin and metformin, it is various country, it has been approved, and in India it is approved by the Alchem Pharma, and in other country it is approved by the different pharma company. Clinical evidence of efficacy and safety of evogliptin plus metformin has been studied with either 1000 milligram or 500 milligram metformin. And in the Korean population, they studied the efficacy and safety of adding evogliptin versus sitagliptin for metformin, treated subject with type 2 diabetes, a 6-month randomized controlled open label trial where they found the baseline HbA1c of 7.4 to 7.5 and the mean change in HbA1c of around 0.59%, which is statistically very much significant. And here also you see the HbA1c reduction from baseline to after 6 months of the therapy, it is around 0.55% reduction compared to sitagliptin of 0.48% reduction, again which is statistically very much significant. So this conclude evogliptin was effective, safe and non-inferior to sitagliptin as an add-on therapy to metformin in Indian patients with type 2 diabetes. There are also multinational global phase 2 and phase 3 studies are also available where the evogliptin 5 mg per sitagliptin placebo plus metformin has been studied. It is combined in the Korean and Russian population and also in Russian population. And the DPP-4 inhibitor in type 2 diabetes and COVID-19, if you see, the DPP-4 are very commonly prescribed anti-diabetic in the type 2 diabetes, modest ability to reduce the blood glucose, and experts had advised continuing DPP-4 in patients with type 2 with SARS-CoV-2 and coronavirus disease 2019. DPP-4 inhibitor as a repurposed agent in type 2 diabetes and COVID-19. So a lot of studies has recently identified a main protease named MPRO or 3CL-PRO from the crystal structure of the SARS. This MPRO cysteine protease and MPRO dimer is the catalytic active form which with its catalytic amino acids, and as a member bound DPP-4 is active as a dimer having 3 active catalytic amino acids. So the DPP-4 inhibitor as a repurposed agent in type 2 diabetes and COVID event, these 3 DPP-4 inhibitor in order of ranking include gemcitabine, linagliptin and evogliptin. So the DPP-4 inhibitor are again where the immunomodulator, antifibrotic, anti-inflammatory. So this may appear to help in curbing inflammatory syndrome in patients with COVID-19. A lot of studies are there where the DPP-4 in patients with type 2 diabetes and COVID has been conducted in the recent years, and they conclude a lot. And if you see the guidelines where the glycemic control algorithm by the AAC, where if you see the HbA1c after lifestyle modification and metformin, if the HbA1c is below 7.5%, DPP-4 inhibitor, where the dual therapy is required, where HbA1c is 7.5 to 9%, again DPP-4 inhibitor comes after the GLP-1 analog and SGLT2 inhibitor. In the same way, ADA also give their guideline where the compelling need to decrease the risk of hypoglycemia, where weight is an issue, where the DPP-4 inhibitor are the treatment of choice after metformin. So to summarize, evogliptin, which is truly a once a day due to its longest half-life around more than 30 hours, established renal safety, hepatic safety in mild to moderate cases, and CV safety compared to sulfonylurea and other DPP-4 inhibitor without any need to dose titration. As per the Evergreen study, evogliptin shows highest reduction in glycemic variability compared to linagliptin, and HbA1c reduction was non-inferior to linagliptin.
Emergency है 10 बजे.
In 3 head-to-head studies against Sita, Evo is also proven to be non-inferior versus Sita. In the Evolution India, evogliptin metformin fixed-dose combination formulation provides better compliance, and the emerging evidence shows DPP-4 can be perhaps useful in lowering the risk of COVID-19 as observed in at least one relatively large retrospective study. So thank you for your kind and patient hearing, and the topic and the over to Rajiv Ranjan sir and to the organizer.
Thank you, sir. Thank you for your excellent talk on evogliptin. This is DPP4. I'll over my mic to Dr. Saibal Guhas. He will. Yeah.
And that was a very nice and crisp talk, Dr. Ritesh. Congratulate you for that. And if there are any queries, I would like to everybody to send them in the chat box so we can take them so that speaker can take them directly and we can save some time. And I think then we can move on to our next talk without wasting any time. The next speaker, Dr. Rajiv, who is the next speaker now? Dr. Lohani is not here.
At this time, Dr. DP Singh sir.
Dr. DP Singh sir is the next
Indian
speaker.
dyslipidemia.
Right.
First is my talk.
Yeah, Dr. Lohani's talk is there, right? That's what I'm saying.
Yeah, no problem, sir.
Sir would be speaking on recent update on management of dyslipidemia, is it not, sir?
Yes.
Yeah.
Yes, sir. Yes, sir. Over to you, sir.
Okay.
In the meantime, I'll request everybody else to keep their mics on mute. Thank you. Yes, sir. Lohani sir, your screen is visible.
गायब हो गया है. यहाँ कॉर्नर में ले जाएंगे क्या?
Am I audible?
Yes, sir. Absolutely. You're audible and your slides are perfectly visible.
Okay.
Please go ahead, sir.
Honorable chairpersons and dear colleagues, at the outset, I would like to congratulate API Chhapra branch for organizing BAPICON in spite of all odds. Where there is will, there is way. So far, management of dyslipidemia is concerned, medical fraternity entered into 21st century along with ATP3 guidelines given by National Cholesterol Education Program of USA. It was revised in 2004, and we managed dyslipidemia accordingly for about 10 years. Then came 2013 cholesterol guidelines of American College of Cardiology and American Heart Association. This was again revised in 2018. So many changes in international guideline in such a short span of time made the whole scenario very confusing for physicians and cardiologists world over. To clear the aforesaid confusion, European Society of Cardiology and European Atherosclerotic Society proposed a new guideline during their annual conference in Paris in September 2019. This guideline is quite comprehensive and reasonable, and in a stipulated 20 minutes time, we are going to discuss it in a nutshell. This guideline is based on certain principles. The first thing is that the low density lipoprotein and other ApoB containing lipoprotein is the cause of atherosclerotic cardiovascular disease. We all know by ApoB containing lipoprotein, we mean non-HDL cholesterol. Another important fact, other important principle about this guideline is that they recognize that benefit of lipid lowering therapy is determined by both the absolute reduction in LDL and other ApoB containing lipoprotein and corresponding absolute reduction in atherosclerotic cardiovascular disease. So both factors are important: reduction in LDL cholesterol and other ApoB containing lipoprotein, as well as absolute reduction in atherosclerotic cardiovascular disease. And last but not the least, these guidelines prioritize identifying people at high and very high 10-year risk of experiencing a cardiovascular event because they are most likely to derive the greatest short-term clinical benefit from aggressive lipid-lowering therapy. What I mean to say is that in our practice, we must try to find out the high and very high-risk individuals because anti-lipid therapy or lipid-lowering therapy are going to benefit these patients the most. The first thing in the management of dyslipidemia is risk stratification. I think many people are not mute as yet, so I will request them to mute their mic. The risk stratification proceeds in 3 stages. The first one is clinical evaluation. Second is 10-year risk estimate, which is known as SCORE, Systemic Coronary Risk Estimation. And the third thing is assessment of risk modifiers. By clinical evaluation, we try to find out the presence or absence of certain clinical conditions which decide whether a patient is high risk and very high risk or not. These conditions are documented CVD, diabetes mellitus, moderate to severe renal disease, very high level of individual risk factors, and familial hypercholesterolemia. 10-year risk estimation, that is SCORE, is actually a computer-generated formula where we feed certain findings related to the patient like age, sex, BMI, diabetes status, blood pressure status, LDL cholesterol, HDL cholesterol, or even the total cholesterol. And we get a figure which is divided into high risk, very high risk, moderate risk, and low risk. We will discuss it in detail in the next slide. And the third one is risk modifier. In selected individuals at low to moderate risk, other factors including in apoprotein B, lipoprotein A, LPA, C-reactive protein, family history of premature disease, presence of atherosclerotic plaque on imaging may improve risk stratification and influence treatment decision. One by one, we will take up these 3 factors. Very high risk. Very high risk people are people with the following conditions: documented atherosclerotic cardiovascular disease, either clinical or unequivocal on imaging, diabetes mellitus with target organ damage or diabetes mellitus of more than 20 years duration, 3 or more major risk factors, severe CKD where GFR is less than 30, and familial hypercholesterolemia with atherosclerotic cardiovascular disease or another major risk factors. When you calculate a score in these patients, it will come to 10 or more than 10. High risk. People with high risk have markedly elevated single risk factors like total cholesterol more than 310, LDL cholesterol more than 190, BP more than 180 by 110, etc. Patients with familial hypercholesterolemia without other major risk factors come into this group. Patient with diabetes mellitus without target organ damage or diabetes of less than 10 years duration, or the diabetes more than 10 years duration come into this category. And moderate CKD, where GFR is between 30 to 60 ml per minute, come into this category. When you calculate a score in these patients, it will come between 5 to 10%. Next is moderate risk individuals, young patients with diabetes of less than 10 years without other risk factors. So a person with diabetes of less than 10 years without other risk factors fall into this category, and the calculated score in these patients are between 1 to 5%. And lastly, the low risk individuals where the aforesaid clinical conditions are absent and the calculated score is less than 1% for 10 years risk estimation. So this is how we decide whether a patient is having very high risk, moderate risk, or low risk, and accordingly we treat. About the risk score, as I was just mentioning, we have got 4 categories: very high risk between more than 10%, high risk between 5 to 10%, moderate risk between 1 to 5%, and low risk less than 1% for 10 years risk of fatal CVD. A score can be used to estimate risk in patients who do not have clinical atherosclerotic cardiovascular disease or other clinical condition, as I mentioned just now, that define a risk category. So this score becomes important when patients do not have associated clinical conditions or risk factors. So especially in moderate and low risk patients, we try to find out what is the score, and accordingly we manage it. There are certain factors which are called disease modifiers. They are family history of premature CVD. We all know what we mean by premature CVD. In men less than 55 years, in women less than 60 years. Elevated biomarkers like ApoB, LPA, CRP, triglyceride, or atherosclerosis or non-invasive imaging. Social deprivation is another very important factor. Obesity, especially central obesity as measured by the body mass index or waist circumference, physical inactivity, left ventricular hypertrophy, chronic kidney disease, obstructive sleep apnea syndrome, and non-alcoholic fatty liver disease. These are the risk modifiers. By risk modifiers, we mean that even if a person is of low risk, but if these factors are present, we will consider it as a moderate risk. Or if a moderate risk patients are having these conditions, he will enter into the high risk category. So that is the utility of these risk modifiers. In American guideline, they use the term risk enhancer for these conditions. And this is precisely the approach towards management. It is slightly complicated, but I will try to make it very simple. On the right hand side is the risk category, and other blocks suggest the approach. So for low risk, we have to do lifestyle modification till the LDL cholesterol is less than 116. Once it crosses 116, we have to think of adding lipid lowering drug. For moderate risk, lifestyle modification till it is up to 100. After that, we have to add lipid lowering drug. For high risk, lifestyle modification till it is less than 70. After that, you should think of adding lipid lowering drug. And for very high risk, lifestyle modification till it is 55 or less, and adding anti-lipid drug once it goes above 55 or above 70. And finally, for secondary prevention, these patients fall into very high risk category. And even if the cholesterol is 55 or less, we have to think of adding lipid lowering drug. And of course, lifestyle modification is always there. One thing is very important after looking at this slide, that you cannot think of managing dyslipidemia, you cannot think of preventing coronary artery disease without giving proper importance to lifestyle modification. And of course, after that, we have lipid lowering drug. So this is the cutoff level. In other words, the goal, what we should aim for while treating these conditions. For secondary prevention, patients with very high risk, the target is less than 55 milligram per deciliter. For primary prevention, for very high risk, again, the target is less than 55 milligram per deciliter. For primary prevention, in patients with familiar hypercholesterolemia, again, the target is less than 55. For secondary prevention, in patients who have second vascular event within 2 years, in other words, repeated acute coronary syndrome, in these patients, the European guidelines suggest that the target should be less than 40 milligram per deciliter. For moderate risk patients, target is less than 70. For moderate, less than 100. For high risk patients, less than 70. For moderate risk, less than 100. And for low risk, less than 150 milligram per deciliter. So precisely, primary prevention, secondary prevention, and different category. And we have got different target which we are supposed to achieve while treating these patients. This is the summary slide of what I was talking just now. On the left side is that target, the goal which we are supposed to achieve. On the left side of the slide is the different category, the low risk, the moderate risk, the high risk, and the very high risk, and the criteria for their classification. And as I said earlier also, for low risk, 160 milligram per deciliter is the goal. For moderate risk, 100 milligram per deciliter. For high risk, 70 milligram per deciliter. And for very high risk, 55 milligram per deciliter. And as I said earlier, for secondary prevention in recurrent acute coronary syndrome, the target is 40 milligram per deciliter, according to European Society of Cardiology. Here, I would like to mention one fact. The Indian Lipid Association, rather the Lipid Association of India, LAI, last year proposed a recommendation about secondary prevention. And they said that for secondary prevention, the goal should be 50. And if there is recurrent coronary syndrome, then the goal should be 30. So gradually we are moving towards lower is better concept. But anyway, European guidelines still suggest 55 and 40 for secondary prevention, but Indian guideline is slightly different. So this is the item you should know about it also. If you look at this slide, it is very obvious that we have to aim for these goals. At the same time, we must aim for more than 50% reduction from the baseline LDL cholesterol by giving treatment. So both are important nowadays, less than 50% reduction, as well as attainment of the goal, that is 55 or 70 or 100. So we should keep these things in our mind while managing the patient of dyslipidemia. The million-dollar question at this stage would be how to achieve these figures, 55 or 70 or 100. And the answer is statin, statin, and statin. Either statin alone, or statin with ezetimibe, or statin ezetimibe along with PCSK9 inhibitors. This is the treatment protocol world over as on date. We all know the statins are classified into three categories: low intensity, moderate intensity, and high intensity statin. By low intensity, we mean a dose which can reduce cholesterol by less than 30%. By moderate intensity, which can reduce LDL cholesterol between 30 to 50%. And a high intensity means a dose which can reduce LDL cholesterol more than 50%. Rosuvastatin in the dose of 20 to 40 milligram and atorvastatin in the dose of 40 to 80 milligram are high intensity statin. The lower dose of these two molecules, as well as the high dose of every other statin, are moderate intensity statin. So for high intensity statin, we have only two options: rosuvastatin 20 to 40 milligram or atorvastatin 40 to 80 milligram. The second thing is that when a patient cannot tolerate such a high dose of statin, or even if with such a high dose of statin we cannot achieve our target, in that situation we have to add ezetimibe. We all know ezetimibe is a molecule which delays the absorption of cholesterol from the gut. Statin, we all know, it inhibits the synthesis of the cholesterol. So when we add ezetimibe in a high intensity statin, we can get up to 65% reduction in the LDL cholesterol. So that is an extra advantage. And even if after adding ezetimibe in statin, if we are not up to the target, we are not achieving the goal, then we can think of adding PCSK9 inhibitors. We all know it is a monoclonal antibody given by subcutaneous injection, and it facilitates the removal of LDL cholesterol from the blood. But the biggest tragedy with this molecule is that it is very, very costly. It has been nowadays allowed production in India also. It is now allowed. The Director General of Drug Control has approved this molecule, evolocumab. But then the cost of one injection is about 20,000 rupees. It is given fortnightly. It means the cost of treatment will be approximately 5 lakhs per year, which none of our patients can afford if they have to afford it from their pocket. So you can use it only when the insurance company is there. and which no insurance company is covering, at least in our country. Even in America, people are very hesitant to do the payment for this PCSK9 inhibitors. So that is the biggest problem. But then there is a good news. A new molecule, which is called bempedoic acid, has been approved by FDA in USA, which is a tablet, 180 milligram daily is given. This is the third drug which can be used as add-on therapy if you want to achieve a bigger reduction in LDL cholesterol. So maybe in future, we will have less emphasis on PCSK9 inhibitors and more emphasis on this bempedoic acid than a new molecule, which was approved only a couple of months ago in USA. Last but not the least, in very high or high risk patients with triglyceride between 135 to 499 milligram, despite statin treatment, omega-3 polyunsaturated fatty acid, that is icosapent ethyl, 2 gram twice daily, should be considered in combination with statin. What I mean to say is probably well known to all of us. If we get a patient of mixed dyslipidemia, where cholesterol and triglyceride both are high, we start that treatment with statin. And after 4 to 6 weeks of treatment, if we find that triglyceride is still high between 150 to 499, European guidelines say it is 135 to 499, we should think of adding omega-3 polyunsaturated fatty acid. Till date, we are using fenofibrate for this situation. A new molecule which has been approved by the Director General of Drug Control in India is seroglitazar, a dual PPR agonist. So these are the options when triglyceride as well as cholesterol is high. But one thing I would like to again remind, which you all know hopefully, that if triglyceride is more than 500 right from the very beginning, don't give statin. First of all, reduce triglyceride by the suitable drug, and once it comes below 500, then add on statin. So this is because with very high triglyceride, there is always a risk of acute pancreatitis. So the priority changes in that situation. Lastly, all persons are recommended diet with low saturated fat, high in fiber and fish, target body index 20-25 kg per meter square, waist less than 37 inches in men, 31.4 inches in women, and 3.5 to 7 hours of moderate physical activity per week. This is lifestyle modification, which I said earlier also is very, very important. If you want to treat dyslipidemia, if you want to treat diabetes, if you want to treat hypertension, if you want to prevent coronary artery disease, lifestyle modification becomes very, very important thing. So we must give emphasis at every stage of management of dyslipidemia. I would like to conclude my talk by quoting a very famous anecdote related to Lord Buddha. Someone asked Buddha, "What is poison?" He replied, "Everything excess in life is poison." What I mean to say is not very difficult to guess. Excess of bad cholesterol is really bad for health. The sooner we treat it, the better. But then at this juncture, anybody can ask a very valid question. Should we treat dyslipidemia according to international guideline, or should we have a different approach, because dyslipidemia in Indian patients are different from what we see in patients in America or Europe or other countries? This is a very, very valid question. And this question will be answered by the next speaker, Dr. D.P. Singh, who happens to be my very good friend, and he is also the president of CSI Bihar chapter. So with these few words, I would like to thank all of you for your kind attention and present hearing.
Thank you, Dr. K.K. Rohani, sir, for very wonderfully updating us on the management of dyslipidemia.
Dr. Seval, may I have one query?
Sure, sir, please.
Yeah, to Dr. K.K. Lohani. Sir, as usual, as always, very nice talk. My one simple query we frequently come across. So one of my patients, rather senior colleague, is suffering on secondary prevention with rosuvastatin 10 milligram only. So his LDL cholesterol is just 38. So he frequently asks me, should I stop it or continue? He's in secondary prevention. So what is your opinion? What should I advise?
Yes, I got your question. As on date, according to European guideline, 40 is the target. According to Indian guideline, 30 is the target. Your patient is in between these two figures. So there is no question as on date. There is no question of stopping rosuvastatin in this patient. So tell him to whatever the dose it is, the target is within limit. So that is okay. But besides, if required, patient can take 20 to 40 milligram of rosuvastatin. But if fortunately it is with 10 milligram, you are well within target. So go ahead, no problem.
Besides, I think, sir, it's a case of secondary prevention. So statin has many other pleiotropic advantages over and above reducing cholesterol.
Pleiotropic effect.
Yeah. So thank you, sir, for updating us so nicely. And I don't think there is any scope for questions after such a lucid presentation, sir. And we will take the discussion further with another excellent speaker, Dr. DP Singh, sir, who will take this topic further and tell us how Indian dyslipidemics are different. So over to you, sir, DP Singh, sir. And we can ask anybody who has queries to put them in the chat box. Dr. DP Singh, sir, the dice is yours.
Yeah, thank you, Dr. Shehwal. And first of all, congratulations to you for becoming the secretary of our prestigious organization,
Thank you, sir.
API Bihar. And I know that you will carry this API flag higher and higher with your academic activities and other things. And thank you, Dr. Rajiv Ranjanji, organizing secretary, for excellent this seminar, excellent BAPICON. Congratulations for that. And
thank you, sir.
Your wish to carry this Indian dyslipidemia, how it is different. And I will try to do justice to that. And already Dr. Lohani has given his most of the views, and even he touched upon the Indian dyslipidemia also, the level, etc. And इसको शेयर करना है पहले क्या? इसको शेयर करने की इसको कर दो पहले.
तो अच्छा ये यहाँ पे ना कहाँ पे वो चैट बॉक्स?
Yes, sir, your screen is visible now.
Yeah.
Slide is visible.
Yes, my topic today is, before I speak, if our national president, Dr. Kamlesh Tiwari sir, is here, he's listening, and just saluting to him to give this beautiful program and beautiful this API BAPICON and guidance and everything, and all the seniors and all my friends. So Indian dyslipidemia, carry forward whatever Dr. Lohani has given the deliberation, very excellent way, very lucid way. India is in the middle of an epidemic of atherosclerotic cardiovascular disease. No sign of abating. Coronary artery disease manifests almost a decade earlier in India than in the Western counterparts. So that is the difference. Why we are suffering more in the coronary artery disease. Incidence of CAD is increasing most rapidly in the younger patients 40 years of age. 10 to 25% of MI in India before the age of 40, and more than 50% that is related before the age of 50 years. So this is, we shall try to find out whether the dyslipidemia is one of the cause. It is a major condition necessary for the atherosclerotic process, and alarmingly, the prevalence of dyslipidemia in India is very high. 80%, almost 80% of Indians have got at least one lipid abnormality or other. And surprisingly, this HDL cholesterol, which is said to be protective, 72% of us, we have got low HDL cholesterol. Triglyceride is in 30%, and this culprit LDLC is only in 12% patients, they are elevated. Hence, the optimal management of dyslipidemia is key to stem the epidemic of ASCVD along with the control of other risk factors. So suppose there is one Indian story, 32-year male IT professionals. He's an occasional drinker and a smoker, non-diabetic, non-hypertensive, so no other risk factors are there, but he's obese. History of this, family history of heart attack is there, but CAG is normal. LDL cholesterol is just less than what Dr. Lohani was talking about, less than 100, less than 110, 100, just borderline. TG is high and HDL is less than 40, 30, and that risk calculator shows just the moderate risk is there. Would you give statin or not? Let us try to find out the answer. Dr. Raman Puri, chairman of Lipid Association of India, told Indians are unique and unfortunately are afflicted with atherosclerotic disease that is premature, severe, and carries high mortality. Seized of this serious situation, Lipid Association of India launched its mission of improving the awareness and management of dyslipidemia, and which is a major modifiable risk factor of ASCVD. What is the Indian CVD burden? If you see what are killing the Indians, the topmost cause is coronary artery disease, and coronary artery disease. And if you see the CV mortality in Indian, comparing the 1990 to 2020, almost more than double, 100% increase in the mortality in Indians are there due to cardiovascular disease. And that is the premature atherosclerosis, premature coronary artery disease. If you see the data, less than 40% of Indians, we have got the 25% of first heart attack below the age of 40, and the 67% below the age of 55 years. So younger Indians, this MI occurs, acute MI, in the young age of us. That is very alarming and very much dangerous things that we must think about this. And the cause is that, what is the cause of why we Indians are suffering from more of the acute MI? The changing epidemiology. More of urbanizations causing diabetes, hypertension, and dyslipidemia, more of stress, and less of physical activity, changing dietary pattern, improved life expectancy. All these are increasing the number of CVD cases and earlier onset of death. See the large number of McDonald's and what we are getting, the saturated fats, and what our Modi is saying, however westernized we get, Indians are still Indians, and that is Obama has got certain remark on this. Even in South Asians, if you see MI at younger age in India, high smoking, high BP, but heart disease among Chinese are very low and Japanese the lowest. And you again the comparison of CVD and CAD from 1990 to 2020 shows more than 119% increase in that. So answer, we shall try to find out whether there is traditional risk factors in Indians are more, or there are non-traditional risk factors which are common in Indians. The data show the similar or lower prevalence of traditional risk factors in ours than with the other population. However, the prevalence of diabetes, as you know, in India, diabetes is India is a capital of diabetes. So prevalence of diabetes is uniformly higher in South Asians. And extent of diabetic lipidemia, dyslipidemia in India is very, very high. Almost 85% of male and 97% of women who are diabetic in India have got concomitant dyslipidemia. So it's very, very common in all states across from Jammu Kashmir to Kanyakumari. And there are certain factors which can influence in this dyslipidemia. Diet is very important. Our friends were talking about the fish and other omega-3 fatty acid. Dyslipidemia profile, even vegetarians are not protected. We Indians have got rich in carbohydrate, low in omega-3 PUFA, and that is exacerbating triglyceride levels. Asian Indians are more physically inactive, and there are maybe certain genetic factors, abnormal variants of ApoC3, ApoE3 genes common in India, and famous this thrifty gene hypothesis, and body composition are also excess body fat in relation to our body mass index. Again, the famous inter-heart study that showed, if you compare these 9 risk factors, dyslipidemia is the most common risk factors. And the data, if you see this population attributable this part, 50% of cases of these first MI attacks, the dyslipidemia, lipids were in the 50%, and next in the was the risk factor was smoking. So this is the maybe the secret that why we Indians are suffering more from that. And this is the typical Indian profiles, and which is more atherogenic, and we can call it atherogenic dyslipidemia, that we Indians have got low HDL level, most common, 76% or so, TG 30%, and the high LPA level. That is also common in Indian, and the commonest, this what we talk about in the European and others, high LDL level is very uncommon. And the inter-heart study also shows the ApoB by ApoB-A ratio seems to be the best indicator or biomarker in Indians. If you see the prevalence and pattern of dyslipidemia in younger generation, adolescent age, there also the HDL level is less than 45 milligram in 48% of population in male. So what should be the answer? There should be screening of young these students at the age of 20, at the time of college entry. That should be, could we give us that data so that we can tackle the dyslipidemia in the younger age. And these atherogenic particles, this non-HDL-C level, that is very, very important in Indians. See the size of this apolipoprotein B, LDL, and small dense lipoprotein, which is cholesterol. See this SDL, small size. This smaller is very dangerous because they are not taken care by the scavenger cells, and we Indians are very rich in this, and so we have to take care of this ApoB or LDL as well as small dense lipoprotein. What we call it, Satsaya ke dohre, Arunavak ke tir, and dekhan mein chotan lage, ghaw kare gambhir, like that. And this HDL level, if you see this lower is the HDL and other is lipoprotein, small a, LDL and IDL and VLDL, all they are non-HDL groups. And so we have to take care of this non-HDL also. So far as triglyceride level and CAD is concerned, the TG have proved to be independent risk factors for CAD and Indians, and that is very much prevalent. Again, the size of the TG are also important. Concept is that those patients with high TG with prevailing smaller particle size are high risk of getting this CAD. In diabetics, TG and low HDL have got more strong and consistent relationship. So in Asian, we have got low prevalence of traditional risk factors. Disease occurs at early stage, more severe form with the poor outcome, and the high disease burden in India is there. And we have to take care in India that non-traditional risk factors like coronary calcium scoring, this is lipoprotein small a, metabolic syndrome, homocysteine level, CRP, these non-traditional risk factors should also be taken care in Indians. CSC scoring more than 400 says to be the very much specificity with the CAD. Similarly, lipoprotein is small a, more common among CAD patients with existing family history. The level of this is also very high, significantly higher in Indians than in Chinese in Singapore. And this again, there's a high lifetime risk of SHCBD in the metabolic syndrome that is very common in Indians. This homocysteine level is also correlated with the increased risk of coronary artery disease. CRP level, there is significant SHCBD with reduction of this statin. The value of more than 2 indicates the increased SHCBD risk. And how we calculate this, the European calculator or other American calculator, this JBS calculator is said to be more useful for Indians. And what is the Joint British Society calculator? A lifetime, this risk should be calculated all Indians. But what is the problem? We Indians are very good in auscultation, but not in statistics. And if you honestly ask all physicians, how many of us sit with the laptop and while like this getting the patients of lipidemia, dyslipidemia, calculate the lifetime risk, and then you start the treatment of that. But we should, if you want to be particular and if you try to find out the guideline. So my dear friends, identify the high risk patients, assess the risk factor, estimate the lifetime risk, get the target and treat with that. And this risk factors very well described by Dr. Lohani, and I won't go in that. The risk factors should be calculated whether they give high risk, moderate risk, and low risk. And for that, we shall fix the targets. And again, the theory is the LDL level, lower the better, whether it is primary, whether it is secondary, and in which there are very high risk or high risk are there. So in all the data shows the lower the level of LDL, the better it is. Again, the proposed LDL cholesterol goals for secondary prevention and familial dyslipidemia. This Lipid Association of India, it has got given the statements or guideline in 2013, then in 16, and then in 20 also. And there are very good in that. And especially in the extremely high risk groups, they have categorized category 1 and category 2, in which the category 1, they have given the less than LDLC goal, less than 50, while in category B, we are talking about that is goal is less than 30. And category B means the CAD with more than one of the following: diabetes, polyvascular disease, or 3 or more atherosclerotic cardiovascular disease with target organ damage, or recurrent ACS within 12 months, despite on LDL therapy. So this group, even the less than 30, that is the recommendation by Lipid Association of India. It's the same thing. So, but beyond the LDL also, we have to target, there are several atherogenic lipoproteins, and LDL accounts only for 75% of them. There are residual risk of SACVD in the statin-treated patients remaining high as 50, more than 55%. So it is evident that to reduce the SACVD, we need to concentrate on all atherogenic lipoprotein, not just the LDL. So in Indian scenario, non-HDL cholesterol measurement should be there. And in this, again, the very high risk, we have to reduce the non-HDL level less than 80, and low risk group less than 130, and similarly moderate and a higher risk group less than 100. So that is the guideline, that Indian guideline, that non-HDL level should also be taken care of. What about the triglyceride? Do not underestimate this high TG. And this level is also related with the CHD risk. In this atherogenic TG, if it is 250 and more, this is the phenotype B. And in this group is more TG, more this concentration in the liver, and more formation of small dense lipoproteins. These are very dangerous. But if the TG is low, and in that case, there is low content of this TG in the liver, and the chances of getting the phenotyping a less small dense lipoprotein, and these are more protected. This non-fasting level, this high level more than 150 to 499, in this group, there are very high risk group, more than 500. Below the 500, again, we shall see that how the statin helps in that. Again, relationship between HDL and CV risk. There are data that very high level of HDL are associated with increased risk of death from both CV and non-CVD. So that you have to get that U-shaped curve. High level is okay, not very high level is not protective. So the inter-heart study shows HDL in Indians, prevalence of low HDLC level was much higher, and increasing HDLC level was associated with more than 13% reduction in MI risk in South Asian as compared to 23 in the other Asians. So the patient with low HDL are 3 times more likely to die after an acute coronary attack. So we have to take care of this HDL also. And so what should be the therapy for the Indians dyslipidemia? So in the Indian dyslipidemia, apart from this aspirin or antiplatelet. We have to take care of this blood pressure. We have to take care of the cholesterol level and what is the target. But in this low risk or moderate risk groups, diet and exercise and physical activity, thus are very, very important step to get the target. So identification of subjects with dyslipidemia, increasing the dosage and adherence to statin is the suitable subjects focus on achievement of the LDL-C goal. Identification and application of lipid marker like lipoprotein small a and apolipoprotein B for the risk stratification and control of vascular inflammation. Significant residual risk persists even after the high intensity statin therapy, and further lowering of LDL-C beyond that achieved by statin has been shown to further reduce the severe risk by addition of non-statin lipid lowering agents like this ezetimibe and other PCSK inhibitors. So we have to achieve the goals. But physicians has got inertia in using the high intensity statin that was failed, that is responsible for patient in India not achieving the LDL-C goal. It is noted that statin dosage are often reduced in ACS patient even after first few months. And instead patients who are unable to tolerate these subjects, we should lower the dose. We should not stop the dose. Ezetimibe 10 milligram is the drug of first choice for the adjunctive therapy. Similarly, LDL-C goal, if it is not achieved, in that cases, PCSK inhibitors may be considered for addition as a third LDL-C lowering, lipid lowering agents. And this slide is again, we have already seen in Dr. Previous speaker. And this is the reduction is very, very important on how we reduce by the moderate intensity or high intensity statin. And if you add ezetimibe, we can achieve the 65% reduction. If we add these PCSK inhibitors with ezetimibe, we can achieve even the 85% this reduction of the LDL-C. And so the target is to be achieved. How low is very low, too low. The zero LDL hypothesis is there. Many patients on this PCSK inhibitor achieve extremely low level of this. Extremely low level LDL-C are associated with even less cardiovascular effects. And so on minimal side effects. So we have to fix the targets. And similarly here the algorithm that high intensity statin of this optimize the control of diabetes and hypertension, reinforce lifestyle measures like heart healthy diet, regular exercise, weight reduction, quit smoking, alcohol restrictions, and if this very high risk group, add ezetimibe, keep the level less than 50 or so, consider PCSK if the goal is less than achieved to less than 50. Similarly, in category B, you have to achieve less than 30 as the Lipid Association of India says. What about this high TG level? Subjects with TG more than 200 and less than 500, again is statin. Statin is the drug of choice, but subject with high 500, more than 500 levels, fibrates to prevent the acute pancreatitis, and later you can add statin to achieve the non-HDL-C goal. Combination of this statin and fibrate does not improve the ACS. This atherosclerotic cardiovascular outcome is generally not recommended. Considered therapy with statin and fenofibrate for men in selected cases where the both triglyceride is more than 200 and HDL is less than 35. Combination therapy can be achieved, but the dosing should be spaced more than 5 years because side effects of these combinations are there on kidney and others area. This is the lifestyle modification is smoking. This all study have shown this alcohol consumption should be prohibited. Vegetarians are not protected. Eat baked or boiled fish at least twice per week. And already we have listened that how much this omega-3 and other things should be there. And we Indians are 1/3 of our populations are inactive. So regular exercise 150 minutes, more than 150 minutes a week, that is there. Mr. Modi, is it true that there are 4 billion lazy people in India? Yes, that is why I invented World Yoga Day. But this is the So what should be the Indian lipid policy? Indian lipid policy should be three-pronged. First is the individual, second is the policy and legislation, and community population, especially the primordial preventions in the younger generations should be there. And we should screen all adults at 20 years of age at college entry, magnificent 7, all starting with the S majority, that is quit smoking, sedentary habits should be removed. This heart saturated fat should be reduced. This statin could be the answer if there is cardiovascular disease. Blood pressure should be controlled, systemic blood pressure. Sugar should be controlled. And of course, body mass index should be maintained. So my dear friends, so what should be the story of this answer of that story? The young Indians, 32 years, if he is drinking or smoking, it's a major risk factors. We have to stop it. Obesity is a moderate risk factors. It's lipoprotein is small a, and this low LDL levels, that should be, that also there are TG is also there. These are the high risk factors. Low HDL, again, the major risk factor, statin is the answer in this, apart from physical exercise and diets. So take home message should be the atherosclerotic cardiovascular disease events are skyrocketing in India and what occur with only modest hypercholesterolemia. More aggressive LDLC and non-HDLC goals are needed in India, especially in secondary prevention. Statin ezetimibe use needs to be increased in India. We are not using it properly and proper doses. This PCSK inhibitor can facilitate low LDL cholesterol goal achievement, but cost is the barrier. Again, injection form is there. Multifaceted approach are required to induce the lifestyle changes, control ASCVD risk factors, and optimal lipid lowering goals. Screening all adults at the age of 20 should be made mandatory. So today is the wishing everybody happy Independence Day. But in this Independence Day, we should think about Indian dyslipidemia, which is different. We should have Indian risk calculator. We do not want to calculate it. That is also important. We should have the Indian target of LDLC and a non-HDLC goal, and the Indian approach of dyslipidemia should be there. Thank you very much.
Thank you. Thanks a lot, Dr. D.P. Singh, sir, for this excellent talk on the Indian scenario and bringing us to realize how we are missing out on this silent epidemic and how we are missing to target this this disease in our clinics. Thanks a lot, sir. And if there are queries, kindly I request them to be put in the chat box. I think Dr. Sanjay is here. Sanjay, are you there?
I think
Sanjay, neurologist, Sanjay Kumar.
Yes,
Sanjay is here. Great. So
yes,
the next talk is from a very promising and upcoming neurologist of Bihar, Dr. Sanjay Kumar. He needs no introduction, and he'll be talking on childhood epilepsy. So without much ado, over to you, Sanjay. You can start your presentation now.
Thank you, sir. A very happy Independence Day, sir. All of you respected seniors, sir, my dear Sewal boss, and all the junior colleagues and the students who have joined my session. So my topic is of childhood epilepsy and seizure syndromes. Just directly going to what's not working. So if you see about the problem, why this topic is very much important to be discussed. If you see the total population of epilepsy and this childhood age group, you will find 25% of the population of whole of the epileptic population is from children. And if you see the round, that was 1 year before data, that is around 12 million children is suffering worldwide from this epilepsy, different type of epilepsies. So what is it? Before this, epilepsy is a disease where we got seizures. So what is seizures? Seizures is time limited. Time limited means that it should be normally less than 5 minutes episode. It is paroxysmal and which is abnormal, involuntary, but rhythmic discharge of one part of brain or most of the brain at a time. So it depends upon the area of the brain where the seizure arises and give rise to different symptomatology. It can be motor, it can be sensory, it can be autonomic, it can be visual. Whatever the area of the brain is involved, we can have that type of symptomatology we can face. So what is epilepsy then? So epilepsy is a disease which is characterized by more than 2 unprovoked seizures. What do you mean unprovoked seizures? That means, just in the next slide, we will see the provocation of a normal brain. Suppose we all are presumed to have a normal brain. We can have seizures. We can have seizures. Okay, like this. If you are able to see the slide. So a normal brain can have seizures. Provocation may be is a very high dose of sedatives. We can have a great degree of insomnia, high degree of fever, brain injury, intracranial hemorrhage. The normal brain can have seizures. But what is the difference between an epileptic brain and a normal brain? So normal brains are having high threshold of developing seizures, but in epileptic patients, this is very low threshold to develop seizures. So in epilepsy, we are having propensity to develop spontaneous, unprovoked seizures. And therefore, seizure is a symptom and epilepsy is a disease. And we will have multiple type of epileptic disorder in our kitty to discuss. So whenever patient will deal with seizures, so how do we proceed for diagnosing that very thing? So we have got a clear-cut guideline. Whenever you find and you feel that this patient is having a seizure, then write down whole of the event which is occurring to the patient and then think yourself, really it is a seizure or not? If it is a seizure, then what type of seizure? It's a partial seizure, it's a complex partial seizure, is it GTS or different varieties of GTS? And then think again that it is either it is syndromic or it is non-syndromic seizures. What do you mean by syndromic? That there's a particular conglomerate of different type of seizures, sign and symptoms. And then if you are find that it is not giving any particular syndrome in the kitty, then you can write it down that is a non-syndromic type of seizures. And then find out the etiology. Either it is caused by some structural problem of the brain, or you know some genetic basis of that. Then you write down the etiology. And then the seizure is causing, how much disability the seizure is causing to your patient, that should be written in this list. So this is the complete diagnosis of the seizure. Whenever the patient will go any part in the globe, the person is very much effectively be known to the other doctors that exactly what is happening to the patient. So after this, we will find that in childhood epilepsy, how many types of epileptic problems we can have. So for your discussion and the prognostic point of view, it should be discussed in 3 important things, like the disease, or it's a syndrome, or it's an encephalopathy. We will discuss one by one. But what is the difference between disease, a syndrome, and an encephalopathy? The disease, if you say this a person is suffering from a particular epileptic disease, that means there is one seizure type which is present, one and only one seizure. There is no other sign or symptom of other systemic problems. The only problem is a seizure which is of a single type. This is known as epileptic disease, and this is having a very, very good prognosis if the prognosis of the patient is concerned. And if it is a syndrome, then a multiple seizure type is present. Multiple sign and symptom pertaining to the other system of the body may be present, and then you can say it's syndrome. And in the syndrome, if the seizure is causing a decline in the cognitive level of the patient, then you have to term it the syndrome as an encephalopathy. There is a difference of disease, syndrome, and encephalopathy. Disease prognosis is very good. Syndrome, the prognosis is in between. Encephalopathy, you are going to deal with a very bad prognosis. So very bad prognosis. Okay, so that is about this. So in the epileptic disease, what are the things to be discussed? First is the absence epilepsy. Second is the Rolandic epilepsy. Third is the occipital epilepsy. Fourth is febrile seizure or GFS plus. which is known as generalized epilepsy with febrile seizure plus autosomal dominant nocturnal frontal lobe. Let's see one by one. And in the syndrome and encephalopathy, we have got JME, progressive myoclonic epilepsies, Rasmussen syndrome, Lennox-Gastaut syndrome, and a special or newer variety which is known as electrical status epilepticus during slow wave sleep or Landau-Kleffner syndrome. We will come one by one in a very short way. Childhood epileptic disease. The first one, I am giving three important things. How to think about the diagnosis. To see the video, you can diagnose, the easy finding, and the treatment part I'm not going to discuss, because if you diagnose something, treatment is available everywhere. You will find treatment everywhere. If your diagnosis is correct, treatment is the easiest part as far as the neurologist is concerned. How do you suspect an absence seizure? Typically, a child of a school starter age group come. If the guardian is very learned one, very observant one, they will say, and then my kid or my child or the teacher will say, becomes absent from the class for seconds, and then he comes back. When you used to ask what is happening, he is not answering, or decrease in the scholastic performance of that very particular guy. Otherwise, he's very intelligent, but he's not picking up the subject in a good way. So there is why this is occurring. This is occurring because he is having a brief period of impaired consciousness. And that is around 50 to 100 times, even in the 1,000 times a day. Duration is 5 to 10 seconds. And that is more than sufficient. If someone is hearing a lecture in a very concentrated way, and suddenly he found 10 seconds of the lecture absent, then you can understand the way how he is picking up the subject. Continue up to 16 years of the age. So you just see the way. And the EEG is very much particular see that they which you have the seizure started and he became cut down from the environment. He is being cut down from the environment, you can see that. And then a long gasp and again started responding. The EEG is becoming normal. And there is no post-ictal phenomena. So this is typical of absence seizure. Definitely, if the residents are hearing, this is the drug of choice is valproic acid and ethosuximide. And this remains around 14 to 15 years of the age. Rolandic epilepsy. As you name, the Rolandic area is the perisylvian area. And what is the function of that very particular area? Whole of the buccal and oral cavity is supplied from motor activity of the buccal and oral area is controlled from the Rolandic area. So if a seizure is arising from that very particular area, what will happen? There will be either the movement of the lips or the tongues or the deglutiting movement of that. Usually it is a simple seizure or a simple partial seizure, or it can be complex also if there is an impaired of the consciousness level. Usually it is up to 10% of the childhood seizure is from this area. And the beautiful part of this, if it is usually to start with, in most of the years, it is nocturnal. So if the mother is not aware about the fact that yes, the child is suddenly awaking from the sleep and suddenly doing some chewing movement or deglutiting movement or some tongue movement and then again go into sleep, then it is very hard to pick up. But it picked up when it occurs during the daytime. So anytime if you feel this is a Rolandic epilepsy, a nighttime EEG or a sleep-deprived EEG is very much required to diagnose this very part, because in almost all the cases, these are epileptic diseases. And in the most of the cases, and almost all the cases, the MRIs are normal. The only way of diagnosis is either you're going to diagnose that everything clinically if you're having a video of the patient or with the help of the EEG. And they are very much responsive to the drug. And if the patient is not, or the patient party is not very much concerned, they are very helping, then these diseases, if the frequency is very less, you may not treat these patients, and generally reassuring the patient party is more than enough for this kind of epilepsy. So knowing this epilepsy is very, very important. So Rolandic epilepsy, if you see the EEG, it has got spike and wave activity in the centrotemporal area. The Rolandic area is just the middle of the area, central and temporal area. You will have spike and wave activities. So you just see. This is complex. This one, the whole of the lip movement is suddenly followed with an unawareness of the fact. And again, there is no post-ictal confusion or anything like that. And if you see the EEG of this very particular thing, this is C3, any central area, we have got a spike and wave activity. This is wave, this is wave. This is spike and wave activity. Spike and wave activity you can find in the centrotemporal area. So this is very much pathognomic of Rolandic seizures. Benign occipital epilepsy of childhood. Again, it is occipital area. Definitely we are hoping some visual phenomena to occur. It is occurring in 6% of the kids. And if you see the visual phenomena, we can have a positive or a negative visual phenomena. In the positive phenomena, what exactly we can feel? There may be a visual hallucinations or flashing of lights. And the negative phenomena, there can be complete blindness or hemianopia. Illusions of the of different kind of images can be there, which is paroxysmal, less than 5 minutes, and it can be followed by headache, nausea, or vomiting, and in 30% cases, impaired level of consciousness. So if you will feel this phenomenology, it is very, very close to a classical migraine, where there is a visual aura, headache, nausea, and vomiting. We will come to show that what are the important symptomatology in seconds, that if it is present, that will differentiate between a classical occipital lobe epilepsy and a classical migraine. Usually this phenomena is nocturnal. There is a family history of any type of benign epilepsies, and it is appears in the usually 3 to 5 years of the age and going up to 15 years of the age. But usually, if you see the EEG, will have a posterior dominant spike and wave activity. And the most important part of that, if you've seen anyone of you seen the EEG pages, there is written is sleep, awake, hyperventilation. There is meaning of this. So if the patient, in this very particular patient, if the EEG is not taken with the eye closed, you will miss the occipital spikes, because these spikes only appear when the fixation is abolished or the eyelids are closed. So for that very particular person, we have got different type of modulation where we take the different type of EEGs. So this is EEGs, we'll have a occipital spike and wave activity. So the question was that, just on the onset, we have told you that we may have problem in diagnosing the occipital or differentiating the occipital lobe epilepsy from the classical migraine. So if you see this very particular image, on the left side, you are seeing that that in one of the visual field, there is colorful balls which are appearing in the visual field. And in the other, you are seeing the whole of the visual field affected. And there is zigzag lines, which is black and white, which just is spreading outwards. So in the left side, if the patient will discuss, you will ask, you have to say the patient what exactly you see or experiences. If his description is like this, we see the colorful balls, which is spreading both the visual field, and then the diagnosis is a occipital seizure. And if there is zigzag line, which is just starting as a 1 point and then spreading to involve both of the hemifield, then it is a classical migraine. And the second important point in classical migraine, there is nothing. I have already told you that 30 to 40% of the patient of occipital seizure may have impaired level of consciousness. So in that migraine, we don't have any migraine. We don't have impaired level of consciousness. So these 2 points you have to remember, that the visual aura, type of the visual aura, we can well differentiate between occipital seizure and classical migraine. Panatopolar syndrome. If you don't know this, many times you will miss the diagnosis. This is very interesting, and this is dramatic type of epilepsy, where we can have nocturnal seizures. And as it is nocturnal, most of the benign syndrome, apart from the just living, if you leave absence epilepsy, you will find most of the other epilepsies which are benign are coming nocturnally only. Why this is occurring? Let me explain, because the time is very limited. Anytime when you are going between a different type of different phases of sleep cycle, like stage 1 to stage 2, stage 2 to stage 3, stage 3 to stage 4, or coming back from it, these are the important landmarks where the epileptic seizures are most notably appears. So this is during the sleep. This benign epilepsies are most commonly occurring during these periods due to our change in the depth of the sleeps. So this phanatopolar syndrome, why it is very important to diagnose this? Because this is we have multiple diagnoses. If before diagnosing this, I have till this year I have got 14 patients of this, and all 14 patients have got at least 6 diagnoses before diagnosing a phanatopolar syndrome. Why? Because just see the semiology. Nocturnally, the child is just sleeping, suddenly awakes, the eyes are open, deviated towards one side, and he is pointing towards his stomach as if there is some discomfort in the stomach. There is a retching sensation, hypersalivation, and then nausea, and then the vomiting, which can just go beyond 30 minutes, and then again child go back to sleep. And every time, if you see the panic reaction of the guardians, they will go different. Every time they are going to ICUs, admitted after one day, discuss different diagnosis, metabolic syndrome, encephalitis, cyclical vomiting, and being the peptic ulcer syndrome, ZERD, multiple diagnoses you will face that, until you just have an EEG or a neurologist who can just keep it there. See this.
I would request everybody to kindly mute.
Unresponsive child, unresponsive, is not responding, eyes open, pupil dilated, eyes is fixed towards one side. Hiccups, hypersalivations, and the last, he will have a sense of vomiting. Sense of vomiting, this is nausea and going to be vomit.
He doesn't puke sometimes when he's...
This is vomiting. And if you see the seizure, the occipital, O1 is occipital. This is occipital, you have a spike and wave activity. Again, the occipital spikes and waves. So in every occipital montes, we will have an occipital spike and wave activity. This is phanatopolar syndrome, and it is very, very responsive to oxcarbamazepine. So if how to diagnose nocturnal episodes of recurrent vomiting and unresponsiveness for 5 or 6 or 7 minutes. Think about this very particular syndrome. And if you don't have your working periphery, give 10 or 15 days of oxcarbamazepine and ask about any further attack. If the answer is no, go for it. Go for it. Next is ZEFS plus. This is again a very interesting syndrome. Suppose a patient of 2 or 3 year child comes to you and say, the doctor, whenever there's a fever, either low grade fever or a high grade fever, my child is having seizures, like generalized seizures. You are pretty well diagnosed that the patient look, nothing to worry. This is the case of a febrile convulsion. You have to not let your child to develop high degree of fever. You have to give paracetamol, and at best you can give clobazam 5 or 10 milligrams when the fever develops. This is all the well-proven therapy of febrile convulsion. Then the guardian or patient party will ask you, doctor, up to what time we have to take the precaution? Your answer will be 6 years. 6 years will the answer. After 6 years, you don't have seizures. But again, the patient party will come to you. Dr. Sahab, you have told me that after 6 years, there is no seizure at all. but my child is having 7 years of age and now he is having seizures. What to do? You don't have to panic. Yes, we have got an entity where the febrile conversion can convert into generalized epilepsy and febrile seizure plus, which is a channelopathy, which is genetically predetermined seizures. After 6 years, what happens that seizures comes to febrile as well as febrile seizures. If it is GTCS, other seizure types also come to join this type of seizures. But you don't have, because every test, MRI or CSF or blood test, everything will be normal because it is channelopathy. You don't have to worry and ask the patient to wait for next 5 years. And then again, it will regress. And it is due to sodium channel defect. So if the diagnosis is a febrile seizure earlier, and the seizure is continuing after 6 years of the age, and the new onset seizure is coming, or the patient is also having an afebrile episode, you don't have to worry about this. Definitely you do a new set of tests, just to rule out other things are going to perturb that very particular case or not. If everything is normal, you just fix the case at GFS plus. Now, if anyone will ask you, if the residents are hearing, if anyone will ask you that what is the commonest problem which or the commonest seizure which is very much in a differential diagnosis of somatization or non-epileptic type of movement disorders. Previously used to think that temporal lobe epilepsies are very common because their psychiatric symptoms were there. But the most common seizure which mimics with the somatization or non-epileptic movement disorders, these are autosomal dominant frontal lobe epilepsies. Why? You will ask why this is so and so. Because the reasons are it is very short lasting, number one. There is no post-ictal phenomena, number two. Number three, there is a bizarre type of activities are there. Like suddenly in the seizure, the patient will just start grasping someone who is nearer to him. He just go and embrace that very person and tracing movement, vocalizations, as if you see in the history equation, what exactly if the patient who have lived in villages or the doctors who have experience of villages, there are a lot of diagnoses were there. Before we used to hear history and like that the child is having some hysteric problems or somatization, where all these symptoms are present, like vocalization, thrashing, grasping, or grabbing something. And the most beautiful part is that the patient is having semi-awareness of that very particular events. All these things make frontal lobe epilepsy a very, very important mimic of somatization or somatization and frontal lobe epilepsy. So every time if you see the patient and psychiatrist had just raised their hand, I given everything, but the somatization part is not going through, think about a frontal lobe epilepsy that can be have. So how do we diagnose this? The seizures are usually, most of the cases, it is nocturnal. What can we see? The patient start gasping, or thrashing movements may be there, or they grab onto things, what are nearer to them, they start just grab the things. And it occurs in clusters. Within 1 or 2 hours, we can have 10 or 15 attacks, and it can persist up to adulthood. And as there's a multiple movement, motor movement is going during the epilepsies, usually there are a lot of movement artifact during the EEG. So interictal EEG is usually normal. So in the frontal lobe epilepsy, unless you are not seen the videos, you are not able to diagnose this. And many a times that are moving in and around the psychiatrist for this kind of disorders. Just see, we have put 2 videos back to back and see how much this can present. About the first video, about this video. This is a guy who's a 6-year-old. What is the presentation? Usually in the evening or night hours, suddenly he used to awake, search his mom, and who is nearer to him, just grab him, and just starting vocalization and some movement of the upper and lower limb. Vocalization, movement, and upper and lower limb. Vocalization, movement of upper and lower limb. And then the patient becomes all right. And just see the video. Night, he awoke. This vocalization, and see the movement of upper and lower limb. This question is from Chapra itself, the organizing committee chairperson, sir. This is from your district. So this is the kind. He is having vocalization and movement. Many times he answers some questions or recognize some knowing face, and then he becomes all right. For medication, antidepressant, and antipsychotic, many drugs were being given without any response, and ultimately 3 or 4 days back he diagnosed as a frontal lobe epilepsy. The second video, that is a guy from a nearby town from Patna, always having been a problem that he's having thrashing movements all around. He started biting and just giving tongue to other person who is nearby, and then again become restless for some time, and then become okay. And many times he has been scolded and thrashed and beaten by the family members for doing this. But how it's
Dr. Sanjay, about 1 minute left.
and again he is going to sleep, start doing some stereotype movements as if he is dreaming. And so in the only part is that if he is sleeping, the closest differential diagnosis apart from somatization is parasomnias. So we have to rule out this disorder. So best is through the video he uses doing in the night time is very important to diagnose this. Seizure syndromes. The first is juvenile myoclonic epilepsy. This is again very important. How to is present. Typically, usually girls, 10 to 15 years of age, comes to you. So in early morning hours when brushing or taking tea, suddenly there is a jerky movement and the brush is thrown, or the glass is thrown, or the tea is thrown from the cup. And then after 6 months or 4 months after this, episodic jerky movement of the hands or the body or the limbs, there is GTCS. And why you have to know this? Because many a times, almost all the investigation apart and just except EEG will come normal, and it outgoes around 40 or 50 years without any mental problem or physical disability or anything else. So it is a syndrome where we can have myoclonus and GTCS as a part of seizure, 2 types of seizures. There is no mental problem. Usually start in 12 to 18 years. Girls are more affected. Early morning awakening hours seizures are most common, and 4 to 6 hertz spike and wave activities are usually seen. Spikes, these are spikes. So before 1, 2, 3, 4 spikes and waves. 4 to 6 spike and wave activities, generalized activities are very much pathognomic of this very particular disorder. So anytime you are having video, see this video of the girl, very cheerful girl, a very good singer also. So this is your JME. So just 2 or 3 slides, I will request Chairperson sir to allow me 2 or 3 more minutes because the video is going. The video part is something which I wanted to show you. So what is progressive myoclonic epilepsies?
Yeah, please be fast.
Means there is a myoclonic seizure associated with generalized seizure, and then there are certain neurological symptoms like ataxia or dementia associated with some neurological deterioration or cognitive decline. This is progressive myoclonic epilepsy. There are multiple types of progressive myoclonic epilepsy, like Baltic myoclonus, like Lafora body disease, like sialidosis. but I will discuss which is common in our part of the world, that is subacute sclerosing panencephalitis. Usual typical patient are non-vaccinated measles patient, which go unrecognized. After 10 or 12 years, there is sudden cognitive decline is associated with slow myoclonus, and really it is a dreaded disease. Just you have to remember this slow myoclonus. There is a visual loss, GTCS, and cognitive decline. If you have seen this, you can diagnose SSSP, and then the EEG is typically of there is a periodic pattern of a slow and fast wave discharges are seen. Rasmussen syndrome, again, it is a dreaded syndrome, although very rare, where autoantibodies are present against the glutamate 3 receptors. This is immunologically mediated. So if you are not diagnosed with time, the whole half of the hemisphere you have to lose. And it is associated with epilepsia partialis continua. And there's a focal seizure is going on. And this is the seizure where early steroid or IVIG can help the patient. Usually the patient can present like this. Half of the body, you just see half of the body is jerking. Every time, 24/7, it is jerking, jerking, and jerking. There is a slow cognitive decline, hemiparesis. It is due to an autoantibody against glutamate 3 receptors. Other autoantibodies are like AMPA, LH1 are coming, and hemiaspherectomy or IVIG and steroids in early stage is the treatment of choice for this type of patient. Always half of the body is jerking and jerking and jerking. This is known as epilepsy partialis continua. You do a MRI. If your MRI is like this, half of the brain is hemiatrophic, then Rasmussen encephalitis is used to diagnosis. Now the Lennox-Gastaut syndrome. 2 more syndromes only. One is Lennox. So what is this? This is one of the dreaded epileptic syndrome where the prognosis is very, very, very bad. And how do we reach to the diagnosis? Just see this. Tonic axial spasms, atypical absence, atonic astatic, mentally retarded, cognitive impairment there, and in this syndrome and without any effects. Yes, their latest treatment is coming down, but due to short time, I will just see some videos like this. Like this atonic seizure. How do you diagnose? Multiple type of seizure. Atonic seizure, just watch. Yes. So this is atonia. If this seizure and this seizure, yes. So every time there is a jerk and the patient falls. There is loss of tone and the patient falls. And if both of them are present, there 99% of severity of the child that he is suffering or she is suffering from Lennox-Gastaut syndrome. And lamotrigine is a drug which is very much helpful in this. If you are having this, the EEG is 1.5 to 2.5 hertz slow and spike wave activities. That is for diagnosis for LG syndrome. Now we have got 2 important things, just the last 2 slides. That this is the latest epileptic syndrome we are having. So anytime if a guardian or patient party comes to you, say that my child was very good up to 6 or 7 years of age, and now he started having a cognitive decline. And what are the symptoms? There is any other seizure type like clonic or partial or CPS. Think about this very particular entity. Why this is important? Why this is important? Just let me show you. This is normal EEG waves of stage 3 and stage 4, where the slow wave. What is slow waves? These are the slow waves. These are slow waves is imparting 20 to 50% in 3rd stage and more than 50% in the 4th stage. And why these slow waves are important? Because this is the stage where whole of the consolidation of your memory part is coming in your brain. So whatever you learned, if you have not slept, you are not able to consolidate. So 8 hours sleep is very much important. That is said in our mythology also. So why this is important? Here is the cause. The slow wave sleep is very much important for the consolidation of the memory part and the cognition. But what happens in this type of epilepsies? Suddenly the child has learned so much thinking up to 6 or 7 years of age, and then multiple type of cognition like memory or making figures or walking or cycling or playing something. is being declined. He is not able to do the learned activities. So why this is happening? Why this is happening? Just you have to learn. If you see in the awake EEG, there is nothing is coming. Only thing, only diagnostic tool is that a sleep EEG. So in this sleep, when we used to do the sleep EEG, you would find all the slow wave of third and fourth stage of the sleep has gone and is replaced by a spike and wake activities. So when the brain have to take a rest by the slow wave activity, suddenly it has been changed to a spike and wake or seizure disorder. And then the brain was not ready to learn or concentrate anything. Even what has been learned is going to decline. So it is an acquired cognitive decline.
Please sum up, sir.
It is known as slow wave sleep and seizure disorder. And
Please
one
sum
variety
up,
of
sir.
this is known as Landau-Kleffner syndrome, where the seizure type is associated with acquired aphasia.
We are very
Whenever
late,
you
sir.
see a patient which is having an acquired type of aphasia associated with any seizures, that means he was all right before 6 or 7 or 8 years of age. Suddenly the language part is gone. And then other leading questioners said, yes, he is having some type of seizure, which may be partial or atypical absence. Then think about this very particular entity. Have a nighttime EEG record. You will have a spike of wake activity in third and fourth stage of sleep. And the best part is that the seizure will go automatically after 13 or 14 of age, but aphasia remains. If you started the treatment in the form of steroids or IVIG, it is very good. But certain drugs like phenytoin, phenobarbital, carbamazepine should not be given in this type of acquired aphasia and the seizure syndrome, because it can worsen the effects. Valproic acid is good enough to control apart from the immunomodulator therapy. So
Sum
what
up,
is
sir, please. Yeah.
epilepsy in childhood is wide spectrum, benign and complete remission is can be there. Syndrome, we have to know proper treatment and prognostication is good. But in encephalopathy, you have to beware of the fact that your current treatment schedule cannot treat this patient. So you have to go for the further referrals and the surgical treatment it can have. And then a good independent thank you to all of you who have
Thank you, sir. Thank you very much, sir.
carefully and cautiously.
Thank you.
Thank you, sir.
For excellent talk.
And
Thank you, Sanjay, for the wonderful
any question and query?
Any question and queries will be sent in the chat box, Sanjay, and we'll let you know if there are any. But it has been so beautiful and elaborative that I don't think there is any questions because of the videos as well. And the next, I would like to hand over Dr. Sri Mohan Mishra as the moderator. And the next speaker would be Professor Dr. Arvind Kumar, the noted cardiovascular surgeon, who is a guest speaker today. So over to you, Dr. Sri Mohan Mishra, sir. Kindly start the session.
Okay, thank you. Dr. Rajiv, as per schedule, the next lecture of Dr. Professor Pavan P.K. Agrawal.
I have told him already, Dr. P.K. Agrawal. Dr. Sanjay has some emergency work.
Oh,
yeah.
Okay. Dr. P.K. Agrawal is not here.
No, he's
I have
after
told
him.
him. Yeah.
Dr. Pramod will talk
After him, he will join.
We'll now talk.
After lecture of Dr. Arvind Kumar, na?
Yeah.
Yes.
Just without loss of any time, I just want to request Professor Dr. Arvind Kumar sir to kindly start his deliberation. And his topic is very important for our day-to-day life and for the future. Dr. Arvind Kumar sir, kindly start your lecture. And I want to request our chairpersons to kindly join with us. And chairpersons for this are Dr. Govind Kumar, Dr. Ahmed, and Dr. D.K. Sinha. They are here or not?
Sir, may I request you to please bring Dr. Shailendra Kumar sir? Sir is already there.
Yeah, I am here.
Why not? Why not? He can join as chairman. There is no problem. He is my friend and now the chairman of Bihar chapter. There is no problem. Dr. Shailendra, kindly start. And Dr. Govind Kumar sir.
Very original topics.
Very relevant topic.
I am eager to hear him.
Yeah, definitely.
Please start.
Well, distinguished chairpersons, distinguished delegates, a very warm good evening and namaskar to all of you. First of all, my very humble, sincere thanks to BAPICON and particularly to my dear friend Dr. Rajiv Ranjan for this not only very kind invitation, but also for putting this very unusual topic amongst very brainy topics, on dyslipidemia. So there was cardiovascular, there were neurological, and suddenly we moved to environment. So I will bring you very freshness and change. And let me just put my time clock so that just give me a second. I will restrict to time 20 minutes. I'll finish in less than 20 minutes. So why have we kept this topic? So first of all, I bring you greetings from Medanta, the Medicity, where I moved about 6 months back as chairman of chest surgery. And I also bring you greetings from this most loving affair of my life, the Lung Care Foundation, which is an NGO working in the area of clean air, climate actions, and improving the lung health of people. It's a pure non-commercial activity where we do a lot of activity related to air pollution and not now climate change also. Why has this topic been kept in this conference? The answer is very simple, that it's a very, very important topic today, and the coming few years are going to decide whether the human race continues to exist on this planet or becomes a fossil like dinosaurs. This sentence may sound very abnormal to you today, but I'll explain to you why it is true. So first, what is climate change? Climate change is a systematic change in the long-term state of atmosphere over multiple decades or longer. Now, what has caused this climate change? Why there is so much of talk about? The changes which are being observed in the Earth's climate are primarily driven by our own human activities. And if you were to enlist the various human activities, it is the fossil fuel burning. And by fossil fuel, I mean all the liquid as well as for solid fuel. Solid fuel is coal and wood, and liquid fuel is various petroleum products. Now, unlimited use of coal, wood, and petroleum products has released mammoth amounts of greenhouse gases into the Earth's atmosphere, thereby causing the climate change. Now, this picture actually is most important because it illustrates what is really happening. So when just concentrate on the left side photo, this is natural greenhouse. Sun releases a lot of energy which comes in the form of solar radiation towards our Earth. Now, Earth, we have this atmosphere, and then we do have some amount of greenhouse gases which are present, and the major gases I have listed on the left hand side. So what happens is that this radiation comes in, but it actually escapes. It comes in, but it escapes back because a thin layer of these greenhouse gases, it allows the heat to escape out. It does not trap the heat. So there is less. So the heat comes into the Earth, it goes back, and there is no resistance to the going back. So it comes, it is re-radiated back into the outer space, and that's how our temperature is maintained. Now, please come to the right side drawing. When there is too much of these greenhouse gases, which mainly consists of carbon dioxide, methane, nitrous oxide, ozone, chlorofluorocarbons, and water vapor. When a huge envelope of these gases is present outside of atmosphere, as is the case today, the solar heat which comes in, but when it is to be re-radiated back, this layer does not allow this heat to escape back as was happening normally. So more heat is trapped back and this is exactly what is leading to rise of temperature. So there is not extra heat being produced by the earth inhabitants. The heat of the sun which is coming in, which used to go back into the outer space, is not going back because of this thick layer of greenhouse gases, and this is what is leading to the climate change. So it is unequivocal that human influence has warmed the atmosphere, the ocean, and the land, and there are widespread and rapid changes in the atmosphere, in the oceans, in the cryospheres and biosphere. And the saddest part is that human influence has warmed the climate at a rate that is unprecedented, at least in the last 2000 years. So what we did not see in thousands of years before industrialization, more than that change has taken place in the last 100 to 150 years. How do we know that this climate change is happening? Well, if you look at so there is a rise in temperature. The planet's average surface temperature has already risen by 1.18 degrees Celsius since the late 19th century. A change which is largely driven by increased carbon dioxide and methane which is present into the atmosphere. And why is it happening? Because the human activity is increasing more than 250 times rise in CO2 level than it did from natural sources. So during the ice age and during the earlier years of human civilization, there were various natural events which used to occur, which also used to release the CO2, but we had a huge forest cover, huge number of trees, a small amount of CO2 was released, and that CO2 used to be absorbed by these natural absorbents, and there was no rise in the level of CO2. But what has happened in the last 100 years, there has been a rapid deforestation and there has been a huge mammoth increase in the levels of CO2 being released because of our activity. Now, this is a graph which shows the level of CO2. This is about thousands of years ago. So people have done these scientific calculations and they have written that up to about 1950, this CO2 level remained below a certain level. And this was the level in 1950. But just see whatever was the variation in thousands of years between 1950 and 2020. In just 70 years, just see how steep increase in CO2 has occurred. And if we look at the temperature, you see this was the average temperature for the last thousands of years. And you just see between 1850 and 2020, there has been a steep rise in the temperature. And the saddest part is that this steep rise is rising and is expected to rise by about 3 degrees centigrade, which is going to have huge and very, very dangerous effects on us. So global warming of 1.5 to 2 degrees centigrade will be exceeded during the 21st century unless we take measures today and cause deep reduction in the carbon dioxide and other greenhouse gas emission. Now, whom is it affecting? It is affecting our environment where the temperature is rising. It is also affecting the oceans. And as you know, about 3/4 of the surface of Earth is ocean. So ocean temperature is also rising. There has been a 0.3 degrees Celsius rise in the ocean temperature in the top 100 meters since 1969. And since more and more CO2 is getting dissolved in the sea water, so there is acidification of the sea water, which is increased by 30% in the last few decades. Now, that's not all. A huge amount of melting of ice is occurring. So one example, Greenland, which used to be covered with ice, has lost billions of tons of ice, and Antarctica. Now, these used to be two massive pools of ice on Earth, And now these massive pools of ice are melting because of the effect of rising temperature. And glaciers are retreating almost everywhere, in Alps, in Himalayas, in Andes, in Rockies, Alaska, Africa. Human influence is very likely the main driver of global retreat of glaciers since the 1990s. So, sir, the atmosphere is warming up, seas and oceans are warming, oceans are getting acidified, our glaciers are retreating, the ice packs are melting, and most alarmingly, there is a rise in the mean sea level because of melting of the ice in Arctic. There has already been a rise of 0.2 meters between 1900 and 2000. The average rate of sea level rise was 1.3 millimeter per year between 1901 and 1971, which increased to 1.9 millimeter per year between 71 and 2016. And very horrifyingly, this from 1.3 to 1.9, and between 2006 and 2018, it increased to 3.7 millimeter per year. And it is expected that in the next 10 years, this rise is going to be even faster. Now, this will lead to massive rise in the sea levels, and this is going to absolutely demolish more than 30 major metros across the world, including Shanghai and Mumbai. Now, this is a graph which shows that the sea levels are continuously rising. And apart from the rise in the temperature of the atmosphere, rise in the temperature of the oceans, acidification of oceans, melting of ice in the Arctic, retreating of glaciers, and other effects, there have been extreme weather events. Over the past century, there have been distinct geographical changes in the total annual precipitation, with some areas experiencing severe and long-term drought and others experiencing massive rains. And the severity and intensity of all these is increasing. Now, these large-scale global changes are resulting in what we call as weather and climate change. So what is happening? The temperatures are rising. All of you must have read that Europe this year had temperatures going up to 47, 48. So there is wetter areas are getting wetter, dry areas are getting drier, hot areas are getting hotter, and there are more frequent and extreme heat events. There are droughts, there are rains, there are cyclones, there are floods, there are tides, and of course the air quality is worsening. So ladies and gentlemen, if you look at the magnitude of this problem, climate change is the biggest global health threat of the 21st century. I will not be wrong in saying that all the diseases that we discussed during our entire MBBS, MD, or DM career, if we were to put all those diseases together and put consequences of climate change on the other side, the palra will be bhari on the side of climate change and its consequent action. So there will be injury, illness, and death due to extreme weather events. There will be increase in cardiovascular and respiratory diseases due to increased allergens and pollution. There will be, so the effects will be on the health, on the food security, on the geography, on the topography, on the seas and oceans. So look at this. Food and water insecurity will be there, which will lead to reduced crop yield and poor quality water sources resulting from changing weather patterns. There is expected to be a very, very serious increase in vector-borne diseases, and lot of other physical and mental health problems will come. And this will affect rural areas, small towns, big towns. Basic necessities will be disrupted. Food supply will be affected. Air will become polluted. Water will become polluted. Vector-borne diseases will increase. Overall, there will be millions of additional deaths every year because of various reasons. The rising temperatures are going to lead to massive heat stroke problems, aggravated respiratory and cardiovascular problems. They are going to lead to a lot of mental health issues because of the extreme weather events, and the poor air and water quality is going to affect every possible system in the body. And as I said, there is expected to be an epidemic of vector-borne diseases, and there is also a predicted more pandemics due to viral diseases will come, which one of which we are already going through, but in times to come, we will see more such pandemics. And ladies and gentlemen, if you just flash back over the last 2 years, now these images which are going to I'm going to show, you will realize there have been a spate of wildfires across the world. Today, there are major wildfires in at least 20 countries across the world. This is an example of a wildfire in Turkey, which has affected over 20,000 hectares of jungle. Australia, you know, millions of animals died and millions of hectares of jungle was lost because of wildfires in Australia. Same thing today is happening in Greece. It is happening in Turkey and in California, and it is happening in Amazon rainforest. The Amazon rainforest has a huge importance because this is supposed to be the carbon sink of the world. Because of the forest, the carbon is supposed to be extracted here. And if this forest goes on fire, you can imagine the consequences. All of us know how cyclones have been hitting our country, whether it was Tokte or it was Yas. So many cyclones are coming. Places like Germany, which had never seen floods ever in their history, the cities are now becoming like rivers and boats are running across the city. China faced massive floods. Our country, of course, you all know how badly Uttarakhand has been affected, how badly Himachal has been affected. All of us know what happened in Kinnaur just 4 days back. More than 50 people are still supposed to be trapped under the landslide there. Kedarnath, all of us know how thousands of people died. Just stop for a minute and pause. Why are all these activities happening? Why are mountains coming down in massive landslides so regularly? Why there are so many flash floods occurring regularly in all mountains? Why there are so many cyclones? Why there are so many jungle fires? All this was happening once in few decades, till few decades back, but today it is happening regularly and it is happening across the world. We all know this girl, Dr. Deepa Sharma, who was a nature lover who lost her life due to landslide in Kinnaur. So ladies and gentlemen, I would summarize by saying that climate change is real, number one. It is a massive, massive threat to human existence. It is not a health threat. Health is going to be affected. Food security is going to be affected. Our habitation is going to be affected. Our ecosystems are going to be affected. And when all these are affected, ultimately human existence is going to be affected. I would not be wrong in saying that since the time of human civilization, I don't think there has ever been a bigger threat to human existence ever than this demon of climate change. And the sad part is, if I ask this question, are we prepared for climate change? The answer is no, we are not. What is supposed to be done to reduce or stop climate change? What is the cause of climate change? The cause of climate change is unrestricted use of fossil fuels, which release massive tons of carbon dioxide, methane, basically carbon. And this involved energy sector, our powerhouses, the transport sector, the food sector, the industry sector, the agriculture, and numerous other sectors. So friends, the answer also lies in the problem. The problem is fossil fuel use, and the answer also will come from stopping the use of fossil fuel and shifting to renewable green sources of energy, whether it is our powerhouses, transport, food, industry, agriculture, solar, wind, and water energy will have to be harnessed as the main source of energy. The good news is the technology is there. It's not very expensive. It's getting cheaper day by day. All the science that is needed to be there to implement it is there. All that is missing is a mindset and understanding. It is not a question of should we do it or not. It's a question you have to do it. If we continue to use fossil fuels, the day is not far when human race actually will become fossils. We have, as a part of Lung Care Foundation, we started this activity called Doctors for Clean Air, because I feel that as passionate individuals who are seeing the health effects of air pollution and climate change every day in our practice, we are motivated, number one. And when we talk to people in general, they listen to us because it's a health issue. So we are in a better position to motivate people. So I call doctors as motivators to talk to public at large about the issue of air pollution and climate change. And that's why we started this Doctors for Clean Air, to spread awareness amongst the people, to bring about awakening in them, and to request them that the time to take the action was actually yesterday, but we missed it. We must not miss anymore, and we need to do it. And I'm happy to inform you that over 20 national medical associations, including the national API, 40 plus senior doctors, over 2,000 plus doctors have already committed to work for this across. We are trying to spread this to every state, every city, every village, everywhere. My dream is that every doctor should actually become a dooth to talk to people about the problem of air pollution and climate change. So I would summarize by saying that climate change is the biggest global health threat of the 21st century. And we, the doctors, are an important and a very powerful voice which can inform people about the reality, which can tell them about the magnitude of the problem and exhort them into doing actions which need to be taken to make a difference. All that we need to do is we all commit that yes, it's our duty. We are motivated motivators. We shall do it. We have to do it for the sake of our next generation. If we all join hands, I'm sure we can make a difference. Although it is late, but it's never too late. And I would end by saying that I am a stubborn optimist. Stubborn because I know it's a difficult problem. We are faced with various powerful commercial lobbies. But as doctors, if we decide it's a question of human existence, it's a question of our future generations, we have no choice but to do it. And if we all get together, I'm confident that, friends, we can make a difference and we can give a better future, a better Mother Earth to our future generations. Dr. Rajiv Ranjan and colleagues, thank you very much for giving me this opportunity to address you, and I wish BAPICON all the success. Thank you very much.
Thank you, Dr. Arvind Kumar, sir.
Thank you, sir.
Very nice and very motivating topic. Your topic has changed our vision regarding the environment and climate changes. I am also very much interested in these kinds of topic, since we see a number of cases of COPD due to the environmental changes and air pollution. I think your appeal must be accepted by all of us, and we must join your movement of this Lung Foundation. Thank you.
Thank you.
Now, without delay, I want to call Dr. Professor P.K. Agrawal. He is professor in Katihar Medical College, and fortunately, he is also resident of Muzaffarpur.
I have one query from Dr. Arvind, that how can we become a part of your Doctor for Climate? If we want to do an activity of your drive, then how can we become a part of your mission. Please tell 2 lines about that also, if you are hearing me. Okay, he is offline.
He is off. Dr. Agrawal, kindly start your presentation. Very important and very relevant topic, that is HIV and hepatitis B. Dr. Agrawal, kindly start your topic. Dr. Sailendra?
Yes.
Good evening, everybody. First of all, happy Independence Day to you all. I have been assigned to talk on two important diseases, HIV and hepatitis B virus, when come together. ये move नहीं कर रहा है. When come together, it's called a double trouble. We see in recent years, the management of HIV or AIDS has undergone a revolution. There was a rapid and dramatic decrease in mortality associated with opportunistic infection that complicate advanced HIV infection after the introduction of HAART. Since the emergence of vaccination of infants for hepatitis B, the incidence of chronic hepatitis has declined tremendously. Both hepatitis B and HIV share common modes of transmission. There is increased prevalence of HIV and hepatitis B virus co-infection. Hepatitis B infection is more frequent and more severe in HIV patients. The progression to cirrhosis and end-stage liver disease is more rapid than in those not HIV infected. Co-infection of HIV may cause reactivation of hepatitis B in surface antigen antibody patients, especially in immunocompromised people. One of the most frequent cause of non-AIDS related death in HIV patients is liver disease caused by hepatitis B. Weber et al. did a study in 2016, included nearly 23,000 patients to know the cause of death in HIV infection. And he concluded liver-related disease accounts for more than 50% non-HIV related death in HIV infection. Since transmission routes of hepatitis B and HIV are more or less similar, as for example, sexual contact, mother-to-child transmission at birth, parental like blood to blood, and though other infected body fluids, so there is high frequency of co-infection of HIV with hepatitis B. Worldwide, nearly 10% of HIV infected population also infected with hepatitis B. It is expected to be higher, approximately 20% in Southeast Asia, 5% in North America and Western Europe. Higher rate of co-infection of hepatitis B and HIV has been observed in men having sex with men than heterosexual or injecting drug users. Prevalence of Australia antigen has been observed in HIV-infected Indian population is nearly 2 to 14%. Another studies indicate approximately 22% and 30%. This shows quite high frequency. This variation in a study, most probably due to a small sample size, data multi-center studies, and unavailability of multi-risk group data. Thus, in India, overall epidemiological trend remains obscure. According to NACO, in 2017, national adults that included 50 to 49 years of age, HIV prevalence in India is estimated to be at 0.22%. Total number of patients living with HIV is estimated at 21 lakhs. India is estimated to have nearly 87,000 new HIV infections in 2017. According to Journal of Clinical and Translational Hepatology, it is estimated that about 200 crores of worldwide population have been exposed to the hepatitis B virus, of whom 350 million harbor it chronically. India falls in the intermediate endemicity zone, that is the prevalence of 2 to 7% with an average 4%, with a disease burden of about 50 million. Out of 36.7 million people living with HIV globally, 2.7 million people also had hepatitis B virus infection, nearly 10%. If we go through the pathogenesis, we all know hepatitis B is an immune-mediated infection. Interaction of the virus and the host immune system leads to liver injury, progressing to cirrhosis and hepatocellular carcinoma. HIV weakens the immune system by infecting and destroying CD4 T cells, which leads to immunodeficiency. HIV attached to the CD4 protein on the surface of these and other cells to gain entry. Hepatitis B virus, more or less 100 times more infectious than HIV. The risk of chronic hepatitis B is greater in cases of hepatitis B virus with HIV co-infection. It is demonstrated that the co-infection of HIV with hepatitis B virus mortality due to liver disease is 19 times more than of the hepatitis B virus infection alone and 8 times more than in persons with HIV infection alone. Mortality increases in individuals with CD4 T cells, lower CD4 T cells. Since we know hepatitis B is an immune-mediated infection, liver inflammation is minimal in uncontrolled HIV. After the initiation of highly active antiretroviral therapy, there is immune reconstitution leading to more liver damage. There are higher hepatitis B virus DNA levels, lower serum LT, more liver fibrosis, and more risk of end-stage liver disease in the patient with HIV with hepatitis B virus co-infection. Although healthy adults who are infected with hepatitis B virus has less than 10% chance to develop into chronic hepatitis B, when an HIV positive adult is infected, the risk goes up to 25%. CD4 restoration is less than satisfactory in response to heart disease. Come over the treatment. In general principles, patients with HIV and chronic hepatitis B infection should receive treatment to suppress both the viruses, regardless of hepatitis B virus DNA level or degree of liver. We must not consider the level of hepatitis B virus DNA. First goal of clinician is to select the patient whether to treat for HIV alone, hepatitis B virus alone, or both the virus. For patients having HIV or HIV with hepatitis B virus, the treatment endpoints remains the same. Although loss of E antigen or surface antigen, as well as seroconversion to antibody to E antigen or antibody to surface antigen is not common. The treatment must include agents active against both the viruses, that is against HIV and hepatitis B virus both. Not doing so will lead to emergence of HIV strains that are resistant to NRTI. The recommendation from the recent USA and Europe guidelines advocate the use of 2 anti-hepatitis B virus drugs as part of HART in hepatitis B virus and HIV co-infection. The aim of this combination therapy is to decrease the development of resistance, even though very little data exists on either mono or co-infected patients with such therapy. For most patients, we administer a regimen that includes tenofovir. Tenofovir is effective for the treatment of hepatitis B virus in both treatment naive and treatment experienced patients. That is, those who have received lamivudine, emtricitabine, or inticabine, including those with lamivudine resistant hepatitis B virus. The preferred treatment for dual hepatitis B virus HIV co-infection is a combination of tenofovir with lamivudine or emtricitabine. Inticabine may be suitable alternative in select setting when tenofovir should not be used or may not be ideal, that is with the side effects of the tenofovir, as for example, severe osteoporosis, certain drug interactions, eGFR less than 15 milliliter and not on hemodialysis. However, if inticabine is used, then it must be administered in conjunction with a fully active ART regimen. Since inticabine, although partially active against HIV, lacks significant biological potency and can lead to development of HIV drug resistance mutation M184B. For patients who have suppressed hepatitis B virus DNA or who have a detectable hepatitis B virus DNA level with less than 1 lamivudine resistance mutation, we administered inticabine at the dose of 1 milligram per day instead of 0.5 milligram per day with fully active ART regimen. For those with multiple drug resistance mutation, tenofovir remains the preferred choice for the treatment of hepatitis B virus. And the reasons for not using tenofovir must be reassessed. Removal of hepatitis B virus therapy or change in HIV therapy for virological failure may lead to rebound hepatitis. Hence, on changing ART, always consider HIV therapy with activity against hepatitis B virus. Certain patients require change in their HIV regimen. Reasons include adverse reaction to the ART regimen as well as detectable HIV RNA with HIV resistance mutation. Tenofovir should be continued for the treatment of hepatitis B virus when changing the HIV regimen. For patients with the drug-resistant HIV, other suitable agents should be added to active HIV suppression. If tenofovir cannot be used, another fully active hepatitis B virus agents such as entecavir must be used in conjunction with fully active HIV ART regimen. Latest studies suggest that despite faster decline of antigen level on addition of pegylated interferon for the treatment of hepatitis B virus, active ART E antigen positive co-infected person, E antigen or surface antigen clearance did not increase. Tenofovir alafenamide is now available with comparable efficacy to tenofovir but with reduced toxicity. Other new antiviral agents like hepatitis B virus inhibitors are currently in development. Even after surface antigen seroconversion, cessation of hepatitis B virus active NRTI is safe or not remains unknown. Most patients with HIV and hepatitis B virus co-infection will receive indefinite treatment for HIV and hepatitis B virus. This is based upon the chronic nature of hepatitis B virus infection and that patients with HIV require lifelong antiretroviral therapy. Come over the vaccination part. On post-exposure prophylaxis, hepatitis B immunoglobulin should be given. It is best administered in first 24 hours, but it can be given up to 7 days after percutaneous or permucosal exposure and should be given within 14 days for post-sexual exposure, followed by hepatitis B vaccine series. Vaccination against hepatitis A and B should be given to all HIV patients who are not immune. In HIV positive patients, the immunogenicity to hepatitis B virus vaccination is decreased. That is reflected by lower antibody titer, gradual waning immunity, and seroconversion rates of 18 to 65%. Response to vaccination is poor in HIV patients, especially in those with lower CD4 count. These individuals poorly maintain the antibody titer after vaccination. You may consider increase the dose, that is double the dose of the hepatitis B virus vaccine for adequate response. 1 month after the completion of vaccine schedule, antibody to surface antigen titer should be checked. Patient with antibody titer less than 10 international units per milliliter, a second vaccine cycle is recommended. Improved response may expect with higher CD4 count and undetectable plasma HIV RNA on doubling the hepatitis virus vaccine dose. To conclude, liver is frequently affected in patients with HIV. HIV hepatitis B virus co-infection shows more rapid progression to end-stage liver disease and liver fibrosis. Since both HIV and hepatitis B virus share common modes of transmission, so the incidence is high with co-infection. With improved control of HIV disease with heart, liver disease has emerged one of the leading cause of death in patients with HIV. For the treatment of HIV hepatitis B virus co-infections, agents selected should be active against both the viruses if either HIV or both HIV hepatitis B virus infection meet the criteria for therapy. Complexity of this hepatitis B virus HIV co-infection highlights the importance of close working relationship between the hepatologist, infectious disease specialist, and family care providers in order to optimize the patient outcome. Thank you. Thank you for your presence here.
Very in-depth presentation, sir. One line question from my side. If hepatitis B virus does not meet the criteria for drug treatment and there is coexistence of HIV infection, we should give hepatitis B virus drug or not?
We should continue the hepatitis B virus drugs to lifelong because it has been seen when you stop hepatitis B virus drugs, this hepatitis B virus again reactivates. So we should continue in practical, we should continue both the drugs for hepatitis B virus and HIV.
But in hepatitis B virus treatment, there is already criteria that after becoming seronegative, you should not stop suddenly. There is a criteria that you should follow up.
This is applicable if there is only one hepatitis B virus infection. When it is co-infected with HIV, we must continue the drug that is active against both the hepatitis B virus and HIV, particularly tenofovir. And we should give the combination of for HIV, we should give tenofovir, lamivudine, and in these days we include dolutegravir. This is the best combination we give.
Thank you very much. So now should we move for the next session? I think topics for this session are already covered. So mic over to organizer, Dr. Rajiv Ranjan.
Sir, next lecture will be of Dr. Indranil Haldar.
And chairperson is same.
Yeah. So everybody is a pulmonologist. I do expect. So
so next speaker, Dr. Chandranil Haldar.
Yeah.
Are you available?
Yeah.
What is the topic?
Challenges of extrapulmonary tuberculosis.
Oh, very important topic for our department. We always face this type of challenge day-to-day practice. So, Dr. Chandranil Haldar.
Yeah.
Topic is challenges in the diagnosis and treatment of extrapulmonary tuberculosis.
Yeah.
Get connected and upload your slides.
Dr. Rajiv, that will be played from your side, na?
No, Dr. Mishra, you are the chairperson.
It's a we are playing
for this topic also.
Hello.
हमको कॉल किया जाए.
It will take few seconds just.
Yeah.
Good evening, everybody. First of all, I should thank the organizers of the BAPICON, the 31st annual conference of the Association of Physicians of India, the Bihar chapter, and the organizer, the Chhapra API. Today, I'll be going to discuss on the pitfalls in the diagnosis of extrapulmonary challenges and pitfalls in the diagnosis of extrapulmonary tuberculosis. Myself, Dr. Indranil Haldar. I am the head of the Department of Pulmonary Medicine, College of Medicine, JNM Hospital, Kollani, under the University of Health Science. So, as defined by the WHO, the Global TB Tuberculosis Report 2013, extrapulmonary is a form of TB affecting any organ other than the lung parenchyma. In fact, in many cases, pulmonary and the extrapulmonary lesions are present in both of the patient, though it will be classified as pulmonary tuberculosis. And about the incidence of the extrapulmonary tuberculosis, it ranges about 9.3% in the 2013 report. So extrapulmonary tuberculosis contributes about 20% of all cases of tuberculosis. Diagnosing extrapulmonary tuberculosis remains challenged because clinical samples obtained from relatively inaccessible sites may have bacillus, thus decreasing the chance of detecting it through any of the established tests. Coming to the biochemical markers in tuberculosis affected serosal fluid, which includes, as we all know, the adenosine deaminase or the gamma interferon, and the molecular biological techniques such as the polymerase chain reaction may be useful adjunct in the diagnosis of extrapulmonary tuberculosis. So coming to the principles of diagnosis. When we suspect an extrapulmonary tuberculosis, every attempt should be made to procure some form of tissue or relevant fluid for diagnostic testing. The most accessible tissue should be procured either for histopathological, cytopathological, or microbiological diagnosis, and microbiological diagnosis, as we know, is the most confirmatory. We should take help of some modern radiological techniques, including the ultrasound, the CT scan, the MRI, or even upper GI endoscopy, colonoscopy, laparoscopy, and other invasive investigations such as hysterosalpingography and colonoscopy to have a precise anatomical localizations of the lesions in extrapulmonary tuberculosis. If there is no accessible tissue or fluid available for the analysis, we can go for a radiological guided fine needle aspiration cytology or biopsy to secure tissue for the diagnosis. So diagnosis of extrapulmonary tuberculosis is usually made with a significant delay from the time of presentations. It is simply because extrapulmonary tuberculosis is lately put upon into the differential diagnosis panel, and we are finding out some other cause. And many a times, clinical findings suffer from lack of specificity, and the result of the test assessing tuberculous infections, mainly coming to the tuberculin skin test or the interferon gamma test, may be misleading. In fact, to date, no form of extrapulmonary tuberculosis can count on reliable single rule-out test. The diagnosis is thus made often by integration of several non-specific clues from various investigations. So the development of newer diagnostics for the extrapulmonary tuberculosis is flawed by the absence of a true gold standard test. Whereas in pulmonary tuberculosis, we know that sputum for a acid-fast bacillus is a very good test, and we have a confirmation for the diagnosis. Now, there are molecular tests for pulmonary tuberculosis also. Now, if you go by the WHO definition for extrapulmonary tuberculosis, diagnosis should be made on the basis of one culture positive specimen, if it is available, or a positive histology, or if both of them are not available, strong clinical evidence consistent with an active extrapulmonary tuberculosis. So coming to the most important aspect of identification of mycobacteria by stain or by culture. We have the conventional smear microscopy. It has a low sensitivity. In these cases, a mycobacteria culture may help, and here the yield may be 30 to 80%, but definitely it takes some time, about say 2 to 8 weeks time. All suspected cases of extrapulmonary tuberculosis should be assessed for concomitant PTB to determine whether the case is infectious, because we have seen that about 10 to 50% of extrapulmonary tuberculosis has concomitant pulmonary involvement. Some EPTB patients have positive sputum culture result despite a normal chest radiogram. So it is prudent that we should always go for a sputum sample of pulmonary to detect pulmonary tuberculosis or pulmonary involvement, even if the chest X-ray is normal. And the sensitivity of sputum culture varies from site. For example, in abdominal tuberculosis, it ranges from 28 to 50. In tubercular pericarditis, 10 to 11%. In meningitis, from somewhere between 24 to 29%. And in tubercular lymph node, in about 5 to 14%. Bronchoscopic evaluation or sputum induction with nebulized hypertonic saline sometimes increase the yield and the diagnostic sensitivity. So in fact, this chart depicts us that there are a lot of misdiagnoses. In fact, meningeal tuberculosis is misdiagnosed as encephalitis, intestinal tuberculosis as some form of Crohn's disease, female genital tuberculosis as some can malignancies or even inflammatory pelvic inflammatory diseases, endometrial, sometimes misdiagnosed as endometrial carcinoma, and so on and so forth. In fact, extrapulmonary tuberculosis are sometimes asymptomatic and they are possibacillus, only a few bacillus in the culture, so it may be very difficult for us to diagnose. And also lack of sensitivity of existing diagnostic, that is gene expert sensitivity varies according to the type of specimen. Antigen is not applicable right now. There are many false positive and negative results, and some of the invasive investigation may sometimes be needed to find out the specimen. Coming to the point of care diagnosis, there is inadequacy of biomarkers are there. So ultimately, the remedy is, that is, a specific biomarker is necessary in some cases. Point of care diagnosis from easily accessible samples should be there, and ultimately improved sensitivity of the prevailing diagnostic should be there. So what are the tools in our hand for the diagnosing extrapulmonary tuberculosis? So the signs, symptoms depends upon the site of the extrapulmonary tuberculosis. For example, a lymph node will present as a swelling, sometimes there will be tenderness, sometimes there will be discharge. Abdominal tuberculosis may present with features of distension of abdomen, ascites, pain abdomen, so on. So coming to the procurement of biopsy for histopathological diagnosis, here the presence of granuloma, caseation, or a demonstration of the acid fast bacillus is commonly used to define a case of positive tuberculosis. However, because of loss of host immune function, can result in histopathological finding demonstrating greater suppurative lesions and less well-formed granuloma. So sometimes there are many pitfalls and we cannot get at the diagnosis even if a test is tuberculosis. So in general, tissue biopsy yields positive culture more often than fluid aspiration, and the diagnostic accuracy could increase further when the results are the biopsy and polymerase chain reaction assay are combined with those of culture. When the specimen is sent for examination, it should be sent both in formal saline and normal saline. The formal saline is used for the histopathological examination and the normal saline for the mycobacterial culture respectively. Coming to the body fluid examination. So tubercular pleural fluid is exudative with lymphocyte predominance in about 90% of cases. However, polymorphic nuclear cells may predominate in patients when the symptom is less than 2 weeks duration. There, so here a pitfall is there. Even with polymorphonuclear cells, it may be tuberculosis, especially when it is less than 2 weeks duration. Measurement of one of the biomarkers, namely the adenosine deaminase and interferon gamma, can be done. Later, the interferon gamma being less preferred because it is a costly and not easily available in most of the cases. Now coming to the molecular test, the nucleic acid amplification test, the major advantage of the NAT is, such as PCR, is because of its rapid diagnosis. A positive NAT result can be considered as a presumptive case, whereas a negative NAT cannot be relied upon to exclude the diagnosis. Not only that, when we go for molecular test, mainly the cartridge-based nucleic acid or the expert MTB, rifampicin assay, which is a novel automated cartridge-based and is commonly known as the CB-NAT, is considered useful for rapid molecular diagnosis of extrapulmonary tuberculosis and also tells us whether the mycobacteria is resistant or sensitive to rifampicin. Some of the meta-analysis has reported that the expert MTB RIF has an overall sensitivity of 83% and a pool specificity of about 97% for a diagnosis of extrapulmonary tuberculosis. Expert sensitivity differs substantially between sample type, whereas expert is highly sensitive for TB detection in lymph node samples, but it is moderately sensitive for detection of TB meningitis. The sensitivity is low for pleural fluid also. Immunological test. The commonly used are the tuberculin skin test and interferon gamma releasing assay, commonly called the IGRA. which may be some of the supportive methods for diagnosing extrapulmonary tuberculosis, but it has limited diagnostic value. Interpretation of the tuberculosis skin text reactivity may be complicated by cross-reactivity with previous BCG vaccination or latent tubercular infection. Not only that, factors like HIV infection, poor nutrition state, recent viral or bacterial infection, or vaccination with live virus can reduce the response of the tuberculin test. Like the tuberculin test, the IGRA cannot distinguish between latent and active tuberculosis or extrapulmonary tuberculosis, and negative result cannot entirely exclude the disease. So now just recapitulating some of the commonly encountered type of the extrapulmonary tuberculosis, and one of them is the tubercular lymphadenitis. So the enlarged lymph node are common in the cervical or the supraclavicular nodes. It may be unilateral, bilateral, and the preferred method still now used is the fine needle aspiration cytology. In addition to the acid-fast bacillus smear, culture aspirate should be subjected to the cartridge-based nucleic acid amplification test. For example, in mediastinal lymph node, a mediastinal biopsy can be obtained with the help of the EBUS or the mediastinoscope or the thoracoscope. And it is known that obtaining a proper specimen may not always be easy when it is in the abdomen or in the mediastinum. Fine needle aspiration cytology smears may show acid-fast bacillus in about 25 to 50% of specimen, and the organism may be isolated in up to 70% of in substances where tubercular etiology is considered. Smear with necrosis has a higher rate of positivity as compared to smear without necrosis. Now coming to the pleural tuberculosis, usually presents with symptoms of pleuritic chest pain, cough, and fever. Diffusion shows chest X-ray is usually small to moderate in size. Sputum acid-fast bacillus and culture should also be obtained. Chest X-ray may show no obvious parenchymal disease in more than 50% of patients with pleural tuberculosis. And if we assess the pleural fluid, it is usually exudative, lymphocyte predominance, and often has low glucose level. The adenosine deaminase is often elevated in pleural tuberculosis. Closed pleural biopsy is indicated when patient has a lymphocytic predominant exudative effusion. And in fact, the closed pleural biopsy has taken over by some other methods like the thoracoscope or the VATS, where the diagnostic yield is much more. Skeletal tuberculosis most often involve the spine, followed by tubercular arthritis in weight-bearing joints. The cold abscess, which are non-tender with sinus tract, may form later. The resulting anterior wedging and angulation of adjacent vertebral bodies with disc space obliteration produces the palpable spinal prominence, commonly called as the gibbous, and gives the classical radiological appearance. If skeletal tuberculosis is suspected, MRI, especially in the spinal involvement, or CT, is to be obtained. So if we have a cold abscess, we can aspirate to see acid-fast bacillus. CT-guided biopsy in vertebral tuberculosis will have positive microbiological or histopathological yield in 60 to 90% of patients. In sometimes synovial biopsy may yield culture positive in 90 to 95 and should be performed if the diagnosis of tubercular arthritis is in a suspension. In joint involvement, evaluation of synovial fluid is usually not diagnostic. WBC count in tubercular arthritis may range between 10,000 to 20,000, but can be much higher also. CNS tuberculosis usually presents with meningitis or intracranial tuberculoma. If we go to the CSF pictures, it shows lymphocyte predominance, elevated protein, and reduced glucose. However, atypical CSF findings are well described, particularly in immune-suppressed patients. ADA cutoff value of 8 shows a sensitivity of about 59 and a specificity of 96% in diagnosing tubercular meningitis. CT scan MRI of the brain may show edema, hydrocephalus, bacillar meningitis, thickening, or tuberculoma. For tuberculoma, CSF analysis is usually normal, and diagnosis is then solely based on the radiological imaging, CT or MRI finding. Abdominal tuberculosis include the peritoneal tuberculosis and the tuberculosis of the GI tract, CT of the abdomen, ascitic fluid analysis, and if possible peritoneal biopsy can be done. CT scan or radiology usually shows ascites, bowel wall thickening, or they may show abdominal lymphadenopathy, and if the lymph node is accessible for an FNAC, it can be done. Ascitic fluid as such may be non-specific, and rarely acid-fast bacillus is there. Sensitivity of culture of peritoneal fluid, high result required up to 8 weeks, but peritoneal biopsy is most often effective means of the diagnosis. Direct inspection may reveal miliary nodule over the peritoneum and allow a presumptive diagnosis in most of the cases. Biopsy may demonstrate caseating granuloma in the presence of acid-fast bacillus on examination. Colonoscopy and biopsy are carried out to diagnose tubercular enteritis. Colonoscopy will reveal ulcers, pseudo polyps, or nodules. Definitive diagnosis is based on the biopsy, which shows granuloma and culture positive on tuberculosis. Genitourinary tuberculosis, the symptoms include dysuria, hematuria, urinary frequency, and intravenous pyelogram may show the moth-eaten calyx, which is typical, or the papillary necrosis. Abdominal CT or urine analysis may be done. Urine analysis shows pyuria, hematuria, proteinuria, or they all may be normal. So if there is a pyuria which is sterile, that is superimposed bacterial infection may be present in patients with genitourinary tuberculosis, but a sterile pyuria is sometimes typically thought of tuberculosis. Urine culture for tuberculosis is usually positive in 80% of patients, and 3 samples for culture improve sensitivities to be sent. Nucleic acid amplification test of the urine can help the adjuvant tool for the rapid diagnosis of genitourinary tuberculosis, and the definitive diagnosis is by a tissue biopsy. Pericardial tuberculosis, chest X-ray shows cardiomegaly and pleural effusion, ECG low voltage. Echocardiography, the CT scan or MRI shows pericardial effusion and thickening across the pericardial space. If pericardial fluid is analyzed, it shows exudative with increased lymphocyte. Hemorrhagic effusion is seen. Acid-fast bacillus of the fluid is commonly negative, and culture may be positive in up to 50% of cases. So what should we conclude? Extrapulmonary tuberculosis is a complex disease. Diagnosis is difficult due to the paucibacillary state. An invasive procedure required to obtain an adequate sample in many cases. There is no single diagnostic test can be considered as a point of care. Microbiological tests need to be combined with the classical signs and symptoms and imaging techniques to improve diagnostic accuracy. Now with the advent of molecular test, which has improved the time of detection of disease and drug sensitivity, but they cannot replace the gold standard culture. Though the sensitivity of molecular test is high, specificity varies between samples from different sites. A combined reference standard is often used for TB evaluation, as culture reference alone is inadequate. But what is more important is early and accurate diagnosis is needed to prevent the associated morbidity and mortality. So thank you for your patient hearing.
Thank you.
So to sum up, there is a reasonable place for the clinical presentation here also, because all diagnostic modalities, whether biochemical, or whether histological, or whether molecular, are not very specific for extrapulmonary tuberculosis. But as for WHO guidelines, if there is a strong clinical sign and symptom and history pointing out toward extrapulmonary tuberculosis, then we should consider, because by such an astringent diagnostic criteria may diagnose less and miss more. This is my personal opinion, that clinical criteria must be taken into account while diagnosing extrapulmonary tuberculosis. Thank you very much for excellent presentation. Now this session is over and I hand over the mic to organizer, Dr. Rajiv Ranjan, to continue with the next session.
Next talk is by Dr. S.S. Sen. Hello.
Hello,
Yeah,
Dr. Rajiv.
On viral pneumonia. Yeah.
Viral pneumonia, approach to viral pneumonia.
Yeah.
I want to invite Dr. S. Sen. Kindly start your deliberation. Dr. S. Sen.
Are my slides visible?
Yes, definitely visible. Thank you.
Okay. Give me a minute. My full screen is visible, hopefully. Oh. Okay. Good evening to all of you. At the outset, I thank Bihar API to invite me for the 4th consecutive year for this BAPICON, and I am very glad because I am an ex-student of PMCH Patna to get this opportunity. I thank the chairman of API Bihar, Dr. D. Nath, the secretary, Dr. Sudhir Kumar, the chairman of scientific committee, Dr. Rajiv Ranjan, Dr. Rajiv Kumar Singh, the secretary, and the organizing chairperson, Dr. S. Vishwakarma. My topic is approach to viral pneumonia. These days, we are really treating viral pneumonia, but this was not a very important topic earlier because viral pneumonia was a bit neglected topic because we used to come across bacterial pneumonia as a dreaded thing. So with the advent of COVID, now this is very important. But I will not discuss only COVID. It's a huge topic, but I will try to go on my slides, but I will mention the salient points as quickly as possible because we are already 1 hour late. Suppose this is a case of previously healthy 54-year-old lady who was referred from a local hospital with progressive respiratory failure following a febrile illness of say 2 to 3 days, admitted to the ICU with respiratory distress. This was her X-ray and this is the CT scan. This is, I am talking about pre-COVID days. Blood counts were normal, mild renal failure. The patients were usually suspected to be having viral pneumonia and started on antivirals like oseltamivir, 150 milligram twice a day, and intravenous broad spectrum antibiotics, and supplemental high flow oxygen. Blood culture and urine culture had come out to be negative. The ABGs were suggestive of ARDS. The patient was intubated and mechanically ventilated, treated with these high spectrum antibiotics, broad spectrum antivirals, usually weaned off and extubated on 7th day, and there is clinical and radiological improvement. So this is a picture of viral pneumonia, and this is a syndrome which is caused by acute infection, is usually bacterial, but clinical and radiological signs of consolidation of a part or one or both lungs are indicative, and we have to focus on viral pneumonia. Why is it important now? Sir, anything you are telling me? Sorry, sir. Okay, should I continue, Doctor? Okay. The incidence of viral pneumonia has increased during the past decade, an increase in population of at-risk groups and patients who are immunocompromised. The recent advancement in molecular biology with the ability to amplify the multiple viral genomes like the PCRs and the RT-PCRs has let us discover many new viruses, and the severe acute respiratory syndrome coronavirus and the Middle East respiratory syndrome MERS coronavirus have been associated with regional outbreaks in the past and again could have re-emerged to produce outbreaks in the future. And that has what happened 2 years back with COVID-19. And this is a pandemic caused by a virus of the same family that caused SARS in 2002 and MERS in 2012. See, the etiology of viral pneumonia is so huge. There is a huge list. The respiratory syncytial virus is the most common cause of viral pneumonia in small children and infants. Rhinovirus is the most common cause of upper respiratory tract infection in all age groups. Now you are aware of the influenza viruses, particularly A, B, C, and the two concerning subtypes of influenza are the avian flu, that is H5N1, and swine flu, that is H1N1. There is a huge list of viral pneumonia etiology, and most virus can cause viral pneumonia. including the very well-known varicella zoster virus too. There are some viruses which has not invaded our continent till now, like the hantavirus, which causes frequent rapid respiratory failure and cardiovascular collapse. And other certain viruses like CMV, HSV, Epstein-Barr, measles are all important. As I mentioned, the SARS in 2002 and later the MERS, which are all variants of the coronaviruses, has shown there are emergence of new virus infections, and the availability of molecular diagnostic tests like the PCR and the RT-PCR for the RNA viruses is very much important to detect them. Then came COVID-19. As you all know, COVID-19 is coronavirus disease. It was identified in the year 2019. In this disease, people might be sick for the virus for 1 to 14 days before the developing of symptoms. The most common symptoms are fever, tiredness, and dry cough. As with any viral pneumonia we used to come across before the advent of COVID-19. And most people, around 80%, recover from the disease without needing special treatment. And also, compared to the previous SARS and previous MERS, the breakdown of deaths by age has shown that though the mortality is not so high, but because of the pandemic and huge number of people are affected, millions of people are affected and lakhs of people have died. So COVID-19 is something to us, and so viral pneumonia is important. Usually in epidemiology, viral pneumonia is most common in the very young and elderly, and if there is related immunosuppression like chemotherapy or radiation therapy, treatment of chronic inflammatory illnesses with immunosuppressive therapy, history of organ transplantation, acquired immune incompetence secondary to HIV, and inherited diseases of diminished immune competence has increased the susceptibility to viral pneumonia. The comorbidities which are associated with viral pneumonia are usually trauma, severe burns, uncontrolled diabetes mellitus, malnutrition, poverty, environmental exposure, and living in groups. The 2009-10 H1 influenza pandemic was more common in the population ages 5 to 59 years than the elderly, could be due to the lack of exposure and the similarity to the previous H1N1, that is in 1957 strain. Now the swine flu came out as a big thing, and in the spring of 2009, the scientists recognized a particular strain of the flu virus, that is H1N1, which is actually a combination of viruses from pigs, birds, and humans. Usually, occasionally, pigs transmit the influenza viruses to people, so the swine flu came out to be important. During the 2009-10 season, the respiratory infections in humans were huge, and WHO in 2009 declared it as a global pandemic. And in 2010, in a year, it was controlled. Since that time, scientists have changed the way they name the viruses. Now, the H1N1 virus is known as the H1N1V. V stands for variant and indicates that the virus normally circulates in animals, but has been detected in humans. Since 2011, another strain, H3N2V, has been circulated in humans, and both strains are now included in the annual flu vaccinations we give since 2018-19. As you all know, antigenic drift and antigenic shift are very important in the treatment of influenza pandemic, or when the influenza virus comes every year in a cycle. Antigenic drift is a gradual, continuous, ongoing process that results in the emergence of new strain variants, while antigenic shift is a sudden, abrupt change in the antigen by which a novel strain of virus is evolved, which acquires the capability of infecting human beings. And this antigenic shift is usually associated with pandemics. Usually, there is no pathognomonic history for the diagnosis of viral pneumonia as opposed to bacterial pneumonia. There is also no pathognomonic physical examination too when we can identify both of them. Similarly, some symptoms of COVID-19 are common to most viral illnesses like cough, sore throat, fever, running nose, sneezing, fatigue, and difficulty in breathing when pneumonia sets in. So the evaluation is very important. Not only history and physical examination, because that does not give much of a cue, but fortunately the diagnostic accuracy of the laboratory examination in combination with radiography and both history and physicalization combined gives us a clue. The CBC and differential is very important. Usually with pyogenic pneumonia, it's different. Chemistry panels helps us in knowing the liver functions, the renal functions, the electrolyte levels. As a reactive phase reactant, the CRP level is usually elevated in viral pneumonia, though it's not very sensitive or specific. But when procalcitonin is increased, we usually think of bacterial pneumonia, and repeatedly low amounts suggest that the bacterial infection is unlikely. So in viral pneumonia, we'll get a low level of procalcitonin. Now to diagnose. How to diagnose? Usually by rapid antigen detection is very important. ELISA methods of enzyme-linked immunosorbent assay can detect viral antigens, while an immunofluorescence assay requires the presence of prepared, intact, and infected cells. Now, the ELISA rapid antigen tests are available for herpes simplex virus, respiratory syncytial virus, influenza A, B, and also cytomegalovirus. And these are very important because gives a quicker result. And there are some disadvantages also, that the overall sensitivity is lower. Like nowadays, the rapid antigen test for COVID-19 is also very important. The SARS-CoV-2 is now also recognized by the rapid antigen test. And the gene amplification techniques like the PCR and methods are very important for CMV, respiratory syncytial virus, HPV, and coronaviruses. For influenza H1N1 and the avian influenza, RT-PCR of either nasopharyngeal swabs or bronchial aspirates or sputum is the diagnostic modality of choice. And here also COVID-19 is very important. And since the advent of COVID-19, we earlier had to send all samples to National Institute of Virology, Pune. Now various centers have been developed all over the country in most districts of India to do these RT-PCR tests, because these are now valuable tests to detect the viruses. Now again, cytologic examination is not very important, because nowadays we usually go for the antigen test or the RT-PCR or the PCR examination as the case may demand. The presence of viral inclusions is diagnostic in cytological evaluation, although the method has very low sensitivity. Viral culture are routinely not available for 10 to 15 days, and therefore it limits them, because usually we treat viral pneumonia in the acute care settings. So though they are gold standard, there are not much usage because it takes time and we can't take its help in acute care settings. As there is tremendous overlap in findings on chest X-ray, no one finding is pathognomic. As you all know, in chest X-ray for bacterial pneumonia, we have alveolar infiltrates, lobar consolidations, pleural effusions, and so on. But features that are more suggestive of viral pneumonia include interstitial infiltrates, patchy distribution, bilateral infiltrates, and also it can be an unremarkable chest X-ray. And like for COVID-19, it is very less sensitive than chest CT. Findings are most extensive about 10 to 12 days after symptom onset. So to have an earlier pickup of the disease, we usually need to advise a chest CT if needed. So plain radiogram, it takes 10 to 12 days to have the florid or the most extensive distribution. Airspace opacities, ground-like consolidations may be there. The distribution is often bilateral, usually the peripheral distribution and lower zone predominance. Very rarely there is pleural effusion. So what is the role of CT thorax? Definitely CT thorax is recommended. The severity of the lung involvement on the CT correlates with the severity of the disease. As you all know, when we are suspecting a patient of COVID-19, we are advising a CT chest, and CODATS 4 or 5 is highly suspicious for COVID-19, and CODATS 6 is done when already the patient is mentioned, when already the patient has been detected to be having RT-PCR positive or rapid antigen positive for COVID-19. So the ground glass opacity is the most frequent findings in chest CT, followed by consolidation and crazy faving. So these three are the most important things, like ground glass regions, ground glassing, crazy faving, and also patterns which are compatible with organizing pneumonia. So the definitive diagnosis cannot be achieved by using imaging features alone. Recognition of viral pneumonia patterns can be done. And if we can do it early, we can not only try to differentiate between viral and bacterial pathogens, but also we can reduce the unnecessary use of antibiotics. So an early diagnosis of viral pneumonia is important. So the cornerstone of treatment of viral pneumonia consists of not only supportive care to maintain an oxygenation when it is needed, to maintain adequate hydration, to maintain rest and thereby decreasing the oxygen demand, and also to meet the increased caloric need of the patients, secondary to the increased respiratory effort. So management of comorbid illnesses is also very much important, because as I said, it is usually more hazardous in patients who are having multiple comorbidities like uncontrolled diabetes mellitus or in immunosuppressive states. And definite viruses have definite specific antiviral therapy. And these molecules can be used as per recommendations, as per needed. Like oseltamivir is used for this influenza, the new variants. Like influenza virus is treated with oseltamivir, respiratory syncytial virus can be treated with ribavirin. Other like herpes simplex virus can be used, acyclovir can be used as an antiviral agent. Similarly, varicella zoster virus can also be treated with acyclovir. Now for COVID-19, one important thing has come up. The recovery trial 1 year back had helped us to know that usage of steroids in particular patients who need admission and oxygen support, this can help. And this dexamethasone usage has been approved since last year. In COVID pneumonia, we always have some hypercoagulable state-like pictures in patients who are critically ill. So we have to look for the D-dimers and if needed, the fibrinogens and the platelets and APTT, PT also. The cytokine storms should be taken care of. And this cytokine storm is usually taken care of by the early usage of dexamethasone in critically ill patients. So in COVID, usually the viral response phase is the first week of the illness. But the second phase is very important. From the 8 to 13, 14 day, the host inflammatory response come up. And if there is the pulmonary, after the pulmonary phase, if there is hyperinflammation, then the cytokine storm can be hazardous. So this time course should be kept in mind. And this is the time when we should know when to use antivirals and when to use these anti-inflammatory agents. So the cytokine storms should be taken care of. So to be taken together, this cytokine storm is followed by an immune system attacking the body, which in turn will cause ARDS, vascular hyperpermeability, multi-organ failure. And usually the death is mostly due to high cytokine concentrations are unabated over time. And if we can't control it, usually the deaths come into picture. And also the microvascular thrombi should be taken care of because there is microvascular thrombi which impair the blood flow all over the body and also in the vascular system of the pulmonary vasculature also. And for that, a thromboprophylaxis for critically ill patients is in our armamentarium because we have to use low molecular weight heparin or even oral anticoagulants in less severely ill patients. So COVID-19 has taught us to treat these viral illnesses, to detect early, and also how to go in such a way that our knowledge helps us in treating our patients well. For COVID-19, remdesivir came up to be an antiviral of choice for those who are critically ill, and emergency use authorization was given last year, and it has been widely used in critically ill patients. There are certain controversies, but still there are certain indications when remdesivir has been shown to have good results. Convalescent plasma therapy came up last year because we had no other options for critically ill patients, but later ICMR has asked to discontinue the treatment. Now coming back to our age-old influenza, usually we have two types of vaccines, the intramuscular trivalent inactivated vaccine and the live attenuated intranasal vaccine. So we should prescribe our patients, particularly physicians who are having the risk factors of influenza, pneumonia, the elderly, the COPD, the immunosuppressed patients, to have the intramuscular trivalent inactivated vaccine in the months of late August, September, or October when the new vaccine comes. And this vaccine takes care of the major prevalent strains of the virus, which might cause the disease in this particular time of this winter, which will be coming. So from next month, we have to advise patients so that they can take care of their prevention part of influenza. The flu vaccines for 2018-19 protected us against the viruses that cause swine flu and one or two other viruses that are expected to be the most common flu during the season. So the flu vaccines are recommended for immunosuppressed, the persons with heart and lung disease, and definitely we, the healthcare workers, should also be taking the vaccines to prevent this illness. So at the end, we should always try to ask our patients to stay home if the patient is sick, because there is more chance of spread if there is mixing. Is not readily available, we should ask patients, or we should always think of using an alcohol-based hand sanitizer. We should always try to contain our coughs and sneezes and definitely to avoid contact. So the prognosis depends. Some viruses like the hantavirus, the SARS and MERS carry a much worse prognosis than the old respiratory syncytial virus and the influenza virus. The immune competence of the patient also is an important factor, how well the patients can treat themselves. So the pathologies, underlying pathologies like the comorbidities should be taken good care during the treatment, like COPD, cancer, diabetes, or other hematological dyscrasias. And definitely if there is presence of any concomitant bacterial infection, that also should be treated. The main complications which leads to death are concomitant bacterial infection, resulting in abscess or empyema or pleural effusion, sepsis with secondary multiple organ failure, acute respiratory failure, cardiovascular collapse, and ARDS. So consultation with an infectious disease specialist is, if available, and a pulmonary or critical care physician is advisable if the patient is hypoxic or requires advanced airway or placement in the critical care setting. So we should try to promote universal vaccination like measles, varicella, and also for those who are more susceptible like influenza vaccination. And these days, COVID-19 can be prevented with vaccination. So last year, we didn't have this option, but now it's better to get everyone advised to get COVID-19 vaccinated, because that is the only way we can prevent the third, fourth, and fifth waves which are coming. So although specific antiviral agents do exist, the cornerstone of treatment for viral pneumonia is usually supportive care. All patients of COVID-19 also don't need remdesivir or any antiviral agent. So good supportive care from the beginning, and to know when we should start antivirals is very important. And very importantly, we should advise the hand hygiene, the personal hygiene for the patients, annual influenza vaccination, and we should urge our patients to lead a healthy lifestyle, eat healthy, and exercise regularly. The outcomes in most people with viral pneumonia is excellent. However, in individuals who are immunocompromised or at extremes of ages are definitely guarded. So we should take care of this type of population who are more at risk of developing viral pneumonia. Thank you for your patient hearing, and my greetings from Shiliguri where I work. Thank you.
Thank you, Dr. Sen. Now without delay, I want to invite our senior colleague, Dr. Devi Ram sir, for deliberation of his lecture. His lecture is related with pulmonary thromboembolism. Sir, Dr. Devi Ram sir, kindly start your deliberation. He needs no introduction in API Bihar. He is very important pillar of API Bihar. Dr. Devi Ram sir, kindly start.
Yes. Honorable chairpersons, am I audible?
Yes, yes, sir, you are audible.
Honorable chairpersons, moderator, and the most dedicated delegates who are still with us in the late evening hours. I need to congratulate them for their stamina and dedication and honesty. Thank you very much indeed. The topic allotted to me is pulmonary thromboembolic disease. Pulmonary embolism was first described by Verco in the 80s. It's a potential cardiovascular emergency caused by detachment of a part of thrombus from DVT, which is off in the lower limbs and then travels up to pulmonary circulation, thereby causing pulmonary embolism. Long-term complications can cause progressive pulmonary hypertension, leading to right heart failure called chronic thromboembolic pulmonary hypertension, which is due to frequent small pulmonary emboli over the time, though fortunately it's a rare complication. Of pulmonary embolism is undiagnosed or underdiagnosed, particularly in the past, but more frequently diagnosed now with newer and appropriate tests. However, high index of suspicion is needed to diagnose and treat particularly severe pulmonary embolism to reduce morbidity and mortality. Over the years, improved diagnostic tests and treatment have significantly reduced morbidity and mortality. Clinical presentation of pulmonary embolism varies from asymptomatic or with least symptom to fatal outcome. Symptoms are of non-specific, making the diagnosis rather difficult, and symptom varies depending on the size, and location of the embolism, how much lung is involved, and what is the underlying lung and heart disease. However, in the setup of DVT, following symptoms should give strong suspicion of pulmonary embolism, like acute onset of dyspnea, chest pain, particularly of pleuritic type, cough, hemoptysis, tachycardia, tachypnea, hypoxia, fever, sweating, cyanosis. Classification of pulmonary embolism, it is categorized basically in three parts: massive, submassive, and low risk. Low risk fortunately accounts for 60 to 70% of pulmonary embolism and often carries good prognosis. Submassive accounts for 20 to 25% of cases of pulmonary embolism, and it presents as right ventricular dysfunction, dilatation, hypokinesia, and high right atrial pressure with normal BP. But the most important problem is massive pulmonary embolism, which fortunately accounts for 5 to 10% cases, all cases of pulmonary embolism. And this is due to extensive embolus affecting over 50% of pulmonary vasculature, leading to dyspnea, chest pain, cyanosis, and often presenting as cardiogenic shock. And it could well be fatal if left untreated due to multi-organ failure. Sources of pulmonary embolism is mainly DVT of the calf, but it could be from pelvic, iliofemoral vein, and right heart chamber. DVT of upper limb is rare and is often precipitated by placement of pacemaker wire or CBP line. Occasionally, pulmonary embolism could be due to substances other than blood clot, such as fat from the marrow of fractured bone, collagen or other tissue, part of a tumor, air embolism, amniotic fluid embolism in postpartum women, and DIC. These are the differential diagnosis of pulmonary embolism. Risk factor of pulmonary embolism, there are many, like major surgery of joint, lower limb, abdominal or pelvic surgery, gastrointestinal surgery, multi-trauma, spinal cord injury, etc. Acute and chronic medical illnesses like chronic heart failure, myocardial infarction, inflammatory bowel disease, and acute respiratory failure can be a predisposing factor. Malignancy-related factor, active malignancy, myeloproliferative neoplasm, cancer treatment. Hormone-related problem, pregnancy, early postmortem, oral contraceptive, hormone replacement therapy. Body mass index more than 30, venous stasis, varicose vein, past history of DVT or pulmonary embolism, prolonged immobilization, and travel. Then once you suspect pulmonary embolism, you need to stratify. Why do we need to stratify? That will guide us for further investigation. And this is done by scoring criteria, and two popular ones are Welsh score and PERC score. They are very simple, clinically oriented, and most validated. The Welsh criteria. If there are signs and symptoms of DVT, 3 score. If alternative diagnosis less likely than P3 score, heart rate more than 100, 1.5, immobilization 1.5, previous DVT, pulmonary embolism 1.5, hemoptysis and malignancy 1 each. If Welsh score is more than 4, then we don't need to do D-dimer test. We straight away proceed for imaging. Similarly, in PERC rule, age less than 50, pulse less than 100, oxygen saturated more than 95, no hemoptysis, no estrogen, no surgery, no trauma, no previous thromboembolism, no unilateral leg ischemia. If all these factors are present, then the scoring is 0. But if it is more than 0, then ELISA type D dimer is recommended. And if D dimer is negative, then pulmonary embolism is ruled out. But if it is positive, then imaging is recommended. So, approach to investigations is, in other words, patients with low or moderate possibility of DVT and P should undergo D-dimer test without imaging. But those with high likelihood should skip D-dimer and not waste time and should undergo imaging. There is a diagnostic flow chart which again says the same thing which I have described. D-dimer is raised in DVT and pulmonary embolism because of breakdown of fibrin by plasmin, indicating endogenous thrombolysis, though clinically ineffective. D-dimer is sensitive in more than 80% cases of DVT and more than 95% case in P. So, a normal D-dimer test is a good rule-out test. However, it is not specific and might be increased in other conditions like MI, pneumonia, sepsis, cancer, etc. So, it could be misleading. Cardiac markers like serum troponin could be found increased in right ventricular microinfarction, and BNP could be increased in right ventricular myocardial state in submassive PE. ECG, it could well be normal, or it could show sinus tachycardia, or classical S1, Q3, T3, or T inversion in V1 to V4 due to RV strain and ischemia. DVT can be diagnosed by ultrasonography of deep vein system of lower limb, which could show thrombus directly or could show loss of vein compressibility, dilatation of vein, and loss of collateral channels. Loss of respiratory variation of Doppler flow pattern on Doppler imaging angiography is found. CT and MRI could also localize DVT. Further investigation like chest X-ray is often normal in P, focal oligemia, wedge-shaped density due to pulmonary infarct, enlarged right descending pulmonary artery, though well described in books, are seldom found. Moreover, it is helpful to rule out alternative diagnosis like pneumothorax, pneumonia, etc. CTPA, computerized tomography pulmonary angiogram using intravenous contrast, is the most commonly employed test and has become principal imaging test and provides definitive diagnosis to locate sites and site of pulmonary embolism. This definitive test, if indicated, should be done rather urgently, and if delayed, then low molecular weight heparin must be started. This test has virtually replaced all the tests which were being done. Vuki scanning could be done in pregnancy as radiation is less than CTPA, hence decreased maternal and fetal risk. Echocardiography is often normal, but helpful to exclude MI, aortic dissection, pericardial tamponade. However, if it is some massive pulmonary embolism, one can see right ventricular dilatation, hypokinesia, and raised right atrial pressure. MRI is reserved for pregnant patients to avoid radiation to the fetus. Pulmonary angiogram has virtually been replaced by CTPA. Treatment, the most important part, as often said in medicine, is prevention. And as P is due to DVT, hence prevention of DPT and DVT is of utmost importance, like leg elevation, compression, early mobilization, avoid long sitting, moving the legs, plenty of water, and thereby this decreases DVT and hence pulmonary embolism. At times, oral anticoagulants or subcutaneous low molecular weight heparin is given to admitted patients with high risk of DVT. Pharmacological treatment of pulmonary embolism includes anticoagulants and fibrinolytics. Anticoagulants are oral, the classical being vitamin K antagonist warfarin, or NOAC, the novel oral new anticoagulants. Parenteral anticoagulants contains UFH, low molecular weight, and fondaparinux. Vitamin K, this is the one which has been used for long, and as we all know, it interferes with the coagulation factor 2, 7, 9, 10. And its effectiveness is tested by prothrombin test, INR, and it targeted to 2 to 3. However, there are many drug and food interaction with warfarin. So NOAC, the newer ones, are preferred, and these are given in fixed dose. It starts working within hours, requires no laboratory monitoring, and there are fewer drug and food interaction, and probably decreased risk of bleeding and adverse event. However, NOACs are not recommended in pregnancy and lactation. These are the NOACs which are available. UFH, it accelerates antithrombin activity, prevents additional thrombus formation. It has a short half-life, also reduces systemic and local inflammation. Usually it is given IV bolus 80 units per kg, followed by initial infusion rate of 18 units per kg per hour to achieve a target of APTT of 60 to 80 seconds. Low molecular weight heparin are fragments of UFH given subcutaneous, more bioavailable as less bound to plasma protein, and longer half-life, hence more predictable response. No dose adjustment or monitoring needed except in renal impaired patients. Fondaparinux is given OD subcutaneously. No laboratory monitoring is required as it is synthesized in laboratory, unlike heparin, which is derived from animal product, hence does not cause heparin-induced thrombocytopenia. However, its dosage needs adjustment in renal impairment. Fibrinolytics dissolves thrombus of pulmonary artery and deep veins and reverses right heart failure and prevents recurrent PE and reduces mortality. Massive pulmonary embolism, fibrinolytics has shown clear benefits in massive pulmonary embolism and leads to faster improvement with subsequent anticoagulants. In some massive, it's debatable whether it is fibrinolytics with or without heparin or heparin alone. it remains to be seen. Heparin has also been found useful in submassive pulmonary embolism with less bleeding chances. But the greatest benefit when you use fibrinolytic is observed if it is initiated within 48 hours of symptoms, but could be used up to 14 days. Fibrinolytics, streptokinase, urokinase, RTPA, and others. RTPA is preferable. It is given 100 milligram over 2 hours by continuous peripheral IV infusion. Alternatively, 50 gram is thought to reduce bleeding complication. This is called half-dose thrombolytic therapy. Streptokinase and urokinase could also be used. Catheter-directed thrombolysis using low dose has been found successful with reduced risk of bleeding and is preferred to systemic thrombolysis at times. Physical fragmentation of thrombus and embolization of clot distally, suction thrombectomy, etc. are being tried. Catheter embolectomy, surgical pulmonary embolectomy, in which clot removal of large and life-threatening pulmonary embolism is done before onset of irreversible multi-organ failure, with recent improved surgical techniques, can result in high survival rate and avoids the risk of major hemorrhage due to fibrinolysis. Endovascular interventional therapy by devices to recanalize pulmonary artery in pulmonary embolism is being tried recently with successful outcome and looks rather safe. Pulmonary thromboendarterectomy could be considered in CTEPH to prevent clot from moving from legs to lungs in high-risk venous thromboembolic patient. Vein filter in IVC could be offered. Treatment of DVT and low-risk pulmonary embolism. This often requires oral anticoagulants. Only anticoagulant, UFH, and low molecular weight, fondaparinux, or oral. Usually parenteral for 5 days, bridge to warfarin, or switch to NOAC and oral continued. Or it could be only oral monotherapy, warfarin or NOAC to start with. Duration of treatment for isolated DVT of calf or upper limb provoked by trauma, surgery, etc., anticoagulation for 3 months suffice. But for unprovoked DVT or pulmonary embolism, 3 to 6 months anticoagulation used to be sufficient, but recent studies suggest extended period of anticoagulation. In cancer patient, low molecular weight alone for an indefinite period. In conclusion, prevention of pulmonary embolism by taking adequate measures to prevent and treat DVT is most important. High index of suspicion is needed to diagnose pulmonary embolism in the setup of DVT and prompt and adequate treatment, particularly in massive and submassive pulmonary embolism, to reduce morbidity and mortality. Thank you very much for bearing with me for last 20 minutes. Thank you.
Thank you, sir, for very nice and very useful presentation. Thank you, sir. And without wasting time, I want to invite Dr. Rajadhar. His lecture topic of his lecture is recent advances in COPD management. Dr. Rajiv. Dr. Rajiv. Dr. Rajiv, kindly.
Hello, friends. My name is Dr. Rajathar, and I am here to speak to you about recent advances in COPD management. I'm thankful to my dear friend, Dr. Rajiv Ranjan, for having invited me to this BAPICON meeting. I've been lucky in being a part of this meeting before, and I hope this virtual meeting goes well for you guys. And hopefully next year we can meet up on a similar platform, but in person.
Continue, Rajadhar.
So what I'm going to do over the next 25 minutes is to speak about all aspects of chronic obstructive pulmonary disease. Why are we talking about COPD today? We are talking about COPD because over the last 15 years, COPD has gone from being the third commonest disease, chronic disease causing deaths, to the second most common disease causing deaths throughout the world. This is amongst all causes of mortality. If you looked at chronic diseases, then it's second and the second cause of mortality too. So in India, it's the second leading cause as opposed to fifth globally. You can see diseases like diabetes, and you know India is the diabetes capital of the world. The numbers have gone up, but they've not gone up as significantly as it has done in COPD. Why are we worried about this disease? Because as this disease progresses, the number of years lost in the way of life, in the way of survival, increases. So patients who got severe airflow obstruction, severe disease, stage 3 and stage 4, the number of years lost is about 6 years. Add that to people who've been a smoker of more than 20 pack years, that's another 3.5 years lost. So for someone who's been a heavy smoker and has severe COPD, stage 3 or stage 4 COPD, you've lost about 10 years in the way of lifespan, which you would agree is a huge number. And that's why we talk about this disease. The cause for mortality in COPD is exacerbations. So greater the number of exacerbations, the greater the chances that you die early from this disease process. So from the time of diagnosis, and I want you to see my cursor on here, from the time of diagnosis, the first exacerbation happens maybe after 5.5 years. And then as the disease progresses slowly, you see the time span between exacerbations gradually increases or reduces. And then when you've got severe disease, the span between exacerbations is less than 4 months. And that's when the penny falls and people die from exacerbations at that particular point of time. So the treatment that we're going to talk about in a bit is aimed at reducing exacerbations in patients. An exacerbation might mean loss of life, loss of quality of life, but also loss of finances. And this is a comparative figure looking at various causes of acute admission to a hospital and the amount of money spent on these admissions. These are sort of nursing homes somewhere between the big corporate hospitals where the expenses are much more compared to the government hospitals where the expenses are much less. You've got a middle range patient, a middle class patient going to these hospitals, and you can see that the cost for patients who are admitted in a non-ICU setup in COPD is far greater than even patients who get in with cardiac causes or with a severe exacerbation of bronchial asthma or even a cerebrovascular accident. So even within the ambit of chronic diseases, the cost of an admission due to a COPD exacerbation, even without ventilation, is a large amount. The guideline for management of COPD has changed over the years, and this shows you the period where the maximum change has happened. This is looking at the GOLD guidance, and in 2006, the GOLD, which is the official guidance, global guidance for obstructive lung disease for COPD, graded disease according to spirometric severity. So the lower the FEV1, the greater the severity of the disease, which would imply a one-size-fits-all approach. So across various groups, you would give patients exactly the same treatment, irrespective of other factors aside from spirometry. And then in 2011, things changed. How did they change? You tried to personalize treatment, and you personalized treatment based on how much symptoms a patient had, and symptoms would be measured according to two scoring scales called the MMRC scale and the CAT score. These would measure your quality of life, how much you were capable of doing at a given point of time, and what we spoke about a little while ago, exacerbations. So symptoms on the x-axis, exacerbations on the y-axis, and you categorized patients on that grid as A, B, C, and D, depending on how much symptoms you had and how many exacerbations you would have in a given period of time. And this ABCD scale has changed again, and this is the latest scale, which takes out spirometry from the equation completely. So compared to 2006, which is 15 years ago, you understand how the management and how the categorization of this disease has gone from one size fits all to personalized treatment of this disorder. So you diagnose the patient based on spirometry, which is assessment of airflow limitation. And then you grade patients into gold 1, 2, 3, and 4, depending on what the FEV1 was. And then you look at the number of exacerbations and symptoms that this patient has. So for instance, if you were a gold D, it would mean that you had significant symptoms with an MMRC of more than equal to 2 and a CAT of more than 10 and 2 or more hospitalization or 2 or more exacerbations or 1 or more hospitalization in this particular individual over 1 year. So that's a gold D. A gold A, on the other hand, would be someone who has mild symptoms, minimal symptoms. So an MMRC of 0 to 1, a CAT of less than 10, and 0 or 1 exacerbation of COPD, and the exacerbation should not have led to a hospitalization. So that's how you grade according to the ABCD grid of COPD. We spoke about phenotyping a little while ago, and just to put things in perspective, there are two terms that you need to remember. All of us need to remember. One is phenotyping and the other is endotyping. So clinical phenotyping is something which is symptom driven. So individuals who have a high symptom burden, maybe in the form of a high MMRC score, patients who have COPD due to smoking, patients who have COPD due to biomass exposure would belong to individual phenotypes. There would be individuals who have more exacerbations, and that too, the exacerbation prone patient would also be a different clinical phenotype. And then there are endotypes. The endotypes are marked by biomarkers. For instance, you could have COPD, but you could still have a eosinophilic airway. So your blood eosinophils might be raised, which means that you have COPD, fixed airflow obstruction, but a eosinophilic endotype of COPD, or an exhaled nitric oxide, which is high in individuals, could also mean that. The endotype could also lead to be related to the genome. So for instance, someone has alpha-1 antitrypsin deficiency leading to COPD. That would be an alpha-1 AT endotype of COPD. So that's how you grade endotypes and phenotypes in any disease process, but also in COPD. So now we've sorted that out. Let's think about the two endpoints which you try and address when you treat your patients with COPD. And to me, or even in GOLD, the two endpoints that are most important are breathlessness, dyspnea, and exacerbations. So you improve symptoms in COPD by trying to reduce breathlessness in individuals and reduce exacerbations, because exacerbations either mean poor quality of life or mortality. So those are the two endpoints that you address. And you address dyspnea by giving them bronchodilators. And when we talk about bronchodilators, we mean a LABA or a LAMA, a long-acting beta-2 agonist, or a long-acting muscarinic antagonist, or a combination of these two drugs, the LABA plus the LAMA. In some individuals, and we spoke about eosinophilic airways disease a little while ago. So in some individuals, this might mean that you add in an inhaled corticosteroid to the mix, and this would also improve dyspnea in these individuals. So a LABA plus a LAMA plus an ICS. You might want to switch devices. You might want to add oral agents in, and we'll discuss these as we go along. On the other side, it's looking at exacerbations. And again, the bronchodilators, the LABA or the LAMA, seems to reduce exacerbations. And here, the LAMA seems to be better at reducing exacerbations as compared to the LABA. And then you combine, and in some individuals, like we said before, you might want to add in an inhaled corticosteroid to reduce exacerbations. And it's usually individuals who have eosinophilia, who have raised blood eosinophils, which is reflective of the airway eosinophils, where you add in the inhaled corticosteroids. And there are other drugs which reduce exacerbations, drugs like low-dose macrolides, so low-dose azithromycin, roflumilast, N-acetylcysteine. All of these are exacerbation-reducing strategies that you can add in to the inhaled medications in trying to reduce exacerbations in individuals. You can see the eosinophil factored in there, the fact that a blood eosinophil count of more than 150, I know it says 100 there, but 150 in our country is what I would mandate. If you have a blood eosinophil count of more than 150, at the point of adding in a drug, you might want to add in an inhaled corticosteroid in these individuals. Which drug you choose depends on the expected risks versus benefits. So in the triangle at the bottom in the scale, you can see the various drugs and combinations factored in. The expected benefits when you prescribe these drugs are reduction of mortality, reduction of disease progression, improvement of lung function, reduction of cough, sputum production, dyspnea, improved exercise tolerance, reducing exacerbations, and so on. And then the expected risks are things like pneumonia due to inhaled steroids, for instance, or oral steroids, tuberculosis, again for similar agents, skin bruising, osteoporosis, muscle dysfunction, all of them really related to either maintenance or repeated rescue doses of oral steroids, nutritional impairment, cataract, diabetes, again, similar causes. So you weigh the pros and cons between the medications and decide whether you add in a medication or you change a medication. That's what decides individualization of treatment, what we called phenotyping a little while ago. I'm sorry, this is fine print, and I don't want you to pour in and read what's written on that slide either. However, this goes a little bit more into phenotyping and endotyping of individuals. So if you find that the predominant trait in your patient is airflow limitation, it's airways narrowing, you need to find out what exactly is wrong here. Is it more of emphysema on a CT? Is it more of smooth muscle contraction or narrowing on a spirometry? Is it mucosal edema post an exacerbation which is causing it? And depending on drug, on that, you decide on what your first choice medication, your second choice medication is. So for instance, if someone has got more of bullous disease, more of cystic disease, more of emphysema, then you might want to consider lung volume reduction surgery early on in the disease course. You might consider lung transplantation later on in the disease course in these individuals. You can also use the lung volume reduction therapies that we have, the valve treatment, the coils, etc., which help in shrinking lung volume, shrinking the cysts and bullae that I talked about a little while ago. Take the other side of the coin. Someone has eosinophilic airway inflammation, so more of chronic bronchitis. In these individuals with lots of phlegm, thick tenacious phlegm, using mucolytics or using low-dose macrolides might make more sense. Patients with bronchiectasis, again, use of antibiotics in this cohort of patients would be more useful. Patients who have chronic respiratory failure, long-term domiciliary oxygen in these individuals or BiPAP in these individuals might be helpful. So categorizing the disease type, grouping them, phenotyping them helps you in deciding what therapy is most appropriate for individuals. I'll quickly go through some slides before I go to what's the important part of my talk, which is drugs. But think about pulmonary rehabilitation and self-management in patients with COPD. This slide is from Gold and so easily available to all of you. Pulmonary rehabilitation, exercising, physiotherapy, call it what you want, but doing these is important in improving dyspnea, quality of life, and exercise tolerance in patients with stable COPD. And you can see it says evidence A, which means best quality evidence. Pulmonary rehabilitation leads to reduction of anxiety and depression. Again, wonderful quality evidence. The chances of exacerbation with pulmonary rehab is going to be lesser. And hence, using pulmonary rehabilitation, some form of rehabilitation, be it home rehabilitation, is a no-brainer. It's something all of you should do in your patients with COPD. Education and self-management is important. So if you have someone who's exacerbation prone, they should know what medications to start at home. You should chart that out in a prescription for them when they leave for home so that they can start treatment early. Some patients with severe COPD will progress relentlessly. They will have exacerbations and have poor quality of life. And here, trying to control symptoms becomes more the goal rather than trying to make patients feel better. So opiates, neuromuscular electrical stimulation, giving them oxygen, giving them fans to reduce breathlessness, all these factors are necessary to think about in patients with COPD. And then long-term oxygen therapy in patients who have resting arterial hypoxemia, when stable, when out of an exacerbation, is important to think of. So saturations of less than 90% at rest should prompt you to do an arterial blood gas analysis in these individuals. And if the PO2 is less than 60 or even less than 55 in certain individuals, you would consider them for long-term oxygen therapy, monitoring their carbon dioxide, making sure that these patients do not become hypercarbic and hence unconscious from their hypercarbia. So important to remember this in your patients. And then ventilatory support at home, non-invasive ventilation, positive pressure ventilation in these individuals is important because these patients might have pronounced daytime persistent hypercapnia. Interventional therapy in stable COPD, so lung volume reduction surgery, bulectomy, transplant, and bronchoscopic interventions are things that we have spoken about already and would be important in your patients with stable COPD. So the goal for treatment, like we said, is twofold. Reduce symptoms, and symptoms are mainly here about breathlessness, and reduce risk, which is to reduce disease progression and exacerbations in individuals. So let's spend the last 7 odd minutes talking about drugs in COPD. So these are the various agents that are available in patients with COPD. And then there's some more. Let's talk about bronchodilators. And this is a list of bronchodilators. We have said LABA and LAMA, long-acting beta-2 agonists and long-acting muscarinic antagonists, which are available for use in patients with COPD. The ones which are available today are glycopyrronium and tiotropium. Others on the anvil are drugs like aclidinium, oladetrol, umeclidinium, and so on. So all tongue twisters, but drugs that are either available are going to be available in the near future. The 2 drugs available to you today, remember, are tiotropium and glycopyrronium. Why do we combine drugs? What's the rationale of combining a LABA and a LAMA together? So if you look at the airway, the muscarinic receptors are in the central airways. The orange squares is what you're looking at. So those are where the muscarinic receptors are. The beta-2 receptors, the beta-2 adrenergic receptors are there more at the periphery of the lung. So periphery of the lung is where the beta-2 adrenergic receptors are. So your LAMA will work in the central airways and the LABAs will work in the peripheral portions of the lung. You understand that patients with COPD will have disease in both these portions. You have chronic bronchitis and you have emphysema across the board. Some might have predominant emphysema, some might have predominant chronic bronchitis, but patients have both these disorders. And hence, combining these seem to be rational, something that should be done. There's one trial I want to quote for you quickly, which is the FLAME study. And the FLAME study looked at a LABA plus a LAMA. So the LABA in question was indacaterol. The LAMA in question was glycopyrronium. And you combine and you compare that with what people have used for years together in COPD, an ICS and a LABA. And the inhaled corticosteroid, there is fluticasone. The LABA, the long-acting beta-2 agonist, is salmeterol. And very quickly, the results showed that the indacaterol glycopyrronium combination caused more reduction of moderate and severe exacerbations as compared to the LABA and the ICS, so compared to the salmeterol and fluticasone. And the greater reduction was significant. It was about 17%. And then the time to first exacerbation was again greater in patients with moderate or severe disease as compared to patients who had mild disease or all comers with COPD. So 22% risk reduction to time to first exacerbation with the LABA-LAMA combination. So over the years, this is again a gold slide. So a series of new drugs are available. Indacaterol glycopyrronium has been available now for a while, but olodaterol and tiotropium and vilanterol and umeclidinium are drugs which would be available in the not so distant future. And hence, this has been recommended. The combination of a LABA and a LAMA has been recommended as the preferred choice in GOLD group B, C, and D. So stable disease, but with lots of symptoms, exacerbation-prone disease with less symptoms, and lots of symptoms plus exacerbation-prone disease, which is B, C, and D, are the groups in which you would use this combination. Inhaled corticosteroids in COPD, and I'll sort of forget about the history because we don't have time, but the fact that inflammation has been thought to be an important part in the pathogenesis of COPD. We know that inhaled corticosteroid is the most important drug in patients with asthma. Hence, why would it not be effective in patients with COPD? Lots of combo studies. So ICS plus LABA studies, Tristan, TORCH, Summit, FLAME. All of these drugs have looked at ICS plus LABA or ICS plus LABA plus LAMA in showing its efficacy. And the newer drugs have come in and they have claimed even greater efficacy as compared to what their predecessors did. However, we now know that sputum eosinophilia and blood eosinophilia predicts a response to inhaled corticosteroids in patients with COPD. So if you had a sputum eosinophil of more than 3% or an absolute eosinophil count in the peripheral blood of above 150, inhaled budesonide or oral prednisolone would work better. And when we say it would work better, it means that it would improve quality of life by reducing breathlessness, improve spirometry, and also reduce exacerbations in these individuals. So I want you to remember this one slide about inhaled corticosteroids. Where would you use inhaled corticosteroids in COPD? I want you to look at the middle white portion on there where it says consider use. So one moderate exacerbation of COPD with a blood eosinophil count of 100 to 300, I would say above 150 would be an indicator for using inhaled corticosteroid in exacerbation-prone COPD. Now look at the orange. That's the middle grade. What about orange? Where would you definitely use it? And you would definitely use it when there's a definite history of exacerbation causing hospitalization, 2 or more moderate exacerbations of COPD, or a history of hospitalization due to an exacerbation with COPD, a blood eosinophil count of more than 300, a history of concomitant asthma. So concomitant asthma is a no-brainer, but remember this, hospitalization with COPD, 2 or more moderate exacerbations, and a blood eosinophil count of more than 300 would mandate that you use an inhaled corticosteroid. Where would you not use it? And that's the gray box on there. Repeated pneumonia on inhaled corticosteroid, blood eosinophil count of less than 100, or I would argue less than 150, and a history of TB in the past, where TB reactivation would be a real worry. What about triple therapy? And I show you different studies. Again, I won't dwell on these because of lack of time, but the ETHOS study, which looked at a combination of an ICS plus a LABA plus a LAMA versus an ICS plus a LABA plus a LABA plus or another arm of a LABA plus a LAMA. So ICS LABA LAMA, LABA plus LAMA, ICS plus LABA, or the Tribute study or the Trilogy study, all of them showed a significant benefit of the triple as compared to an ICS LABA or even a LABA plus a LAMA. So have I confused you? If I have, I want you to remember one thing. There would be a significant percentage, a small percentage, but significant percentage who would benefit with the triple. Equally, there'll be some patients who would benefit with the LABA and the LAMA. Hence, the addition of ICS based on the criteria I talked about a little while ago is of utmost importance. And I want you to go through these studies in your own time. I can leave these slides with you. Go through them in your own time and make sure when to use these triple versus the double. Low-dose antibiotics is important. The use of low-dose antibiotics, low-dose macrolides in patients with COPD. So azithromycin at a dose of 500 milligrams thrice weekly for a period of at least 3 to 6 months reduces exacerbations and does that by changing the microbiome in the gut. And that's important, and the therapy works. What antibiotics in people with exacerbations is something that's laid out in this chart. It tells you when to use antibiotics. So if you have increased sputum volume, increased sputum purulence, and you are in the high risk factor, so age more than 65 years, FEV1 of less than 50%, 3 or more exacerbations and cardiac disease, you would go for a fluoroquinolone or an amoxiclav combination. Less risk factors or no risk factors, age less than 65, FEV1 of more than 50%, less than 3 exacerbations, no cardiac disease, you would go for a macrolide or a cephalosporin. This is the data showing that azithromycin works in prevention of exacerbations. And you can see by the separation of the two curves that the effect of this drug in the right sort of patient is significant. Does the device make a difference? It certainly does. So this was a study which came out in the European Respiratory Journal, which showed that using a HandiHaler versus a Respimat, the Respimat seemed to improve the impulse oscillometry, so had greater impact on the small airways in patients with COPD and hence resulted in greater improvement of lung function and hence quality of life. So Respimat device versus the HandiHaler device, the Respimat seemed to make a difference because of their impact on small airways. So think about the device too when your patient seems to be uncontrolled despite getting the right drugs. So other studies of note, and I won't dwell on this. Mepolizumab is a biologic. It's a new drug launched in India no more than 2 years ago. This is used in asthma, patients with eosinophilic asthma. However, the drug also seems to work in patients with eosinophilic COPD who are not responding or exacerbating on standard medications that we have described a little while ago. In patients who are exacerbating rather than non-invasive ventilation, you can use high flow nasal oxygen to oxygenate these patients and reduce hypercarbia. This again is work in progress, and we use HFNO in patients with COPD selectively, making sure that hypercarbia is not worsening in these individuals. So over a period of time, I hope I have managed to show you that the treatment is now based more on symptoms and exacerbation rather than being based on spirometry alone. The future would be there would be stratification of treatment based on low-income countries versus high-income countries. We would want to detect disease early. We would phenotype these patients, and imaging these patients to phenotype them better might be helpful. So my concluding remarks before I finish, I've just run out of time. Bronchodilation remains at the heart of treatment of COPD. It says 2019. So that's the COVID-19 habit. It's actually 2021. Select inhaled corticosteroids in the patients with eosinophilic disease. Don't give a triple ICS LABA plus LAMA to all patients. Choose patients for low-dose macrolides wisely. Bronchodilators of the phosphodiesterase class are the future, and we should use them. Nebulization, which we have not talked about today, is for a select few patients of COPD. It's here to stay, but only for a small minority of patients. And smart gadgets, devices which are new, might help in better drug deposition, and things we have not spoken about again, like artificial intelligence, might help in our management of patients better. Thank you for listening to me, and I would be happy to take questions if there are any. All the very best.
Dr. Rajadhar, your lecture was so clear that I think no question has left. So our chairperson, sir.
Hello, Dr. Rajiv Ranjan, kindly take over.
Yeah, sir. Since our program valedictory session is already delayed.
लैग करता है यहाँ से क्या कर
Dr. Salender, what for we are waiting? Is there any talk left?
No, sir. Most likely they have prepared some hall for valedictory person. Am I right, Rajiv? You are muted. Please unmute yourself. Then speak.
Dr. Rajiv.
Yes, sir. This hall is for valedictory session, sir.
Yeah.
This hall is valid for valedictory session. Yeah. Oh. Since at last nobody is here.
अरे यार कैसे nobody is here यार? हम लोग तो हैं सब लोग.
Sir, you are still there. No problem, sir.
हम लोग
actually
to convey to our appreciation and I mean congratulations and say big thank you to you. We are waiting.
So we are really all reciprocating you for big congratulations. This conference was organized nicely under your guidelines.
ये तुम्हारा काम नहीं है, ये हम लोग बोलेंगे. तुम लड़की वाला है. I mean, let me give my own comments and then I will go back. It has been very well thought of, very well planned, the scientific program, very well executed, and taking into the account the
Chairman Dr. Biskarma, sir, you have to say something? Hello? You have to say something, sir?
Boliye, sir.
क्या आवाज जा रहा है ना? हेलो, आप मेरी आवाज जा रही है?
Yes, you are audible. There is no problem.
हम लोग को आ रही है।
Rajiv, the scientific content is judged by, meeting is judged by scientific content, speaker's attendance, speaker's talk, audience attendance, and then maintenance of timing, and last was the quality of food.
स्पीकर का लुक और कपड़ा लत्ता।
नहीं, वर्चुअल में स्पीकर का कपड़ा लत्ता नहीं देखा जाता है, रियल में देखा जाता है।
तो हम तो ख्याल रखें।
When this program is given to me, it took as a challenge. Before this, there is no program in Chhapra, a state level program, and we have done only gastro in 2013. After 8 years, we are doing the state level program here. As a organizing secretary, I have to as an organizing secretary, sir, I have to bear too much because I want that program should go. The program should go, and name of Chhapra should come in the Bihar level. Because before that, 8 years back, I have done gastro here. After 8 years, this program was done. In future, I think for 10 years, nobody is doing any state level program. This forward, I want का आशीर्वाद चाहिए, तो फिर अगले 5-7 साल में हम लोग कुछ कर पाएंगे।
जरूर, मैं आपको प्रॉमिस करता हूं, आप लोगों ने जितनी श्रद्धा से, जितनी शिद्दत से और जितना अच्छा प्रोग्राम किया है, और अभी आपने कहा कि छपरा का नाम हो, तो बहुत छपरा का नाम तो छपरा ही लेला, कौन सी होला ये बलिया ही लेला, छपरा ही लेला, ये तो बहुत जग जाहिर है सर। और प्लस 2 माँ का मंदिर भी आपके यहाँ है, जो कि बहुत प्रसिद्ध है। हम लोगों को माँ का आशीर्वाद तो नहीं मिल सका, क्योंकि एक बलहौरा में है और एक अन्नमा या ऐसा ही जगह कोई है, जो कि
बलहौरा तो आरा में है सर।
हिस्टोरिकली प्रसिद्ध है, इसलिए छपरा का नाम हो ये हम नहीं एग्री करते हैं। हाँ, छपरा में 8 साल के बाद आप स्टेट लेवल कॉन्फ्रेंस कर रहे हैं, जो कि ऑलमोस्ट नेशनल लेवल का हुआ है। आई ऑनेस्टली टेल यू, द अरेंजमेंट्स ऑफ हॉल, द अरेंजमेंट्स ऑफ टॉपिक्स, द अटेंडेंस ऑफ द स्पीकर्स। साहब, इस कॉन्फ्रेंस में हमारे जितने भी पास्ट प्रेसिडेंट्स एपीआई के हैं, पास्ट डीन्स, पास्ट डायरेक्टर रिसर्च फाउंडेशन एंड व्हाट नॉट आए हैं। तो अब इसको आप कह रहे हैं कि साहब हमको नाम चाहिए, तो बॉस नाम तो आपका जग जाहिर हो गया है, पहले से भी था। और हम ऑनेस्टली बोल रहे हैं, आप लोगों से जो अपेक्षाएं थी उससे बहुत उच्च कोटि का आप लोगों ने सब कुछ किया है। टाइम मैनेजमेंट जो है ना, वो सबसे इम्पोर्टेंट है। और कल आप लोगों ने डॉट टाइम में फिनिश किया। आज थोड़ा बहुत डिले हो गया बिकॉज पॉसिबली ऑफ दी झंडोत्तोलन एक्सेट्रा। अदरवाइज आई गिव यू फुल क्रेडिट and I bless you all, and we will have a reunion after 6, 7, 8 years. Don't worry. केवल आप थोड़ा अपना वजन कम कर लीजिए, ये मेरी आपसे गुजारिश है। क्योंकि कल हमने वो क्या बोलते हैं लाइफ स्टाइल वाला पर टॉक दिया था, तो किसी ने मेरे को, इतना लोग शायद उसमें बह गए कि किसी ने पॉइंट आउट नहीं किया कि सर स्लाइड दिखाई नहीं पड़ रहा है, और मैंने भी नहीं सोचा कि बिना स्लाइड के हम बोल रहे हैं। तो इट सो हैपेंड बाय चांस कि ठीक ठाक हो गया, नहीं तो हमारी तो बेइज्जती हो जाती। तो सर छपरा से हमारा लोग का सबका बहुत कनेक्शन है। छपरा के पंडित जी लोग हमारे गांव से अन्न ले जाते थे पहले, बहुत पहले। ये सारी बात हम जानते हैं सर। रिश्तेदारी लोग भी है, छपरा में है, माँ भी वहाँ है, माँ का आशीर्वाद है, सब कुछ है आप लोगों तक। तब ने इतना आप धनी मानी और तगड़े हो गए हैं, माँ का आशीर्वाद के चलते ना। चलो सर, वेरी नाइस। अब हमारे जो चेयरमैन हैं कुछ बोलेंगे, श्री मोहन मिश्रा जी बोलेंगे, बात खत्म कर दिया जाए। बहुत
ओवरऑल बहुत अच्छा रहा, और सबसे अच्छा रहा आपका ऑडियो विजुअल मैनेजमेंट, बहुत अच्छा रहा। चूंकि जो ऑडियो विजुअल का ग्लिचेज तो हुआ ही नहीं, मिनिमम हुआ ना आप लोग के तरफ से, और इधर तो हम लोग का संयोग था कि हम लोग का नेट भी, इतना पानी बरसात होने के बावजूद नेट हम लोग को धोखा नहीं दिया। तो जितना बरसात मुजफ्फरपुर में अभी भी हो रहा है, तो इसमें नेट ही सबसे ज्यादा प्रॉब्लम करता है। तो नेट का साथ आपके तरफ भी अच्छा है, हम लोग का भी अच्छा। टाइम मैनेजमेंट, जैसा सर बोले कि टाइम मैनेजमेंट बहुत अच्छा रहा। बस एक चीज लैकिंग रह गया, वही फूड वाला, तो उसको फिर कभी देखा जाएगा।
नहीं मंगवा लिए ना आप, फूड तो आजकल जाता है, इससे क्या उसको बोलते हो,
कुरियर से
एटलीस्ट ये तो भेज ही सकता है ना, ड्राई फ्रूट्स।
जी सर, जैसा भी सर प्रोफेसर बीबी ठाकुर सर ने कहा कि ये प्रोग्राम बहुत ही अच्छा उम्दा क्वालिटी का हुआ। टाइम मैनेजमेंट की बात जहां तक है, कल तो काफी अच्छा टाइम मैनेजमेंट था। आज संभवतः इंडिपेंडेंस डे के कारण भी थोड़ा रिलैक्स थे हम लोग, और बाद में अंत में टाइम कुछ जो लेक्चर्स था, इतना इंटरेस्टिंग लेक्चर्स था कि हर लेक्चर में 5-7 मिनट एक्स्ट्रा लिया लोगों ने और स्पीकर्स ने, लेकिन इतना इंटरेस्टिंग और इतना लूसिड प्रेजेंटेशन था कि उसमें टाइम लिमिट के लिए कहना है कि वो अच्छा नहीं लगा। इसलिए कि शाम को लगभग सभी लेक्चर में हम और शैलेंद्र जी प्रेजेंट थे, हमको लगा कि जो भी स्पीकर है उनका लेक्चर उनको रोकना ठीक नहीं था, अब बहुत ही इंफॉर्मेटिव था। सबसे बड़ी बात जो आज जो लेक्चर डॉक्टर प्रोफेसर अरविंद जी का हुआ, जो कि क्लाइमेट चेंज से रिलेटेड था, वो हम लोगों का विजन जो है लाइफ के प्रति, सोसाइटी के प्रति, इन्वायरमेंट के प्रति, वो काफी चेंज हो गया है। पहले भी हम लोगों को चाहिए कि हम लोग सब के सब उस मूवमेंट को आगे बढ़ाएं, और हम लोग अपना सर्वाइवल, अपने आने वाले फ्यूचर जनरेशन के लिए भी अगर चाहते हैं वेलबीइंग, तो हम लोग को उस मूवमेंट को अपने अपने स्तर से, कोई जरूरी नहीं कि उन्हीं के मूवमेंट में जुड़ जाए, हर जगह जहां है वहां है कि सो हम लोग अपने आप को ऐसा करें कि इन्वायरमेंट को डैमेज हम नहीं कर सके। ये मेरा
इन्वायरमेंट तो एक चीज
एक तो है ही
है, बाकी सोसाइटी में जहां जहां भी हम लोग को गड़बड़ी दिखलाई दे रहा है, ऑब्वियस दिखलाई दे रहा है। हम लोग भिन्न भिन्न राजनीतिक कारणों से उसको नहीं बोलते हैं कि भाई मेरा ये चैम्बर है, इलाज से रिलेटेड है, पॉलिटिक्स का अखाड़ा नहीं है, लेकिन हम लोग को बोलना चाहिए। जैसे पॉपुलेशन कंट्रोल, को हम लोग बोलना चाहिए कि इसमें हर तरह से तुम्हारा फायदा है, सिर्फ देश के ही फायदे के लिए नहीं है। तो सोसाइटी और समाज में जहां भी कोई चीज गड़बड़ी दिखलाई दे रहा है, वो भी हम लोग के काम का एक हिस्सा है, क्योंकि आपका बात लोग सुनता है, आपका बात लोग समझता है और उसको फॉलो करता है। तो अब 5 आदमी को स्टॉप स्मोकिंग बोलते हैं, तो उसमें हो सकता है 4 नहीं छोड़े, 1 तो छोड़ेगा। तो इसलिए स्टॉप स्मोकिंग बोलने से कोई फायदा नहीं है, कैसे कर सकते हैं? 1 आदमी छोड़ा ना,
नहीं फायदा तो है ही। तो मैं यही कह रहा हूँ कि इस तरह के इन्वायरमेंट जो है, इन्वायरमेंट में चेंज हो, सोसाइटी में चेंज हो। सर जैसा बोले, प्रोफेसर बीबी ठाकुर सर हमेशा बोलते हैं कि पेशेंट के साथ साथ हम उनके अटेंडेंट का भी एक क्लास लेते हैं, उनको भी एक एजुकेट करते हैं कि लाइफ स्टाइल कैसा हो जिससे कि तुम्हारा फ्यूचर बेहतर हो सके। हम लोग इसको अडॉप्ट कर सकते हैं। सर तो हमेशा हम लोग
आपके पास टाइम कहाँ है सर?
नहीं सर, टाइम है सर।
कल एक डॉक्टर साहब से हमने पूछा कि यार आज के डेट में कै गो मरीज देखते हो? डॉक्टर साहब बहुत ब्लड प्रेशर से ग्रसित है, तो सर कहाँ देखते हैं सर? सुबह में 30 और दोपहर में 20।
वो जो भी हो सर, मैं आपके इंटरेक्शन के बाद मैं सर टाइम देता हूँ पेशेंट को जितना हो सकता है, और शायद मैं बहुत इतना ज्यादा है कि तो नंबर ऑफ पेशेंट भी नहीं
बॉस,
देखता।
आपने बड़ी अच्छी बात कही, और मैं एक चीज गुजारिश करूंगा कि अगला साल जो मुजफ्फरपुर में मीटिंग होगी,
जी,
और वैसे भी हम सोचे हैं कि 15 दिन बाद मुजफ्फरपुर वालों को अपना बुलाएंगे, तो आप को भेज है। आइए सर, so now let's close, everybody is tired, so राजीव आप कुछ बोलोगे तो बोल दो, राजीव रंजन आई मीन
सर। बस धन्यवाद दूंगा आप सब लोगों का और आप लोगों के सपोर्ट के लिए। हम लोग फिर चाहेंगे कि ऐसे ही होते रहे, छपरा में ऐसे एकेडमिक प्रोग्राम होते रहे।
एक होम मैसेज राजीव जी मैंने हम लिए हैं, पता नहीं आप लिए हैं। हम लोग
वैलिडिटी सेशन में एक परंपरा है सर, उसका पालन नहीं हो रहा है।
क्या सर?
बोला जाए परंपरा क्या करना है, क्या पूरा करना है।
परंपरा हम लोग यही देखते हैं सर कि जो स्टेट जो होता है, जो स्टेट जिसका कॉन्फ्रेंस कराया जाता है, तो ऑर्गेनाइजिंग कमेटी को उसके द्वारा कुछ दिया जाता है, दक्षिणा होता है ना, जैसे पंडित जी का।
यहाँ रिवर्स है सर, यहाँ रिवर्स है। सेंट्रल एपीआई का बिहार एपीआई के चैप्टर को कुछ है किसी ऑर्गेनाइजिंग कमेटी को देना होता है।
बिहार को चाहिए, बिहार चैप्टर को कि छपरा ऑर्गेनाइजिंग कमेटी को कुछ दे।
नहीं, जस्ट रिवर्स होगा सर। बिहार चैप्टर को ऑर्गेनाइजिंग कमेटी देगा। जी सर,
बिहार से भिजवा दीजिए।
भिजवाना नहीं है सर, जस्ट रिवर्स है सर। जो परंपरा, मैं भी सेक्रेटरी रहा हूँ काफी दिन तक बिहार चैप्टर का, और ये परंपरा है सर कि जो ब्रांच कराता है, जो ऑर्गेनाइजिंग कमेटी होती है, वो चैप्टर को कुछ कंट्रीब्यूट करता है। ये पहले से परंपरा है सर।
वैलिडिटी सेशन का ये मतलब ये होता है
सर, उल्टा होता है सर,
जो देगा
उल्टा होता है सर। और एक बात और
काट रहे हैं
सर, एक बात और, जो सर बोले कि अंबिका भवानी का दर्शन होना चाहिए, तो हम लोग एक जो अगर भगवान के दया से अगर सब कुछ ठीक हो जाता है, तो एक सीएमई कैलेंडर जी, एक सीएमई हम लोग छपरा में करेंगे, और उसमें हम लोग माता का दर्शन करेंगे।
तो आप लोग जरूर भिजवाइए,
इनका भोज करेंगे जरूर।
रहेगा
उल्टा है सर, हम तो बोल रहे हैं उल्टा है सर। जब पहले ही बोल दिए कि आप लड़की वाले हो, तो आप न देंगे सर। हमेशा है कि सर ब्रांच को मिलता है उल्टा, जो ऑर्गेनाइजिंग टीम होती है वो देता है। कैसा नहीं करनी नहीं चाहते। गार्जियन है, बीबी ठाकुर सर बैठे हुए हैं, गार्जियन बीबी ठाकुर सर बैठे हुए हैं।
एपीआई में क्या है ना, एपीआई में by virtue of being a member in the central API, you necessarily become a member of the state API. And state API के रन करने में पैसे खर्च होते हैं। तो अभी तक का सिस्टम यही रहा है, अराउंड 50,000 ऑर्गेनाइजिंग कमिटी देती है, और सेंट्रल एपीआई में भी यही है कि जो एपिकॉन करते हैं वो पैसे देते हैं, नॉट द रिवर्स। और हम लोग आपको इतना प्रोफ्यूजली जो थैंक्स दिए, जो कंग्रेचुलेशन दिए, जो ब्लेसिंग्स दिए, और अति प्रसन्न हो करके जा रहे हैं, क्या कम है बताइए?
भूखे भजन न होई गोपाला।
राजीव जी, एक रिक्वेस्ट रहेगा मेरा फिर से, है ना? जी मेडिसिन अपडेट जो प्रिंट कराए हैं, हम लोग को भेज दीजिए।
राजीव बड़ी अच्छी बात बोला है कि भूखे भजन न हो ही गोपाला। तो भाई साहब, हमको ना भूखा रखे हो।
आप तो हमको आपको आके बुलाया सर, सब खाना हम लोग का बर्बाद हो गया है।
सर, हम लोगों को जो लोग थे यहाँ पर कुरियर से भेज सकते थे, जोमेटो से।
सीरियसली मत लीजिएगा, कोई
बात नहीं हो रहा है। राजीव जी, हेलो राजीव जी, जो
yes,
आपने
sir.
रिक्वेस्ट किया है उनको हम लोग को भेज दीजिएगा।
ठीक है सर, बिल्कुल।
मेडिसिन अपडेट
विद इन 1 वीक चला जाएगा सर।
और सभी लोगों को भी नमस्ते, जय हिंद।
जय हिंद, प्रणाम। अंत में एक मिनट
प्रणाम।
अंतिम में क्या राष्ट्र गान होना चाहिए आज के दिन की नहीं अभी? क्या शैलेंद्र जी, चेयरमैन?
तो पंडित जी गलत करते हैं, एकदम होना चाहिए।
बिल्कुल होना चाहिए सर, आज के दिन तो जरूर होना चाहिए, नो प्रॉब्लम।
ऐसे भी हम लोग के ट्रेंड में तो होता ही है प्रोग्राम।
जी जी।
राजीव जी,
यस
लॉन्ग लिव बेतियाई।
जय हिंद,
जय हिंद,
भारत माता की जय, मातरम।
माँ की जय। नमस्कार, नमस्कार।
शुभ रात्रि, शुभ रात्रि, नमस्कार, फिर मिलेंगे।
हाँ तो